A very good morning to all. We will be starting the session in 10 minutes. I request all your colleagues to join, if not joined yet. Thank you. A very good morning to all. A very good morning, everyone. I'm Dr. Chaitali Bhatt, and it is truly my honor to serve as an host for today's conference. I extend warm and heartfelt welcome to all our distinguished speakers, respected judges, and esteemed medical delegates joining us from all over the country. It gives me immense pleasure to welcome you all on the 11th online webinar conference on good clinical laboratory practice. This event is organized by Narendra Modi Medical College, LG Hospital, Maninagar, Ahmedabad, in association with Association of Physiologists and Pharmacologists of India, APPI Gujarat State Chapter, and the Fraternity of National Research and Publication Society of Medical Sciences Forum. To mark the auspicious beginning of today's webinar, we will now commence with a deep Pragatya ceremony virtually, followed by a soulful Saraswati Vanna. Please enjoy the video presentation.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा.
Okay, now we would like to take a moment to express our sincere gratitude to Dr. Dipti Shah ma'am, the Honorable Dean of Narendra Modi Medical College, for her unwavering support and visionary leadership. Though she is unable to be present with us today due to her prior commitments, she has conveyed her blessings and best wishes, which we deeply value. I would like to also extend a special note of thanks to our esteemed association partners APPI Gujarat State Chapter and Forum for their constant collaboration and support in making this event possible. I am honored to welcome Dr. Saumil Merchant Sir, organizing chairperson of this conference and head of the forensic medicine at Narendra Modi Medical College. He's also the in charge of GCP, GCLP and the Institutional Ethical Committee at this institution. I would also welcome Dr. Pooja Dullo ma'am. She is the president of APPI Gujarat State Chapter. Dr. Janardhan Bhatt as organizing secretary of APPI Gujarat State Branch. And Dr. Urvesh Shah, respected GMC observer for today's session. Thank you so much for your valuable time and consistent support. I now request Dr. Saumil Merchant sir to kindly share a few words as a part of welcome note. Sir, you are not audible. Just a minute.
May I audible?
Yes, sir, you're audible.
Thank you very much, Chetaji. Good morning and healthy morning to everybody who are speaker and participants in this 11th webinar. Behalf of Narendra Modi Medical College, being the chairman of this 11th webinar, me, Dr. Saumil Merchant, invite to all of you in this webinar. First of all, I will congratulations to the Dr. Janardhan Bhatt and his team to organize this type of webinar on a topic, on a very sensitive topic, just like a clinical laboratory, how to practice ethically and legally. Really, it will be helpful to the participant for his or her knowledge to increase regarding these topics. Now, I will start my lectures if you share my screen side.
Sir, I will take a few minutes from you.
Yes.
To all our participating delegates, thank you for making time to be with us today. Your dedication to professional growth is what makes such initiative truly a meaningful time. As Sir has already said that it is a sensitive topic on good clinical laboratory practice, which is not only implying to the pathology laboratory, but all the fraternities which is actually dealing with the laboratory parts. Today, I assure you that all the important sensitive topics will be covered in Good Clinical Laboratory Practice webinar conference, which shows us to follow certain SOPs and standardized protocols, which should be reliable, ethical, and which helps the society to conduct a scientific or provide a scientific integrity. So moving ahead with our first session of Dr. Saumil Merchant sir, he's a distinguished academic and administrator, who is currently serving as a professor and head of forensic medicine and toxicology at Narendra Modi Medical College and LG Hospital. His academic credentials are impressive, holding an MD and PhD in forensic medicine, as well as LLB and LLM degrees, reflecting his deep integration of legal and medical expertise. He is also an in charge of GCP, GCLP, and the Institutional Ethical Committee. At his institution, has previously served as a vice president of the Ahmedabad Medical Association 2015 and 16. Today, he will share his insight on the topic of critical importance on ethical consideration in laboratory practice. I'm truly honored to welcome you. I'm sharing my screen for you. Is it visible, sir?
Yes.
Shall I start, sir?
Yes. Next. Now, my topic is very sensitive regarding the laboratory practice. It is ethical and legal. Now, first of all, what is NABL? The Standard of National Accreditation Board for the Testing and Calibration Laboratory. It is the autonomous body under the Quality Council of the India. It is called a QCI, which provide accreditations to the laboratory in India based on international standards like SOI, IOS, IEC 17025 for the testing and calibrations lab, and ISO 15189 for the medical laboratories. Next. Now, why NABL accreditation important for the medical laboratory or a pathological laboratory? It assures the patient and doctor to accurate the reliable test result. Assure the quality management and competitions in the medical lab testing. That's why it is most important. Next. The role and regulation of the laboratory, especially in the contents of the scientific, medical, industrial labs, can vary depend upon the type of the laboratory and jurisdictions in which it operates. However, there are general rules and regulations that are commonly across most of the lab. Next. Now, for the sample collection, what you have to take precautions. The laboratory staff must treat all the patients equally. No specific preference is given to the patient based on their acquisitions among the staff, their class and caste. That is the most important. Informed consent is taken from all the patient before sample collections. Explaining the reason for performing the required test in the legal, whatever is his or her understand the language that he or she understand. Information only relevant to the patient in investigation is collected. No other personal details are collected. The information received from each patient is confidential, and patients should be aware of the reason for providing these informations. Next. Now, performing test from the laboratory. The test will be performed as the established standard protocol, SBNABI, derived from the standard national and international guidelines. The procedure for in-house testing must be standardized and validated. The standard protocol must include in all the documents related to the standardizations. Next. Now, storage samples in a laboratory. Collect and storage of the human biology material like a urine, tissue, the body fluid, urine have become the integral to the disease diagnosis and human research. Laboratory medical practitioner to retentions of a diagnostic sample for testing and retesting as per the integrity and stability of the samples may be varies and the resources for the research by the community. Next. The store sample should not be used for performing test other than for which informed consent has been taken for the patient. That is the most important. The samples may be stored for retesting in case of any fallacious result. If the stored sample has to be used to performing the some higher test in the interest of the patient care, the patient must be informed regarding the test. Next. Now, consciousness of the laboratory staff regarding the laboratory staff. The laboratory staff must be evaluate his or her conduct and maintain the professional integrity. That is the main thing. The staff must take great care of performing this test procedure and recording the results. Patient sample must be carefully stored by the staff. No fabrication of the sample to be tested or the results should be done. A great care has to be taken in a designing test task to the staff, keeping in mind the importance of each patient samples. No financial or personal interest should be suppress the patient interest. Next. Next. Now, role of the laboratory. Role of the laboratory: research, development, testing and analysis, educating and training, and innovations. Now, research and development. Labs have a space for the research in various fields such as the chemistry, biology, physics, medicine, engineering, etc. They are the crucial for the laboratory to new material, technology, and machines and solution to the social challenges. Testing and analysis. The laboratory often provide testing and analysis services such as the quality control in industry, environmental testing like air pollution, water pollutions, forensic analysis, and medical diagnosis. Now, educating and training. The lab also serve the educational function, providing hand-on training for the student and a professional in different scientific disciplines. They are space where the theoretical knowledge is to put into the practical knowledge. Now, innovations. Laboratories derive the innovations by experimenting with the new ideas, materials, and technology. They are often birthplace of the breakthrough, the discovery and technological advancement. Next. Now, regulation for the laboratory. Laboratory regulations are designed to ensure the safety of the workers, integrated to the work being done, and protect of the environment. These regulations are enforced by the government agency, not by the ours. International body or a specific industry standard. Some key regulations, including the safety regulation, first of all. Occupational health and safety. It is called as OHS. Most countries have OHS regulation which mandatory safety protocol for the laboratory workers, including the use of the personal protection equipment. It is called as PPE, proper ventilations and safe handling and disposal of the hazardous material. Next. Now, waste management. Number two, laboratory generate waste that can be hazard such as the chemical waste, biological waste, or medical waste. Regulating typically requires that such waste to be segregated, labeled, disposed through the licensed waste disposable services. Now, in air and water quality, laboratory must ensure that their operations do not pollute the air as well as the water supply. For example, emissions of such chemical process may need to be controlled, and laboratory discharge like a chemical influence must be treated before being released. Next. Number three, accreditation standards. That is the main importance. ISO standards. In ISO standard, many laboratories, especially those in the clinical and research field, need to comply with the specific international accreditation standardizations. For the example, ISO 17025 specifically requirement for the laboratory competent and quality in testing and calibrating the laboratory. Next, good laboratory practice, it is called as GPL, GLP. This set to principles that ensure that the laboratory research is conducted in a consistent quality control manner. GLP is often used in a clinical and as well as in a pharmacological researches. Next. Now, main importance in ethical regulations, human animal research and confidentiality. In human animals, laboratory involved in a research with a human and animal are subject to ethical guideline and regulating approval process. Institutional Review Board, it is called IRB for the human research or IACUCS for the animal research. Now, in a confidentiality, laboratory working with the sensitive data, patient informations or the priority of the researches. Most adherent to the privacy law such as the HIPAA in the USA for the medical data. Next. Now, fifth is chemical and biological safety. Chemical hygiene plants. In USA, the Occupational Safety and Health Administration, it is called OHSA as a standard for the chemical safety in the laboratory, which meditate this creation of chemical hygiene plan to ensure the safety of handling the chemicals. Biosafety. Laboratory that work with a biohazard material, just like viruses and bacteria, must be adherent to the biosafety protocol that varying by the risk level. Biosafety level 1 and 4 is specific for the Center for the Disease Control and the Preventions. It is called as CDC and in the World Organizations WHO. Next. Now, Quality control regulations. The laboratory, particularly those in the medical and industrial setting, must maintain a high standard of quality control. They are often subject to inspection and audit to ensure their operation meet required standard. Medical diagnosis lab must comply with the CLIA with the Clinical Laboratory Improvement Amendment in the USA. Laboratory equipment and maintenance. The laboratory are required to maintain the equipment to ensure it operates with a specific safety and performance standard. The regular calibrations and maintenance procedure are mandatory in many settings in calibrations of the pipetting and microscopes. Next. Now, key regulating bodies. It is called as OSSA, Occupational Safety and Health Administrations, regulating the worker safety in the USA. CDS, Center for Disease Control and Prevention, regulatory laboratory practice, especially in a clinical and biosafety setting. Then EPA, Environmental Protocol Agencies, oversees environmental regulations related to laboratory waste disposal and emissions. FDA, Food and Drug Administrations, regulated labs involved in the medical and pharmaceutical researches. Then ISO, International Organization for the Standardizations, provided international standard including for the laboratory ISO 17025 for testing and calibrations. Then National Institute of the Health, it is called as NIH, providing the guideline for the laboratory involved in biomedical research, including the ethical guideline for the animal as well as the human studies. Next. Now, documentation and recording keeping. The proper documentation for the experiment and testing and result in a critical for the accommodation and competence. This is the main importance for the legal point of view. This includes keeping the accurate record for the procedure, raw data, and final result. Some regulation mandate the retention of this record for the period. FDA regulation for the medical and pharmaceutical laboratory. Next. Now, what are the research ethics in a laboratory? Patient sample being used for the research in one of the research related ethically, especially when they dealing with the vulnerable group like children, pregnant women, old age people, destitutes, and the people with a neurological disorder. Some samples should be used by the research without taking informed consent from the patient. The researcher should no sample should be used for the research without taking informed consent. The researcher should be honestly report the data, material, and method used in the laboratory without the fabricating of any report. That is the main thing. It is a responsibility of the researcher to maintain the confidentiality of the patient's information obtained for the purpose of the researches. It is the most important for the legal as well as ethical point of view. Next. Now, most important, malpractice. The laboratory should have transparency policy indicating the reason for performing the concerned test. Unnecessary testing has to be avoided. Next. Now, step for implementation of ethical practice in laboratory. Standardization all the procedure. Safe environment including the proper wiring and maintenance for all the electrical appliances as well as the diagnostic equipment. Check. Ensuring the safety of laboratory staff for the healthcare result by the administrations. Automations including barcoding that decrease the manual error. Different tiers of checking monitoring system to detect the error timely. Next. Repeat the training of the laboratory staff. Standard workflow of the laboratory, fixed protocol to work in a different section of the laboratory with the display of all instructions. Accountability of this technical staff and reporting doctor for the safe and lawful practices. Elevating of the discrediting element like the mobile phones to avoid the negligence by the laboratory staff. Next. Now, the laboratory standard consists of the five major elements. Hazard identification, first of all. Number two is chemical hygiene plan. Number 3 is information and training. Number 4 is exposure monitoring. And number 5 is medical consultations and examinations. Next. Now, core principles of ethical laboratory practice. First of all, honesty and integrity. Report data trustfully, no fabrication, no falsifications, and misrepresentations. Give a proper credit for the ideas, methods, and contributions. That is the main thing. Accuracy and precision. Following protocols and procedure, be carefully. Maintain clear, complete, and accurate lab record, lab notebooks, and logbooks. Safety and responsibility. Follow the safety guideline and wear the appropriate PPE during the working hours. Properly dispose of chemical, biomedical, medical hazard or waste. Maintain the clean and organized workplace. Next, respect for the life. Treat lab animal humanity following the animals ethical guidelines. Third, replacement reductions and replacements. Obtain informed consent for the human subject researches. Most important is confidentiality from the laboratory staff. Keep the sensitive data secure and respect the participant privacy. Then accountability. Take responsibility for your work and actions. Be open to peer review and criticism. Environmental responsibility. Minimize environmental impact by reducing the waste during sustainable practice and handling hazard materials carefully. Next. Now, business registration license. These are the different things you have to take if you open the new laboratory. Business register certificates from the local municipal or government authority. That is the main thing. Trade license to legally operate a business in your areas. PAN, TIN number, waste number, GST number or certificates depending on your country of the test systems. Health and safety approval. Biomedical waste management authorizations for your environmental or population control boards. Next. The health department approval. That is the main thing. Clearance from the local and state health departments. Nowadays, fire safety is mandatory. The fire safety certificate is mandatory in all the laboratory from the fire department if applicable. The lab accreditations and quality compliances. NABL accreditations, clear certifications for a quality assurance and lab testing standardization. ISO certificates, just like ISO 15189 for the medical lab of operational but beneficial to the creditability. Next. Now, personal and qualifications. Qualification documents of the lab director and the technicians, degree, license, and resistance. We have to check. Medical council registration for pathologicals or a lab director where they require. And other operational approval. Equipment calibrations certificates. Standard operative procedure SOP is required for the laboratory. Next. Now, data protection and patient privacy policy. In line with the HIPAA in USA or similar regulations is here as insurance and liability coverage of the patient if required. Professional liability insurance if required. The price and property insurance if required. Next. So these are the basically ethical and medical point of view how to practice legally in a laboratory practice. Thank you very much. Thanks.
Thank you so much, sir, for enlightening session on ethical consideration in good clinical laboratory practice. Uh, this was a highlighted part on the foundational role of ethics in maintaining the integrity reliability and quality of lab practices, and also the research. And this insight was certainly from emphasizing on not only the laboratory parts, the technical parts, also the regulatory parts, SOPs, and also the moral roles, what to be followed. And thank you so much on the behalf of organizing team for uh, being with us and enlightening us with on this very important topic.
Thank you, Tetadi.
Thank you so much, sir.
Good morning, everyone.
A very good morning, ma'am. So now moving ahead, I am very pleasure to invite Dr. Gunwanti Rathod, ma'am, who is an academician and pathologist. Uh, and I welcome you on the virtual platform. She is currently serving as an additional professor at AIMS, Bibinagar, Hyderabad. She holds an MBBS and MD in pathology degree from Gujarat University and has also earned the prestigious Famer Fellowship from GSMC KEMH Mumbai. She's highlighting her commitment to advancing medical education and research with a rich academic journey spanning over 15 years. She has held key teaching positions at various reputed universities, including Gujarat University, Sri Balaji Vidyapit, Sumandip Vidyapit, Hemchandracharya North Gujarat University, and Veer Narmad South Gujarat University. Her academic contributions are remarkable, with over 100 publications, participations in more of and dozens of workshops, CMEs and conferences, and editorial roles with international journals such as Progressive Academic Publishing UK and Landmark Research Journals. She is also a life member of several esteemed professional bodies, including the Indian Medical Association and the Gujarat Association of Pathologists and Microbiologists. Notably, she has guided multiple Evigenship projects and has been awarded the Most Favorable Participant Award at the 6th Regional Course on Good Clinical Laboratory Practice held in Bhutan. Dr. Rathod has undergone extensive training in NABL standards, Good Clinical Laboratory Practice, evidence-based education systems, and medical education technologies. She has also served as a member of Adverse Event Following Immunization Committee of Gujarat State. Today, she will be enlightening us on the topic of introduction and scope of good clinical laboratory practice as an essential foundation for ensuring quality, integrity, and regulatory compliance in clinical laboratories. I'm honored to have you with us today and looking forward to your enlightening, insightful session.
Thank you
Over
so
to
much,
you, ma'am.
Dr. Chaitali, for introducing me. Can I share my PPT or you will share from your end? You please share from your end, no problem.
I have made you presenter.
Okay. You can share from your side. I think from my side there is some technical glitch.
Okay, ma'am, just a minute. I'm sharing the screen.
Okay.
Can you see?
Yes. Thank you so much. First of all, I would like to thank Dr. Janardhan Bhatt sir and Sri Narendra Modi Medical College for giving me this wonderful opportunity to speak about the good clinical laboratory practice. Being a pathologist, it's my favorite topic. So without wasting time, we should move forward. Next slide, please. So today, the learning objective of this talk will be definition of GCLP, that is good clinical laboratory practice, and the scope of applicability, where we can apply the GCLP. Along with that, we can also discuss the recognition for available standards for the laboratory as well as specifically the need of GCLP, why it is needed. Next, please. So first of all, direct we can go to the GCLP, but before that, I would like to just talk about the role of medical laboratory in our day to day practice. For a clinician, depending solely on the clinical sign and symptom for the diagnosis can be unreliable. It will be non specific also and inaccurate, which affect patients' health directly. If we will take any example, that almost half of the 4,600 patients in a study in Tanzania, they admitted with a clinical diagnosis of malaria and they are not having a positive blood smear. Same, the clinical symptom and sign of visceral leishmaniasis, they overlap those of the malaria and typhoid. So the clinical diagnosis doesn't make that, okay, this is the only final and we can start the treatment. Role of medical laboratory is so much essential before starting the treatment. Next, please. So, what is the need for medical laboratory in our day to day practice? It is required for the diagnosis, management, and monitoring of the disease. It is also important for screening of early disease diagnosis. Also, it helps for the diagnosis of disease in an epidemic or pandemic setting. It is also important for surveillance of infectious disease like polio and measles. In context of research clinical trial, there is definitely use of medical laboratory and it also help to generate the trained workforce. Next, please. So now what happens when the laboratory data is not trustworthy? If the lab is not releasing a quality reports or the data which is not trustworthy, what will happen in our society? The first and foremost, as we are related to the day-to-day clinical practice, inappropriate diagnosis and the treatment of the patient, which leads to increased morbidity and mortality. It will also create inability to determine the true prevalence in the society and unnecessary expenditure in the region which already plagued with the shortage. It will also affect the untold misery in human lives and suffering. Next, please. So, what is the basic need in our day-to-day practice? Each and every clinicians they always want quality result from the laboratory. Now, what is quality result? To understand that terminology, we have to first learn about quality. So, first we will learn what is quality. Next, please. So, quality, how we can define it? In science, the quality is conformance to the standards, that ability to satisfy the stated or implied needs. Please remember, ability to satisfy the stated or implied needs. And in research, if we will define the quality, that it is conformance to the ethical and scientific standards. But in layman term or in philosophy, if we want to say what is quality, that quality is happiness. You are happy with the whatever need was satisfied. Next, please. So we are moving to the different types of laboratory because quality results they are produced from the laboratory and particularly the lab. It is which type? First is diagnostic laboratory which cater to the individual patient's need. A small lab with a small setup, they are releasing the reports. The second category will be public health laboratory which caters to the population need. They may lead to public health response. like in general hospital, where the patient's workload is more and they are catering to the mass of a patient. Third category is research laboratory, which caters not only to the current participant, but the decision of the research laboratory, they are also useful for the future. Next, please. So here we can see the types of laboratory. Here, this one, it is the individual lab, and this one is the public health laboratory, and third one is the research laboratory, which results we can use in the future also. Next, please. So different type of laboratory will have different type of workload. So either the lab will be public or it will be a private. Either it will be independent or a part of a big hospital also or the clinic. Now regarding the workload, what is the volume of the samples? Either the lab is using manual method or automated system. All these things will directly affect to the result of the patients. So different level of the healthcare facility and laboratories. From elementary to the sophisticated laboratories, here one question will be there that is common, that either one standard is applicable for all situations. The answer is no. We can't apply a one standard for all the situations. Next, please. So, what are the issues with the laboratories, with the workload, and with the methods? The first thing, national policy. National policies are there, but in our country, they are not in existence. The second thing, it is about guideline and standards. There is no uniform guideline or standard for the whole country, so it is not existent. If it is there, like NABL, they are not enforcement in many areas. We can't apply NABL to each and because of the inadequate resources and the training opportunities are not available. Each and every person in the lab, they must have proper training if we want to apply NABL standards in each and every lab. Third thing, it is about clinical lab accreditation or certification. It is not legally required in our country. If we will compare to the US or any other abroad countries, they are having rules and regulations and they are legally bound that they need first lab accreditation and then they can release any patient's report. So these are the issues which are at present in our country affecting the quality results. Next, please. There are many international standards. I think all of you are aware about it. In our country also, NABL is there, that is for the laboratory, that is ISO 15189. But either we should follow them or not. What are the requirement? How much they are important for us? So all these things we will discuss one by one. Next, please. We can see in the picture a small lab which is situated in a peripheral area. So here, if we want to apply NABL, that is ISO 15189 or any other international standard, it is not possible at all. Why? Because all these things, they are very much resource demanding and they are not suited for every level of laboratory in the developing countries. So what to do? That is the only answer for the GCLP. Next, please. We should start to set our own standard. Essential standards need to be set according to your own lab, which should be followed and controlled. If I would like to give one example, that in your own organization, how clean your lab must be. So here you can see in one picture that the cleanliness of the lab, if you will have your own criteria that this must be the criteria for the cleanliness of lab, this will be the picture which will be according to the GCLP guidelines. Next, please. Another example is how safe is your waste disposal. From the laboratory, whatever the waste is created, either we are throwing like that only or we are doing proper waste disposal like burial or incineration. So minimum critical standards are required if we want to follow a GCLP guidelines. Next, please. So now we will come to what is GCLP. GCLP, that is good clinical laboratory practice. It's a set of standard to be satisfied to ensure that pre-analytical, analytical and post-analytical process, they are reliable. We can rely on all the process. The second thing, it is data or result generated, they are accurate Repeatable, that means we can compare, and auditable, that means all the results will be traceable. Another thing, that laboratory generated data, they comply with GCP and other regulatory requirements. Next, please. So here we can see what is the meaning of analytical, pre-analytical and post-analytical. Pre-analytical, that means when the patient is coming for the collection of the sample, or we can say collection of the particular taste sample, what are the parameters that we have to take care? So first is the sample collection. Second, whenever we are transferring that taste sample to the aliquot, and proper labeling. Third is about sample receipt and accessorship. And fourth, if there is need of transferring that particular sample to another place, suppose the facility is available for the kidney transplant patient, to report the kidney biopsy or renal biopsy, we have to give the sample to the another lab which is far away for the reporting, so that the patient's well-being will be checked. So sample transport, again, all this area, all these pre-analytical steps, they are having their own guideline, how to do, what to do, and what are the steps to be maintained. In the analytical area, the test performance, either the machine is fully automated, or they are following the manual method, or it is semi-automated, and what are the test methods they are following, that part will be covered in analytical. We will move to the post analytical part, which is related to the reporting of the test result, how they are reporting, which guideline they are using, and record keeping, either they are keeping the record of the released reports or not, that is also very much important. So here is the general overview of pre-analytical, analytical and post analytical procedures. In GCLP we have to take care about all the three aspects, then and then we can release the quality reports. Next, please. So here the question will come, either we need GCLP or whatever is going on is okay. So here is the answer. Next, please. That GCLP is required to ensure reliability, integrity, and quality of laboratory data, which is used in patient care as well as in clinical trials. Here we are also talking about the research laboratory along with the individual lab as well as the public health lab. It bridges the principle of good laboratory practice and good clinical practice to ensure that laboratory process and the results, they meet regulatory standards for the patient care as well as for the clinical research. So here we can say it's a term, GCLP, which bridges the two things together, good laboratory practice as well as good clinical practice. Next, please. So why it is important? For the data integrity and reliability. Whatever the data we are generating, that means whatever the result we are producing in the lab, that must be integrate as well as reliable. So it ensures that laboratory data is accurate, reproducible and trustworthy. Regarding patient safety, if we would like to say, it minimizes the risk of ensuring proper sample handling, testing accuracy and adherence to the protocol. We can also standardize the process so that from one lab to another lab, if we are moving, the result won't affect. So it helps maintain consistency across different laboratories conducting the analysis. And regarding audit, if there is any audit, then the readiness for the audit will be provided via the GCLP principles only. So it facilitates easier regulatory inspection by providing the clear documentation and adherence to the best practice. Next, please. So where we can apply GCLP, or where is the GCLP applicable? It can be applicable to the all hospital, research lab, clinical lab that provides laboratory support for the patient or participants which are involved in research. So in applying GCLP, it does not matter that how complex the lab environment is. The principle will remain same. Here one thing we have to just mug up, that the principle for GCLP will be same. Either the lab is small, large, it caters a mass of the patient or individual patient. simple point of care test for rapid diagnostic test, or more complex testing like pharmacokinetic in the drug trial, so that it won't affect anything, but the principles they are same for the GCLP. Next please. So now which are the principle of the GCLP? First, it will be regarding organization. Second, personnel, that means who are working in the lab, starting from a attendant, technician, all the faculty members who are present in the lab, they all will come under personnel. Regarding equipment, that means which are the instruments they are used in the particular lab, either they are manual method, fully automated equipment, or they are semi automated. Another thing about information management and purchasing and inventory, that is the most important part. Again, quality control and quality assurance. These are the two important things which will affect directly to the report or the clinical trial results. Assessment, which is external as well as internal, that means internal quality control as well as external quality control. What are the results that we have to assess, and based on this result we have to start process for the improvement. If the results they are not showing proper results, then we have to take the corrective measures, and the corrective measures we have to start to improve. Either the results are wrong, then we have to change the method, or we have to change the process or equipment. Document and records, definitely each and everything must be documented, and we have to record each and everything, that either any untoward incidents or anything, we have to have record of all that data, so that the audit process will be smooth and we can release the quality reports for the patient. Facility and safety also it matters. If we are working in a particular laboratory, then which are the facilities to be made for each and everyone, and the environment must be safe enough to work. Next please. So now we will talk about each and every principle of GCLP into the detail. The first is test facility organization and personnel. And what are their responsibilities? A good laboratory must be well designed to support safe, efficient, and high quality work. It should have designated space for the following key areas which are related to the testing. First, sample collection and reception area. Second, sample processing area. Please remember all these things they must have designated space. That means different space. Not in one place we can do each and everything. That wherever we have collected the sample, the instrument is also there, and we can run the sample and we can release the result. It should not be there at all. So a designated space will be for the sample collection and reception area, sample processing area, analytical or testing area, data entry and reporting area. Next, please. A specific space should be allotted for the reagent and chemical storage. Glassware and equipment washing area, another thing will be there. Now, waste disposal area must be designated because it's a very sensitive issue. Otherwise, the biomedical hazard will be happening. Safety and emergency station must be there. If there is any untoward incidents or someone is injured, then safety and emergency stations will cater them. And staff working area must be there. Next, please. Now we will move towards the important part, that is quality control and quality assurance. Now quality control and quality assurance, they are usually we are interrelated to each other. So routine check to ensure the quality and reliability of result or data. We can run the same sample twice and we can check that either our results they are reproducible or not, they are accurate or not. Independent quality assurance system for internal audit and compliance check we can do. Another thing, external quality assessment and proficiency testing we can ask for, by the which we can check that either what are the results we are releasing, they are perfect or not. Next please. The third is apparatus, material, and reagent. Now, apparatus of appropriate design and adequate capacity must be there. Suppose the workload of laboratory is much more, but the instrument is having capacity of 100 sample only, then it is not proper to run the sample in that particular instrument which is not having capacity beyond 100. It will not give the quality results at all. Documented inspection Documented inspection must be arranged at a regular interval so that we can have watch that either the instrument is working properly or not, the related results every day they are checking the quality or not. Instrument cleaning, that is AMC and CMC. Again, one important thing, it is about calibration of particular instrument. Each and every instrument must be calibrated and must be having calibration reports. Regarding apparatus and material, they should not interfere with the taste system. Chemical reagent and solutions, they must be labeled to indicate identity, that it is which chemical, either it is CuSO4 or whatever is there. The name must be properly labeled. The expiry and specific storage instructions, they must be written on each and every reagent. There is also one policy, that is FIFO. Now, what is FIFO? It is first in, first out. That means whichever reagent chemical you are keeping into the storage at first, that should be come out for the use at first only, so that we can avoid the expiry of particular chemical or reagent or the solution. Next, please. Now, regarding standard operating procedures, there will be a detailed lecture on this, but just I'll give overview on each and every topic. So, SOP, they are what are this SOP? That they are written procedure for a laboratory program. In one paper, the whole process will be written. They define how to carry out the protocol specified activities. Suppose it's a particular test, that it will define each and every step, how this process will happen and how to perform. Most often, it will be written in a chronological listing of action steps, and they are written to explain how the procedures are supposed to work. Next, please. Now, another important principle of GCLP is reporting of the results. So, complete information on test facility must be written in the report. That whatever that we are releasing the report, the whole information must be there. Sample receiving information, that at what time we have received the sample, it the sample was in which condition. Suppose we will talk about histopathology, either the sample was completely autolyzed, then we have to mention prior only that at the time of receiving the sample was autolyzed, so that it won't affect on the result, that in the result we are giving only autolytic tissue is seen. Then the clinicians, they will shout that why it is like that, we have given the enough adequate amount of proper sampling, though you are not releasing the report properly. So to avoid such circumstances, we should take care about all these GCLB principles in our day-to-day practice. So, sample receiving information. Third is test starting and completion date as well as time, where we have started the test starting and we have completed and we are releasing the report at this time and this date. Description of material and the test method. A quality assurance program statement must be there, and test value and the result along with the final report we have to release. Next, please. So here I would like to end my topic, that in summary I would like to say that GCLP gives better image of the laboratory as a quality procedure into day-to-day practice of the medicine. It provides tips on analysis of data as well as it measures uncertainty if we are talking about clinical research laboratory. It helps for the perfect record keeping and guideline for doing testing and measurement in detail. And finally, GCLP provides a guideline and better control for maintenance of the instrument which we are using in the laboratory, environment control and preservation of the test record. Next, please. So, what is the key message from this talk? That GCLP is standard set of principle to be applied for laboratories which are participating in patient care or human research. So compliance to the GCLP assures the process and data quality. It allows for the comparison of data, perform risk benefit analysis, and it release safe and effective reports, which is the need of our day to day practice. Next, please. So, GCLP, if we would like to say in one line, it is a set of local standards to produce quality reports. Suppose some labs they are not able to afford NABL or any other international standards, though they can release the quality reports by setting their own standards. That means local standards to produce the quality reports. If we will just say about our honorable respected Prime Minister Shri Narendra Modi, he also told that vocal for local. So in our lab also, if the NABL is not able to we can achieve, we can go for our own set of local standard and we can release the quality reports for the well-being of a patient. Next, please. So, implementing GCLP and ensuring quality, it's a journey. We can't achieve in a one day that we have learned and we can achieve the good quality reports. It's a journey that we have to start from today itself. That okay, we will start our own laboratory set of standards and we will follow them. Then and then we can achieve quality results. So the journey start today. So we have made the beginning. All the very best to all of you to produce the quality results. Thank you so much for giving me the opportunity.
Thank you so much, ma'am, for giving us a very brief, though too much of introduction and information about the foundational principles and the scope of real world applications in clinical and research laboratories. You said that at the end, the summary, the how, if we cannot, if the laboratories cannot afford the international standards, at least they can set their own local standards, SOPs, for working in a quality care in the patient or a healthcare. Thank you so much, ma'am, for sharing your knowledge with us.
Thank you so much for the opportunity.
Now, moving ahead with our next presenter, the next speaker. Am I audible, ma'am?
Yes, you are audible now.
Okay. Now I am proceeding ahead with a warm welcome to Dr. Usha Patel, ma'am, on a virtual dais. She has completed her MD in biochemistry and she is currently working as an assistant professor in Department of Biochemistry at Narendra Modi Medical College, Maninagar, Ahmedabad. She will be addressing on the important topic of a very important topic on the organization, which is ensuring for the success and integrity of the clinical trials. I welcome you, ma'am.
Thank you, Dr. K.V. Bursar and whole organizing team and Dr. Chaitali for giving me the opportunity to share my knowledge on this webinar. Should I start sharing my screen?
Yes, ma'am.
So thank you all. And recently, Dr. Gunavanti ma'am already elaborated very well nicely on good clinical laboratory practice. Still, I am going to speak on the organization and personal responsibility during the clinical trial. I am, why my slide is not moving? So actually, good clinical laboratory practice is a set of guidelines that ensure the quality, reliability, integrity of data generated by laboratories from the sample collection to the performing the complete clinical trials. So it actually combines all the principles of GLP, good laboratory and good clinical practice to ensure the compliance with the laboratory standards and clinical regulation. So main key principle of GCLP already narrated by the Dr. Gunwanti ma'am. It includes the ethical principle, respect to the person, beneficiary, and justice to the persons involved in the clinical trial. It involves the scientific principles, validity and reliability of the research. It also meets the regulatory requirement from the regulatory bodies, international and national. It involves, so these all things should be concluded very well with the assigning the proper roles and responsibility of all the trials staff, response sponsor, and ethical committee. So we have given the certain proper duties to the uh, persons who are involving all in clinical trial, mainly principal investigator, sub-investigator, clinical research coordinator, clinical research associate, data managers. They are involved in data collection, data analysis. Others who are involved in performing the task like laboratory staff, X-ray technician, pharmacist. So these are all mainly principal investigator and others are on, having the basic responsibility to protocol adherence, obtain informed consent with the confidentiality of the patient. They have to manage the safety and right of the patient throughout the trial, as well as they try to monitor the data. Whatever data is collected should be confidential and properly analyzed without any bias of sponsor and meet all the compliance with from the regulatory requirement. And during the trial procedure, they have to undergo the training himself as well as train their staff also and monitor the whole the trial throughout the completion. And they manage how the trial material should be utilized, managed, properly allocate to all the members, communication with the other committee member, and whatever update is coming in the form of adverse event or anything, they have to advise, inform to the sponsors as well as the regulatory committee. So to establish the organization responsibility, the facility, they have to prepare certain teamwork, facility management team, procurement department, logistics staff. So they can be easily important for the how they are going to order that particular specific instrument, which are the tools required for that trial, different type of materials, reagents, they are required for the completion of the. So this is should be cost effective and should be in the quality for the sustainable completion. Whatever material is coming, their organization responsibility to properly store and handle so we can get the perfect result during the trial. And this material management is very much critical for the quality. So that we have to require all the things like samples. First thing is the samples from the patient. So that sample should be collected in proper condition, proper vacuum proper specimen collection tube, and then it should be sent to the laboratory. And for the processing of the samples, we need so many things like barcode reader, then the centrifuge machine, then all the reagents which are utilized for the semi-auto, auto, and other things. Then to maintain that quality of that reagent and the sampling process whole, we should daily run the internal quality control and external quality control. All the consumables which are required for performance of the test should be properly preserved, utilized, and managed. And whatever equipment, again, they have to undergo the specific maintenance, daily maintenance, weekly maintenance, monthly maintenance, so that in that way we can improve the quality of the trial as well as the test results. So all the materials should be have proper traceability so that whenever the compliance is coming, we can easily trace out and we can find the root cause. And ultimately, we are getting the perfect result, as the madam told, for accuracy and precision. So that can maintain the data integrity also. So for that purpose, material should be validated, non-expired, properly stored, and then we are going to get the result. And also they should be having proper documentation. So to prevent that errors, so material management should be having for particularly labeled properly whatever lot number. It should be either in the electronic form or in the manual record form. So whatever we are receiving from the vendors, we have to keep the record properly stored depending on their requirement to 8 minus 80 degree. And whenever it is required to utilize, handle it properly without any risk of contamination, mix up. So you are avoiding the false result. And whenever we are performing, we also look after the whatever extra, then we should not go for overstocking. That will lead to expired materials, and ultimately we are generating so many waste. So try to avoid that things during the material management. So that for that you have to promote the proper staff. So that staff should be given the proper responsibility, so they can work in performance with the lab, and they have to helpful for the team coordination work. So whenever you are going to appoint the staff of laboratory staff, whatever, so you have to keep training about the standard operating procedure, from this sample collection to barcoding to how to performing analysis to the dispatching. Also train the staffs whenever any new technique is coming, then also aware the staff for the vendor qualification, procurement policies, cost per test, or whatever it may be, whatever receipts they are coming from the vendors, they have to preserve. So it is again important for the documentation systems. And the inventory, again, as Madam told, it should be based on the FIFO, first in, first out, or you can easily check for expiry tracking for getting the perfect result from the analysis. And once this whole SOP is going to standardize, again you have to properly maintain the whole trial material in the and maintaining schedule is also prepared in the record. And whenever any compliance, immediately you have to inform and follow the safety protocol. So this procurement material should be from the proper vendors only. Otherwise, if any um, improper reagent, contaminated reagent, low quality reagent, or consumables, maybe like RV test tubes, again you are not going to get the proper results. So try to record all the proper reagent and the consumables, and maintain the inventory in the two-way, first expired and first out, and first in, first out manner. So these persons who are going to maintain, they also keep the record of whatever material is utilized during the throughout the protocol. Any shortage or any damage, or immediately they have to inform to their immediate officers in the form of investigating officer or sponsors, so they can manage the whatever problems arising for the proper reporting. Using and storing materials should be correct. If you are not giving correct information, or not storing proper reagent, or not from samples, you may get the wrong result. And cleaning and returning of items after use should be proper. All should be follow the proper safety procedures to prevent the biochemical hazards in the laboratory. So to give that particular, all laboratory persons should be assigned to play proper, give the training. So each step has to play a role for the training, like proper usage, use materials strictly according to the protocol and SOP, avoid contamination of any sampling, don't mix up the sample, try to minimize the wastage generated during the laboratory, and proper disposable of waste according to this waste, biomedical waste has like red bag, white bag, blue bag, so that can prevent the waste hazard. All the technicians undergo the training program. So attending the training session, ultimately it is going to improve the quality. So they should be updated for their whatever new things is coming. So GCLP should mandate the training frequency, and that they have to given the training for all the kind of new procedure, material handling, or as well as the record keeping training. And whenever this materials is coming near the expiry, they should label and dispose it properly with the proper documentation and traceability. So record keeping is most important of chain custody for critical material. Otherwise, if any hazardous materials, they can be utilized by some other persons in the laboratory workers. try to maintain the proper logbook, electronic system, and regularly arrange the audit, internal as well as external auditory trials. Whenever any reporting issue comes, they should immediately inform to their higher authority. So common challenges, whatever facing during this whole clinical trials, the laboratory may be come across with the expired agents, stock out, some instrument breakdown. So they have to frequently undergo for the troubleshooting for the instruments, light and everything. So immediately inform and try to sort out the problem. You make the all your staff alert, audit and double checks, or you can give the real case, all case studies if it is applicable. What is audit? Audit is an internal audit. You can prevent this type of error by regular internal audit. Internal audit and material handling of the process of systemic evaluation of lab to assess whether the material handling practice comply with the GCLP, SOP and regulatory requirement. So in actually by doing this internal audit, you are maintaining the quality of this all the equipment as well as the reagents required in the laboratory. So how you can do this internal audit by seeing the receipt, documents, storage condition of freeze and everything, waste and labeling, proper checking the records, inventory control, expiry tracking, usage of log, traceability, daily seeing the calibrations of instrument as well as machine or particular test, which are the waste disposable procedure. So this internal audit process is helpful for identifying the whatever gap occurs before the regulatory inspections is coming. And that is important also for the continuous improvement of the quality work of the lab. And you can also ensure the accountability of the persons, and you can give the perfect data to the data analyzer and you can get the good output. So for that, corrective and preventive action is also applied. So that corrective action is in form of like expired material or missing labels. So in that case, immediately you hold the meeting, do the root cause analysis with the fishbone and try to identify the cause. And whenever any results is not coming according to the quality control, try to find out the what happens with the reagent, what happens with the quality material, what happens with the instrument, and try to find the proper cause and take corrective action and also develop the future plan to avoid the recurrence of this type of breakdown. And this should be recorded perfectly. Whatever reagent is not working properly or instrument, so that is improve ultimately our quality, and that is meet the regulatory requirement. So we can prepare this whole things for the future regulatory inspection from like regulatory bodies like FDA, EMA, WHO. So this monitoring is very good important by this. And in conclusion, this organization means assigning the proper duty to the whole sponsor, from sponsor to the principal, sub-investigator, research coordinators to all the technicians. They are going to maintain the integrity of data in research, and they are helpful for the importance of teamwork and communication and looking after the patient safety also. So they can done all these things can be done by following the protocols of good clinical laboratory practice in daily. Thank you very much.
Thank you so much, ma'am, for giving us an enlightenment on the role of each and every member for giving a good clinical or good quality care, teamwork to conduct and to continue the team of the laboratory in all the different perspective. Uh, this also implies for the inspections that will not only help for institutions for the care but also for the institutional upliftments. So thank you so much, ma'am, for
Thank you everyone for your time listening.
okay. Now moving ahead with the next speaker session, I would like to call Dr. Smita Chandra. I'm making you presenter, ma'am. Just a minute. Am I audible, ma'am?
Yeah, you are audible.
Okay, so now it's my honor to welcome Dr. Smita Chandra to the virtual stage. She is highly respected figure in the field of pathology and currently serving as a professor and head of the Department of Pathology at Himalayan Institute of Medical Sciences, SRHU, Dehradun. She completed her MD in pathology from the prestigious King George Medical College, Lucknow, and brings with her an impressive 18 years of teaching experience with over 100 publications in indexed peer-reviewed national and international journals. Dr. Chandra's academic contributions are both extensive and impactful. Her excellence in research and clinical practice has been recognized globally. She is a recipient of multiple national and international awards, including the Cancer Prevention and Molecular Pathology Fellowship at National Cancer Institute, USA, the ICRETT Fellowship from UICC Geneva, the Empowering Future Cancer Research Leaders Award by IARC WHO, and a scholarship award from the American Society of Cytopathologists in 2022, held in Baltimore. Dr. Chandra is also a fellow of the Indian Academy of Cytologists, FIAC, and a member of the International Academy of Cytology, reflecting her deep involvement in advancing the field of cytopathology globally. Today, she will be sharing her expertise on the topic of immense relevance, that is quality control in cytopathology, challenges and solutions. Her insights will undoubtedly enriching our understanding and maintaining diagnostic accuracy and overcoming practical hurdles. I'm truly privileged to welcome you, ma'am. Over to you.
Thank you, Dr. Chetali. I would just share my presentation.
Sure, ma'am.
I think there is some problem in sharing. Can you share for me? From your side, you can present it.
Yeah, sure, ma'am. You can click on the share if you can try once.
Yeah, I'm trying.
You
It
can
is
click
not
on the
uploading
share.
in.
Click on the share, and then there will be a dialog
I'm
box.
doing that, but I think it is not uploading.
I'm making you presenter again. Again.
Okay.
Once you open the dialog box, there will be an option on
Yeah,
this.
that I know. It is being showing also, but
Okay.
uploading is not occurring. No, it is not being uploaded.
You can share the PowerPoint with me. That's fine. If you can mail it right now.
Mail.
Yeah. If you
Okay.
can mail or do WhatsApp, whatever you want.
Okay. I'll just mail.
To all the participants, apology for the glitch. We can start in 5 minutes.
You must have received the mail.
Yeah, just a minute.
Yeah. I think now it is sharing. It is uploading. Is my screen visible now?
Yes, ma'am. Yes,
So
ma'am.
we can start. Yeah, we can start now. Sorry for all this problem. Good morning, everybody. First, I would like to thank the organizers for inviting me in this webinar on good clinical laboratory practices. My topic would be quality control in cytopathology, the challenges and the solutions.
You can click on the screen itself and then go for a next slide.
Okay. It's not moving. Yeah. Slides are not moving.
You can reshare the you can stop sharing the screen and again reshare the PowerPoint.
Okay. There is some problem. It is not moving forward. Okay, fine. So before starting my presentation, there are certain terms which I would like to tell in simple words, although Dr. Gunwanti has told them very beautifully. First is the total quality management. It is just, in simple words, it is the management to maintain the quality so as to reduce the errors and to improve the patient safety in the lab as well. Then there is a quality control. These are the techniques which verify the requirements of the quality, and particularly in cytopathology lab, it includes the technical quality of the slides. Then there is a term called as quality assurance. It is just a confidence that the processes which are being done in the laboratory, they fulfill the quality requirements. Now, the quality control in cytopathology is a bit difficult in comparison to the other sections of the labs. Why? Because in cytopathology, we are having descriptive reports. And so the words, they are different for every person. They will write differently the reports. Then the uniform system of reporting is still not available for all the organs in the cytopathology. Although WHO has given certain reporting systems in collaboration with International Academy of Cytology, such as WHO reporting system of lung cytopathology or pancreaticobiliary cytopathology. And there are certain other previous systems like Bethesda system for reporting thyroid or Milan system for salivary glands. But still, we don't have the uniform reporting system for every organ in the cytopathology. Then another important thing is cost effectiveness. Cost effectiveness, especially in the resource limited settings, they cause difficulty in quality control. Then as more and more ancillary techniques such as FISH, molecular techniques are being used in cytopathology, they all require enhanced quality control, which may be at times difficult. Now, this has been already told. There are three phases: pre-analytical phase, analytical, and the post-analytical phase. Now, pertaining to, especially for cytopathology, the pre-analytical phase involves all the steps till the slides are being submitted to the reporting officer for reporting. For example, it is the receiving of the requisition form, doing the FNAC, processing of the fluids, staining, etc. All these steps are included in the pre-analytical phase. Then we have the analytical phase in which the proper reporting is being done by the cytopathologist or the reporting officer. And then we come to the post-analytical phase. It ends till the reports are dispatched to the patient or the treating physician. And apart from this, it also includes the storage of the slides, the storage of the samples, discarding after the reporting has been done of the samples, and everything that is being included in the post-analytical phase. Now, as such, in cytopathology, not many studies have been done regarding the quality control or the burden of errors which are encountered in cytopathology. There are lots of studies in the clinical laboratories, but and mostly the studies which are being done in cytopathology are related to the cervicovaginal pap smears quality control. So whatever the literature search shows that the total errors which have been detected in the cytopathology lab, they range from 6.5 to 7% of the total investigations that are being done in 1 year. And out of these, the maximum errors are in the pre-analytical phase, which constitutes about 55 to 60% of the total errors. This is almost comparable to the other clinical laboratory sections because they also encounter about 70 to 80% of the pre-analytical errors. And so this shows that how important is this phase, the pre-analytical phase. Then the analytical errors, which is paid very much attention, the errors are ranging from 9 to 11% only, while the post-analytical errors, they constitute 35 to 40%. Now, moving one by one, the challenges which are being faced in the pre-analytical, analytical, and the post-analytical phase in the cytopathology, the first and the foremost is the incompletely or the wrongly filled requisition forms. Now, this problem is faced by all the sections in the lab. Either the patient's details are not filled properly, the name, age, etc., sex, or the clinical details are lacking, as well as the radiological investigation, all X-ray, CT finding. These all play a very important role in making a correct diagnosis in cytopathology. Then there can be improper sample collection or sample discrepancy. Maybe the patient, their husband's name, their father's name may also be same, and there may be mixing of the sites if they are being received from outside. Or there may be improper sample, the container would be overflowing with the fluids, or there may be very less amount, which will hamper the cytological processing and diagnosis. Then there can be poor preservation of the samples. The poor preservation may be supposing an FNAC is being done in the ward by the junior residents or any other. In radiology also, if a guided FNAC is being done, sometimes they take a long time for putting the slides in the wet fix for the wet fix smears. And the Coplin jars, they also do not contain the adequate amount of the solution, that is isopropyl alcohol, for the proper preservation. And so the cytological details are almost obscured and we cannot make out what the cell is showing. Then there can be, this is a very important challenge, that is inadequate cytological material. Supposing a person is doing FNAC who is not well trained, the material which would be aspirated would be either hemorrhagic or would not be related to that pathology. Then there is another challenge, that is the prolonged time of submission of the slides for microscopic examination. This may be at any stage. It may be at the stage of outside the lab or in the lab also. The technicians, they are not doing in proper time, and a lot of time has been taken till the slides are being submitted. So all these errors, all these challenges are present in the pre-analytical phase. Then apart from this, there are certain other errors, that is the validation error. Supposing a new kit has been opened for staining and it has not been validated. So it may show a bad staining, which is not good for the diagnosis. I think we have a proper lecture on validation in the afternoon. Then there is a poor technician competence. This is also important, especially for the newly joined technicians. They don't know how to stain, how to process the fluids, and they have joined and they do a lot of mistakes in staining, etc. So this is also an important challenge which have to be paid attention to. Then the equipment maintenance errors. Although in cytopathology, we do not have very much sophisticated instruments, but whatever is there, for example, a cytocentrifuge, or if in certain labs, we may have autostainers, etc., their annual maintenance should be there so that all the pre-analytical errors can be avoided. Now, with these challenges, now what to do? There are solutions also. So first, for the incompletely or wrongly filled requisition forms, what has been suggested that a bar coding can be done. Bar coding will, although it is a bit costly affair, but if we see the benefit of bar coding, then it is more than the financial constraint. So the mixing of the slides won't be there, the age, etc. would be there, everything would be clear. Then we can, in the requisition form, what we can do, we can check boxes. The clinical details, we can write what is the abdominal findings, what are the X-ray findings, we can put a check box. So the person who is filling, maybe the clinician or the nursing staff or the residents, they know that they have to fill these information in the requisition form. When the check box will be there, they will fill it. Then there is another method, that is the telephonic extraction of the information from the clinicians, but it is time consuming. Then certain forms are received in the lab that lack everything. Only the patient name may be written, or even it is not written, the FNAC has been done, from which site it has been done, or the fluid has been taken out, from which site it has been taken out. So I think these types of forms, they should be immediately returned back to the clinician and they should be asked to fill it properly. Then there are certain advisory services. If it is continuously we have problems, then we can give an advisory service, not to the health staff, nurses, etc., but also to the clinician. Maybe in the clinico-pathological meets or anywhere else, we can just advise them that how important is that we know every clinical detail and other radiological investigations. Then for the improper sample collection or inadequate FNAC, the person who is doing the FNAC should be properly trained. Until and unless, supposing if a person is doing, he's a constant defaulter, then he should be separately trained that how to perform an adequate FNAC. The other thing that can be done is to do a rapid on-site evaluation. The rows increases, it has been studied, it increases the adequacy of the smears from 60% to almost 90 to 95%. So every time when an FNAC is being done, just examine it for the rapid on-site evaluation and see if the material is not adequate. The repeat FNAC can be done at that time only without calling the patient afterwards. Then for appropriate collection of the fluids, there should be an advisory, or you can say certain documents which would be kept in the ward, that they know that is supposing they are sending the fluid, they should not send it in a sodium fluoride vial, they should fill it properly, the container in which it is being sent, they should be sent in proper way, and it should not be overflowing, properly labeled. Then the smear preparation and fixation, they should be told that the coupling jar should be 3/4 filled. It should be have isopropyl alcohol, and the smear should be properly prepared. They should not take out the FNAC material and make a smear in a circular manner. It should be properly made smears. So these advisories or trainings, they can be provided to the clinicians or the other laboratory, other personals in the ward. Then it is very essential for the timely transport, especially for the CSF, etc., that will distort the morphology of the cells. They should be told that do not, as soon as the fluid has been taken out, it should be immediately sent to the lab, and it should not be kept for the next day to be sent. Then the poor technical quality of the smears and the validation errors. So the cytotechnicians, they should be trained that whenever they open a new lot of chemical stains, they should validate it. And another important thing is that the chemicals and the fixatives which are being used for the staining, they should not be continuously used till they are exhausted. There should be a protocol in the lab that after 3 months, they would be changed so as to avoid errors in the staining and the fixations. And another very important thing is the modification of the staining time. It is not necessary that we should keep the staining time the same in every lab. It can be changed according to the temperature, the seasons, etc. For example, I can tell you that in Dehradun, in the winters, we have a very difficult staining, and so we modify the staining time during that time. And this should be updated in the SOP, which should be handy to everyone who is working in the lab. Then use of controls is very important. For example, if we are doing a special stain, maybe ZN stain, maybe silver methenamine, PAS stain, etc. Anything we are doing, we should use the controls so that we can say that it is properly being done. And lastly, what we can do is the cytotechnician training. This should be a continuous process. They should be evaluated and trained every about a protocol can be made in the lab either monthly or 3 monthly, whatever it is. They should be given a proper training, continuous proper training. Then internal quality control has to be maintained. What can be done is that the cytotechnicians who are working in the lab, they are assessed after about maybe in a month. They are given a set of slides, all the cytotechnicians, and they are asked to stain the smears. And those quality of the staining, it is assessed by the pathologist. And if there is a defaulter, they can be trained that how a proper staining is being done. Then it is essential to maintain the external quality standards by sending this is not related to the reporting. It is related to the staining. So we can send the stained smears to any nearby ISO certified cytopathology lab for the quality checks of the smear preparation and the staining. This will give a good idea that what we are doing is proper or not. Then automation in cytopathology lab is also a factor that can be used. For example, auto stainers, which can be used for staining, that will minimize the errors. But it is a costly affair, and especially in resource limited settings, it is an important limitation. However, literature search shows that there are studies that show that the benefit of automation outpowers the cost limitation in quality. So this can be used depending upon the resources of the lab. Then analytical phase, where the proper reporting is being done. Then there are screening errors, cytohistopathological discrepancy, and another is Ascus-Sill ratio error. See, Ascus-Sill ratio is in the gynecological cytopathology because there are audiences of different types. It is not only related to cytopathology. We have certain diagnostic terms in gynecological cytopathology, that is atypical squamous cells or squamous intraepithelial lesions. So these, the ratio has been given, and if this ratio crosses, that means the quality is not being proper of the gynecological cytopathology reporting. And there are errors in the quality controls also. Now, the cytohistopathological discrepancy is considered to be the best indicator of the reporting. It has been observed that the non-gynecological cytology has a more discrepancy as compared to the gynecological cytopathology reporting. And it is not always that if a CH discrepancy is very much is increased in the lab, it does not mean that the quality of reporting is poor. It may be that this lab is detecting better detection of errors is being done by this lab. So it is not always that the reporting is poor. And it has been observed that the breast FNA has the highest CH discrepancy, followed by the bronchial cytology. This is basically, so whenever the breast FNAC is being done, especially if it is being done directly, then there are certain chances of CH discrepancy that should be paid more attention. Then, as I was telling you, that there is Ascus-Sill ratio, which is important. It has been told that 5:1 is the ratio which should not be crossed. The Ascus, if it is being reported, it should not be more than 5:1 ratio. So if it is increased, then it may be that either the pathologist who is reporting has a lack of experience, is giving not proper timings in reporting of this, or there may be sampling errors. Supposing in CAMS, etc., the sample is being taken of the cervical smears and they are not being taken properly, and due to that also this problem may arise. Now, what are the solutions? So first of all, we should follow the universally approved system for reporting. It should not be individual based. So whatever the systems have been proposed, that have the person should be trained in that and should follow that systems. Then it is good that an experienced pathologist who is properly trained in cytopathology does the reporting. And a good communication with the clinician is very important. So whatever the clinical information, radiological information, which we want, that can be done. The cytopathologist should not hesitate in just giving a call to a clinician, and getting a good communication is important in this. Then another important thing is the pathologist should not hesitate for taking an external review in difficult cases. It should not be an ego problem. It is good for the quality of the lab as well as in the point of patient care, that the external review of the difficult cases should be done. Then there is also, there should be also a process of double blinding review by the pathologist. So what is that? Supposing there are 2-3 pathologists who are reporting the cytopathology. So in a month, 2 or 3 cases can be taken out, and each one of them who are blinded with that case, they are given the reporting. And supposing there is some discrepancy in their reporting, the diagnosis is different, then an external review can be taken, and it should be seen that why this is happening. Either it is due to the lack of training, or they are or the time is being given less. Then there should be EQUAS program that should be followed. It can be coordinated by Indian Academy of Cytologists or other laboratory, national and international reputed laboratories like Tata Memorial, etc. They are doing the EQUAS program, and every cytopathology lab, if they want to maintain the quality control, they should be part of that. It just gives an excellence in the reporting of the lab. And coming to the post-analytical challenges, the first and the foremost is the typographical errors. Now, there are certain scientific terms which are not being typed by the typist in a correct way, or even the site of lesion, the right breast can be written as left breast, and so these errors, they do occur. And a majority of these mistakes are occurring when the typist newly joined typist, or if there is a very much increased load of typing and the single person is doing the typing, and it is obvious that he or she will make the mistake. Then another important point is turnaround time. Now, the post-analytical is the time when we give the reports to the patient, and this turnaround time is the key indicator of it. Actually includes all the phases. This may vary according to the infrastructure, experience of the technicians, pathologists, etc. Now, what we can do for the typographical errors, so a training of the typist, and he should be acquainted with the scientific terms. So over the time, he would get used to those terms, and he would not make such type of mistakes. And there should be a limited reports to be typed. It should not be that a single person is given all the burden of typing. There should be 2 or 3 typists if we want to maintain the quality of the lab. We can also use the reporting templates or teleprompter, which will minimize the typing errors depending upon the infrastructure. Then the turnaround time, what can be done is that as soon as the requisition form is being received, or the sample is being received, or FNAC is being done, we put a stamp that this was the time when it was received. And then every time when the slides are being stained, the staining has been completed, a stamp can be put of the time. So this will, the person will know, whoever is following that, who is reporting or who is giving the report, they know that this much time has elapsed. And so they will pay attention towards the minimizing of the turnaround time. Then the certain urgent parameters like CSF, they should be put, a stamp should be put on the requisition. This should be highlighted that it has to be reported within 2 hours. Then continuous monitoring system can also be done by the hospital information system, which will, this information system, we can see that how much time is being elapsed, and why, and what are the cases which are showing the increased turnaround time in a month, and how can we minimize them. So actually, turnaround time is the basic thing what the patient sees, that I have given the sample and it is being reported after about 3 days or 4 days. So this turnaround time is very important, and which can be minimized by these solutions. So to conclude, the first and the foremost thing I would say that in cytopathology, documentation should be there, continuous training of the technicians, of the pathologists, or the clinicians also regarding certain things I told. There should be a maintenance of the internal and external quality control. The identification of non-conformance is very important, and there should be a root cause analysis so that it can be avoided in future. There should be a complete clinical and radiological information, and a good communication with clinician is very important. The hallmark is that the errors should be acknowledged, and there should be a sincere efforts to minimize them. So these are my certain references, and thank you. Over to you, Chetali.
Thank you so much, ma'am, for sharing so much insightful things to be taken care or take a note of, starting from quality control, what technical issues and quality issues comes in samples, the different phases of analytical, post-analytical phase problems and challenges that actually the practically in clinical scenarios that we face, and the solutions, that the root cause to be find out, and the solution has to be done on the finding out after the root cause. So thank you so much, ma'am.
Thank you. Thank you so much.
Okay, moving ahead with our next speaker, Dr. Indranil Chakrabarti. I'm making you a presenter. Am I audible to you, sir?
Hello.
Hello, am I
Hello. Hi.
audible to you, sir?
Good morning. Good morning. Good morning, Dr. Chaitali, and good morning,
Just
all
a
the
minute,
participants.
sir. I'll take a moment. So here I take a moment to introduce Dr. Indranil Chakrabarti, sir, who is an additional professor in the Department of Pathology and Laboratory Medicine at AIIMS Kalyani, as a distinguished speaker on our virtual platform. He's going to enlighten us on specimen management. In his introduction, I would highly respect his figure in the field of pathology with over 17 years of teaching experience and a remarkable academic portfolio that includes 94 publications in reputed national and international journals. He holds prestigious fellowships from the International Academy of Cytology, the Indian Academy of Cytologists, the Royal Society for Public Health, and the International Medical Science Academy. In addition to his academic accomplishments, he serves as the Indian ambassador for both the United States and Canadian Academy of Pathology, USCAP, and the European Association for Cancer Research, EACR, and is the current vice president of the West Bengal Cytology Society. He has played a pivotal role in organizing numerous CMEs, workshops, and conferences, and is widely sought after as a speaker for national and international events. His research interests span cytopathology, oncopathology, and dermatopathology, and he continues to guide postgraduate scholars in advancing the field. I'm privileged to welcome you on virtual dais today, and he will give valuable insights on specimen management. Over to you, sir.
Thank you, Dr. Chaitali. Is my screen visible?
Yes, sir.
Okay.
Yes, sir.
Okay. So today's topic is specimen management. So one thing is, why do we need to know about specimen or sample management? So in field of pathology or in field of laboratory medicine, we use these two terms, specimen and samples, as interchangeable terms. So specimen or sample management, it is a critical component of GCLP, which ensures the quality and integrity of laboratory data in clinical trials and diagnostic testing. So as Gunvanti Rathorman told, that the GCLP is a bridge between good laboratory practices and the good clinical practices. So this specimen or sample management encompasses the systematic handling of specimens from the point of collection to transport, receipt, processing, storage, and the eventual disposal. The GCLP mandates that all processes involved in sample management be well documented, standardized, and conducted by trained personnel under defined standard operating procedures. This minimizes pre-analytical errors, ensures compliance with regulatory standards, and supports ethical conduct in clinical and diagnostic investigations. So as it has been highlighted many a times, that all the phases of laboratory testing, that is the pre-analytical phase, the analytical phase, and the post-analytical phase. Now it has been seen that around 68% of the errors, they fall in the pre-analytical phase. around 13% in the analytical phase, and 19% in the post-analytical phase, which highlights that the importance of this pre-analytical phase. Now, the result of any laboratory examination is only as good as the sample or specimen received in the laboratory. So, as we started our lessons in computers, we came to this term GIGO, that is garbage in, garbage out. So, the quality of the sample that we take depends, it guides the quality of the reports that are generated. So what is a sample or specimen? In general, a sample is a small portion which is a true representative of a larger portion of the material or body. A laboratory specimen is a sample of a medical patient's tissue, fluid, or other material which is derived from the patient used for laboratory analysis, examination, or study. So the sample or the specimen management system, it comprises of various steps. It starts from the patient registration, pre-collection or preparation of the patients, the proper collection, that is, it can be the specimen can be blood or any other specimen, the receipt, the acceptance and rejection criteria, the sample processing proper, the sample specimen refer and transportation, sample or specimen storage, sample retention, and ultimately the safe disposal, that is the biomedical waste management. So a good sample management is essential for accurate laboratory diagnosis. It influences the therapeutic decisions. It directly affects patient care and outcome and influences the laboratory efficiency. So the laboratory's responsibilities include the providing the sample collection information, what sample to be collected, when to be collected, how to be collected, provide appropriate containers and supplies, define a good labeling system, and assess all samples pre-examination and post-assessing, and it can be assessed by the acceptance or rejection criteria of the lab, and if it is accepted, then provide provision of the test request form or the lab request form. Now we also have the ISO 15189 guidelines in 2022, and I request you all to go through the guidelines. It is freely available. So this ISO 15189 in 2022, it describes many of the points that we will be discussing. That is about the facilities and environmental conditions that are required, about the facility controls, about the storage facilities, about the sample collection facilities. So in a nutshell, they encompasses many of the guidelines that we should follow in the good clinical laboratory practices. Now, let us start with this test request form or the lab request form. Now, the lab request form must have a patient ID. Ideally, it should have two unique identifiers. It should encompass the test requested, also including the date and time of the request, the time and date of the sample collection, the source of the sample when appropriate, clinical data where indicated, contact information of the requesting physician or the authorized individual, unique identifiers for traceability within the laboratory, that is the sample identifier, the location of the patient, particularly important if the patient is admitted in the inpatient department, and the priority of request, whether it is routine, it is for routine processing or it is for urgent processing. So ideally, if a sample is very urgent, it should be marked as urgent and it should be processed earlier. So if electronic systems are used, the same information must be captured and safeguarded digitally. Now, the front desk or the billing management area is very important. It receives several types of customers: IPD and OPD patients, insurance companies, corporate houses, medical practitioners, consultants, hospitals, nursing homes, other commercial laboratories. And it is always best to avoid handwritten errors and use of LIS, that is the Laboratory Information System, and barcode systems whenever possible. Before accepting the request for the test, it's always a good practice to review whether the test is being done in the laboratory. In case the sample is brought from elsewhere, adequacy of the sample should be checked. And if the sample is not adequate, the customer should be informed of the required quantity of the sample for the test. Secondary sample is accepted, provided it is collected and transported, maintaining all the guidelines as mentioned. Also should be reviewed the manpower availability, the suitability of equipment for the requisite test. If it is not available, samples are returned. In case any test has been temporarily suspended, such list is made available with the office, and delivery of test report is reviewed for urgent or ordinary samples, and dates are informed to customers accordingly. References are made to any work referred by the laboratory to a referral laboratory or consultant. When the tests cannot be conducted in-house due to some reason, they should be sent to a reputed referral laboratories, and these referral laboratories should be pre-selected. In such instances, customer is informed about such referral by the receptionist, and the customer's permission is sought and should be documented. In case there is an objection by the customer, testing responsibility should not taken up by the lab. So this front desk or billing management requires very good communication skills. Next, coming on to the collection proper. The collection requirements include the patient preparation, the patient identification, the type of sample required, the type of containers required, perfect leveling, special handling in some special cases, and safety precautions. So before going on to the collection, one should be aware that all these are adequately taken care of. So it is a very good practice to provide a sample collection information. So most of the labs, they have a laboratory sample collection manual. Patient preparations, which includes some patient preparation. Some examples are like fasting blood glucose. So the amount of fasting that should be mentioned, what can be taken or what cannot be taken, they should be well spelled out. Suppose again for postprandial glucose, the time is calculated from the beginning of the meal. So all these instructions should be available to the patients. Again, overnight, minimum 12 hours of fasting, which is required for lipid profile. Then for timed collections, for random urine, for stool for OBT. So all these patient preparation information should be available to the patients. A very important part before collection is the patient identification. So when identifying the patient, have them provide their full name, gender, age, date of birth, and address. So before taking the sample, it is always a good practice to ask the patient the name and other details. The inpatient should be wearing an identification band with the above information, which the phlebotomist should confirm for the venipuncture. Always match the test request with the bill or the prescription. It is important to identify the patient accurately so that the blood is collected from the correct person. So I will be discussing more about the phlebotomy because the cytology part has already nicely been taken by Dr. Patel. And so first in phlebotomy, the wearing gloves is mandatory. Wearing of lab coats and masks, particularly for tubercular patients. Closed shoes should also be mandatory because of the risk of needle stick injury. So always approach the patient in a calm, confident, and professional manner. Explain the procedure and answer all the queries. You always should confirm the identity of the patient with the test request form. The patient should be comfortably seated or supine for 5 minutes before sampling and never standing. The patient arm should be extended in a straight line from the shoulder to the wrist, and avoid the arm with extensive scarring, hematoma, edema, burn, etc. So the preferred vein is the median cubital vein, followed by cephalic vein or the basilic vein. Leveling of tubes prior to or after collection. Now this is a contentious issue. So in some institutes, they practice leveling of the tubes prior to the collection and some level the tube after collection. So it can be according to the institute policy. The correct collection system should be used. The tourniquet application, this is very important. Tourniquet tied too close to the venipuncture site can cause hematoma. Veins may not become prominent if tourniquet is tied too high. So it should not be more than 3 or 4 inches above the venipuncture site. Tourniquet left on longer than 1 minute can result in hemoconcentration, which will affect certain tests. So the tourniquet time should be always less than 1 minute. Tourniquet should be released as soon as the needle is in the lumen of the vein and the blood flow is established. The cleansing of the venipuncture site should be done with 70% isopropyl alcohol swabs or sterile swabs. Allow the alcohol to dry completely to avoid stinging sensation upon the needle entry and hemolysis of sample. And once you have sterilized it, do not repalpate. Samples such as blood cultures should be collected using iodine to clean site to ensure sterility of sample. Lab should have a policy to record multiple puncture and never reprick with the same needle. All the blood collection tubes need to be filled to the correct volume. So there is always a minimum fill indicator which is present in the vacutainer. So it should be filled up to the correct volume. Now, so these are the various types of vacutainers that we have. That is the blue top, the red top, the yellow top, the gray top, the lavender, the dark green, pale yellow, and black top. So the blue top is for the coagulation tests, and it contains 3.2% buffered citrate. And after collection, one should invert it 3 to 5 times. For the red top, there is a clot activator. For the yellow top, there is a gel which separates the serum. For the gray top is used for plasma glucose. The lavender is most commonly used in pathology laboratory. That is the EDT for the collection of the whole blood in the EDTA as anticoagulant. And these are the inversions that one should make using these vacuometers. So proper tube mixing is essential to prevent formation of microclots. So apart from blood, there are other specimens that come to the laboratory, like the urine collection, which is an early morning collection, or a spot collection, or 24-hour urine sample, stool, which may be routine for occult blood test or for stool culture, sputum, expectorate sputum or induced sputum, semen, microbiological samples, histopathology samples, and cytology samples. Sample leveling is very important. It should be leveled with the patient's name, age, gender, ID number, test order, time and date of collection, as well as the collector's initials. So use computer-generated barcodes whenever possible. So during sample reception, it should be ensured that all samples are accompanied by the test request form. Document the date and time when the sample was received, assign the numbers as already told, and examine the sample visually to evaluate for acceptability. So it's a very good practice to maintain a master sample reception log. So a master register may be kept, or each specialty lab may keep its own sample register, which includes the date and time of collection, date and time of receipt, sample type, patient name, demographics, laboratory assigned identification, and test to be performed. So there should be as well spelled out sample rejection and acceptance criteria. So unlabeled sample, improper labeling, broken leaking tube, container insufficient, patient information, hemolyzed samples, overfill, underfill, or insufficient specimens, prolonged transport time, or improperly transported specimens, they should be rejected. And once they're rejected, what are the actions that should be taken? You should inform the authorized person that this has been rejected, citing the reason, request another specimen, record the rejected specimen, retain rejected specimen based on present criteria, and under extraordinary circumstances, sometimes we may require testing suboptimal samples if recollection is not feasible. So in the sample processing proper, so we all know how the samples are processed. I won't go into the details of this. So we should monitor the turnaround time, and we should have the standard operating procedures for the sample processing. And very important thing is the sample handling. So handle all samples, whatever be the sample, as if it is infectious. So proper use of personal protective equipment should be taken, that is gloves, masks, gowns, and closed shoes. Safe handling and processing. Use mechanical pipettes, never mouth pipette. Handle samples in biological safety cabinet if aerosols are possible. Minimize open handling and sample transfers. Whenever there is spill, go for spill management with 1% sodium hypochlorite. Hand hygiene, wash hands with soap and water after glove removal or sample handling, and use alcohol-based hand rubs if hand washing is not possible. And sharps handling, sharps should be handled with great care. Never try to recap or bend needles. Dispose these needles in puncture-proof sharp containers. Report sharp injuries immediately in case of needle stick injury. Now, sometimes we have to refer the sample if the tests are not available in the lab, or to allow performing specialized tests at central facility, or as a backup measure. Suppose there is an equipment breakdown, non-availability of lab personnel, or stockouts, we have to refer the sample. Or as a part of the external quality assurance program, or ILC, that is inter-laboratory comparisons, we have to refer the samples. And for confirmation, sometimes for confirmation of test results. So the sample transport timing should be maintained. Some specimen must be transported immediately after collection. For example, the ABG, or the arterial blood gases. Specimens for serum or plasma chemistry testing should be centrifuged and separated within 2 hours. And certain chemistry analyses will require the tube of blood to be chilled after collection in order to maintain the stability of the analyte. A slurry of ice and water is recommended for chilling the tubes of blood. For example, in case of ACTH, in ACE, acetone, ammonia, etc. Always assure safety, that the safety regulations are met. In the sample transport system, WHO recommends the triple packaging system. So there should be a leak-proof and properly labeled test tube, vial, or urine container, which must be sealed tightly with paraffin. So this acts as a primary container. Then this primary container is put inside the secondary packaging, which is a leak-proof container or a Ziploc bag, and it should contain sufficient absorbent material to soak up all the liquid if the primary container breaks. And the outer packaging should be of a rigid outer box or container labeled as biological substance category B UN3373 for routine diagnostic samples. So this is the diamond mark labeling, that is UN3373. They must include sender and receiver information and biohazard level if needed. And we should always follow the WHO, the IATA, and the local regulations for sample transport. For the sample storage, we should describe the samples to be stored, determine the retention time, determine the location, describe the proper condition, establish methods of organizing samples. So all these should be put inside a SOP. For the sample retention, we should have a set policy for retention. We should monitor stored samples, including freeze or thaw cycles. We should maintain an organized and accessible system, establish a schedule to review all stored samples. It's not that we have stored the samples and we never get back to review the sample, how it is being stored. Establish a tracking procedure, record disposal dates or methods, and be compliant with the local regulation. So there are many, it may vary from institute to institute. So this is just an example of the various retention times in clinical biochemistry, hematology, microbiology, serology, immunology, molecular biology, histopathology for the FFP blocks, histology slides. So they should be retained at least for 10 to 20 years, cytology smears. So these are the retention times that are followed in most of the labs. So this can vary from lab to lab, but it's always better to go as per the standard practice or the NABL guidelines. And last but not the least, we should ensure proper waste disposal. So following the Biomedical Waste Management Rules 2016 and the following amendments in 2018, 19, and 2022, which was previously known as the Biomedical Waste Management and Handling Rules of 1998. The key principles include segregating the infectious and the non-infectious waste at source. So this is very important to segregate the waste at source. Color-coded disposal should be ensured, timely and safe transport should be ensured, and on-site decontamination whenever required should be done, and documentation and training. So this is a waste segregation of solid biomedical waste. So it is always a good practice to have such a chart in your laboratory. So the non-infected waste should go to the black or the plastic container. The solid waste, infected dressings or POP casts, they should go to the red or red plastic container. The anatomical waste to the yellow or the yellow plastic container. The infected plastic syringes, gloves to the blue container, and all the sharps, that is the needles and cut glasses, they should go in a puncture-proof white plastic containers, and they should be appropriately disposed of. So commonly in our laboratory, what we see that we get the vacuum-tenors of the test tubes, so they should go into the red and blue bin based on the material. Tissue specimens and body parts in the yellow bin, sharps, needles, and blades in the white puncture-proof container, broken slides and cover slips in the blue bin, contaminated gloves and PPE in the red bin, chemical wastes, store formalin and xylene, do not throw it through the drain, store separately and hand over to the hazardous waste handler. So the internal transport within the lab or within the hospital should be done in closed trolleys, and final disposal should be done via the common biomedical waste treatment facility, which is a government, which is accredited by the State Pollution Control Board, and maintain the handover records and the autoclave logbooks for waste disposal. So the laboratory must have a good sample management in order to ensure accuracy and reliability of testing and confidence in results. And this sample management directly affects patient care and outcome, because the errors made in the PDR prior to the analysis of the sample may influence the quality of the final measured results and compromise the diagnosis and treatment of the patients. So always remember, no result is better than a bad result. So to summarize, we should provide a laboratory handbook with collection information to all the users. We should have a system for tracking samples as they move through the laboratory. We should have SOPs and for sample storage and sample disposal. We should maintain the sample integrity, maintain the confidentiality of the patient, and assure that all transport regulations and requirements are met. And always follow the universal precautions. So we should look at the safety of the 3 Ps, that is the safety of the patient, the safety of the personnel, and the safety of the population at large. So I acknowledge the web resources, the ISO 1518 guidelines, and Dr. Shambhucha Mukherjee for this presentation. And today is the National Pathology Day. So I will conclude by in loving memory of Dr. Vasant Ramji Khanolkar, who is regarded as the father of pathology and medical research in India. Thank you.
You can stop sharing the screen, sir.
Yeah, I have done.
Thank you so much, sir, for a quick recap and a detailed presentation of what and how the specimen has to be taken care of according to the WHO guidelines, and focusing more on the phlebotomy perspectives because already the cytopathology aspects were covered. And of course, in the clinical aspects, we definitely do follow these processes, but sometimes by changing or by having a few errors in this, we can actually manipulate the specimen, and this has to be followed for the reliability diagnostic processes. So thank you so much for your valuable information, and also for sharing us the day of today's day, the anniversary of the father of pathologists. Thank you so much, sir.
Thank you. Thank you.
Now we are moving ahead with the next speaker of today's session, Dr. Harsh Joshi. I'm making you a presenter. Am I audible, sir? Hello? Harsh, sir? Am I audible? Just a minute. Good morning, Dr. Harsh, sir. Your voice is not there. You are not audible. And the screen sharing is also not yet started.
Okay.
Yes, now we can hear. Can you just stop sharing the screen? Hello? Harsh sir, am I audible to you?
Hello?
Yes, sir, you are. Sir, I can't hear you.
Yes, yes, audible.
Okay, now I can hear you. Okay. So I would like to welcome. Yes, sir, audible. Now I would like to honor the virtual dais with Dr. Harsh Joshi, sir, who is an
Okay.
accomplished pharmacologist, earned his MBBS and MD pharmacological degree from NHL Municipal Medical College, securing the first rank at Gujarat University. With over 13 years of experience in the medical field, he continues to serve with excellence at NHL Municipal Medical College, Ahmedabad. Among his many achievements, he has notably one of the youngest single authors in medical education, having published the widely appreciated book Pharmacology Essentials in 2020, which was inaugurated by the Honorable Chief Minister of Gujarat, Shri Bhupendra Bhai Patel. He also revised internationally acclaimed textbook Principles of Pharmacology, 4th edition 2023, adapting it to the latest CBME curriculum for MBBS students. He has received multiple prestigious awards, including Eminent Pillars of India Award at the Delhi Vidhan Sabha, Best Researcher Award at International Conference for Award Winners in Science and Medicine, Pondicherry, Academic Achievement Award in Pharmacology, recognized by Government of India and Niti Aayog, and the Eminent Author in Medical Education and Research Award in Goa. He has also served as a guest speaker on All India Radio, Akashvani, on key public health topics during COVID-19 pandemic and actively contributes to social causes as a core member of the Smith Foundation, supporting over 100 orphan children in and around Ahmedabad. He will be speaking today on the vital topic that is retention of records and reports and confidentiality, including audit. His talk will surely provide critical insight into good clinical laboratory practice. We are truly privileged to have you today, sir. Over to you. Sir, can you share the
Yeah,
screen?
thank you. Yes, yes.
Yes, sir. Hello, sir. May I help you in anywhere for sharing the screen? Hello, Harsh, sir. Am I audible to you? Apology for the glitch. There is some internet connectivity issue going on. So he is continuing with the speaker session in just few minutes. If anyone have any questions regarding the session, they can directly put a question in the chat box directly to the host, that is me. We will try to solve your queries and questions. Hello, sir.
Yeah. My voice is audible?
Yes, sir.
Okay. Yes. So I can share the link.
Yes, sir, I have made you presenter.
Okay. Yeah. So is it visible now?
Not yet, sir.
Not?
We can't see your screen. We can see that you are presenting something, but we cannot see the screen. If possible, you can share your PowerPoint to me. I can share the presentation.
Now it's visible?
No, it's showing that you have stopped sharing the screen.
Okay. Okay. I'm trying again.
Not visible, sir.
Visible?
Not visible. You can share your PowerPoint presentation to me. If possible, then I can directly
Yeah, that is
share the screen.
better.
Ha.
Okay, okay, just PT.
Okay, sir.
Yeah, it's sending. Hello. Very good. What? Hi, sir.
The apology for a delay. I request all of you to stay here. We will be restarting again in
Voice is audible?
5 minutes. Yes, sir. Voice is audible. I cannot see. I have not received the PowerPoint.
Yes, yes. No. Okay.
I have received the PowerPoint. Give me 1 minute. Can you see my screen? Hello? Hello?
No, no, still visible. Visible?
Now, can you see the screen? Can you see the screen?
No. This is audible.
Yes, sir. Can you see the screen, sir?
Yeah. Yes, yes, yes.
So can we start, sir?
Okay. So characteristics of okay, can I start? Okay. Madam, okay.
I'm really sorry for the delay. We are moving ahead with the next speaker, Dr. Manoj Kahar. Uh, Good morning, sir. Am I audible? Manoj, sir? Harsh, sir will join later. We will move ahead with. Yes, sir, Manoj, sir, you can unmute yourself by yourself. I have made you co-host. You can unmute from your side. On the left bottom, there will be a mic. You can click on that. You can directly do mute and unmute.
Hello? Hello?
Hello.
Yeah. Voice is audible and visible screen?
Yes, sir. It is visible. You can keep it in the PlayStation, or you can do landscape mode.
Yes.
Okay. We are starting with Dr. Harsh Joshi's topic, that is records and reports and its audit in good clinical laboratory practice. As Dr. Manoj sir is also facing some problem, we are again reshifting the lectures. So yeah, sir, over to you.
Sorry for the delay. We are starting with the session that is records and reports and audit along with the confidentiality part in GLP. As you know that when the study starts and the study till the public what you write, that is one of the most important part here. This is the very important, sir. I thank you, sir, for giving me opportunity to this topic. Just to start with the discussion, that which are the characteristics a good documentation practice, what we also called it. The first part of it is attributable. The data generated or collected must be traceable back to the individual who has generated the data. So entries should be traceable to the individual, the performing the activity. Each page, each record, the data forms, they should be properly signed or dated also. Definitely the signature, the initials, the better. Some initial signature is different. There is that you should be a proper during the study. The signing of the data must be there with the proper checking and verification of the work. So first, attributable, the date also performed and recorded must be included when the prompted data to the publisher. Performed by, that is, who has performed the step, the proper data, the individual, the signing or mailing the record. So it should be performed by, sign, and recorded by, that indicates the entry or series of the entries which is written by the individual signing or mailing the record. So every data should be have a two parts, that is performed by, sign, and recorded by, that is another sign. So that should be a proper attributable data, that is the back data. The second is legible. Legible be easy to read and which is a permanent. There is no falsification, modification can be done, or there is any possibility to modify it. So entries in record must be clear. Must be there as we are clinical trials, no overwriting. Contemporaneous merit or measurements, etc., must be post dated. What you have done a record at that time it is done. So date documentation and record must match with each step of your GLP part. So it is not a one step, it is a continuous step or continuous operation at which time, at which date you. That is the very, very good part of the record and report in GLP. Characteristic, one of the pillar of the GLP, that is original record. So record the data directly into BPR, what we call that is batch production record, a logbook and or laboratory logbook form, data collection record. Information data printout, the charts if it is there, the raw to that record, the document number also, the page number also, the lot number, and the dated by the proper person. The next and last is the pillar is the accuracy. Entire GLP part, all the entries must represent your data till the end of the research. The documentation must be written so that everyone versed in the general field can follow the document till starting to end and reach the results also. Calculation, if it is there, must be documented in GLP, which is very easy to follow and get the answer. So first it starts the recording and the reporting starts with the retention of records, the raw data. The section relates to the correction of the experimental data also, carrying out the procedures and recording the observation. So before implement any procedure, ensure that in GLP, the record that proper number of adequate trained and experienced staff which is available to the GLP data. Record the training for protocol, aware all the staff what the exact experiment you are doing in GLP. Understand the protocol, very, very important. And the copy should be there at the site where the GLP is actually done. So the protocol copy should be there. Main part, SOP, standard operating procedures, are well written and they are available around the work areas. Necessary equipments in GLP, also the supplier data should be there. Data recording forms are also available at the working site, which is very, very important. Before starting of any procedure, check the equipments also because GLP needs equipments. So the condition of equipments, they are working or not. Record the weighing machines, the quality of it, the balance, the check should be done before the starting of the data. Every machine is working or not. Ensure that this has been done with the reference to the appropriate logbook or an equipment labeling also. All the required procedures were correctly carried out at the corrected time. If the data is lost or the complete record is not made, it should be there in the SOP what should be followed if the data is lost. The data are necessary for reconstruction of the study. So that should be done in the SOP. So it is very, very to be vigilant during recording from starting to end of the research in GLP. The data should be clearly identified who is responsible for carrying out the procedure and recording the data. You have to point out the persons. You have to train the persons. All the data generated during the conduct of the study should be identified and recorded directly and very, very promptly. Accuracy, legibly or illegibly by the person should be there, signed, initiated, and dated. If it is not falsified, right? Any changes should be made. You should also obscure the previous entry. Should indicate the reason why such person making the change must be signed and stable. So signing is one of the very important part at every stage of the recording. Accountability, that is a very, very date. Action record may require the alteration from time to time. Why the change is required? You should be a proper clarification on that. Who is done, by whom, when it is done. Correction. So it is implementation of GLP. It is very, very important that inform the role to be played by each significance of each role for the GLP compliance. ensure that the person concerned sign the CVs and the trained record. So a proper training should be there. The recording of the training also should be there before the GLP record starts, the study starts. So prepare and record about the training for SOPs also. Decide who will be responsible for the management of the organization of the SOP system. Write SOP, proper content, proper layout, proper format, and prepare the template protocol for the studies. List all the equipments and instruments used in the laboratory. In the SOPs, must be defined. It is the best to this sector by sector. For example, the clinical pathology, analytical laboratory, animal house, if it is there, microbiology, histology, or any drug, and dose. So this is all listed in the SOP, also to be instructed to all trained staff. So it is a logbook for each piece of the equipment should be there. Decide the method of maintenance of equipment also, because the equipment maintenance is also a big challenge, including the creation of the metrology unit, maintenance of the responsibility, who is responsible for the maintenance of the equipment. Define the maintenance schedule also. The logbook is there, so you should schedule it, how the maintenance should be done with the equipment. Define the identification, handling, and storage of all the test items, reagents, and the reference item. In GLP, all the test items, the reference solutions, or the reagents, who is handling, how the storage, how you identify should be properly labeled, and the staff should be trained accordingly. Establish how to determine the expiry of the reagents and the reference items also, because it may be missed. Write SOPs for the labeling also for all the items. It may be reagents, it may be solutions, it may be reference items. So the labeling is also very, very crucial part for the recording of the whole process. The SOPs should clearly mention how to preparation, or how to process to be documented, like how the homogeneity test, what is the stability test, how should be performed. So it should not be modified by the persons. Define the raw data in the all operational units and how to record it. Define the way to record this data, like laboratory notebooks or on the pre-establishment forms. That is very, very crucial. For each study, individual study, first write a plan. So till now, we have seen that before you start study, what should be ready with your record. Now we will shift it to our second part of the presentation, that during the study, what you should record. So for each study, that written a proper protocol, how should be performed, how you initiate the study. It should be approved first, dated also with the compliance of the quality assurance personnel. Deviations.
Sorry to interrupt you, Harsh sir. Your
Yes.
slides are not changing. If you don't mind, can I share the screen?
Okay, yes.
Can you see my screen? Can you see the screen, sir?
Just a minute. Still not visible.
Now,
It's loading, but still.
sir, can you see?
No, still. Okay, the screen is now visible.
Yes, sir. Now it's visible. Yes, sir.
Okay, I am changing. So, is it
Yeah, now it's visible and changing. Yes. Okay.
okay? Okay. We are discussing about that before you starting the GLP studies, that what you should be prepare with the records. Now we are discussing about just before this that during the study, which record should be ready or how you have to be very, very careful during the GLP studies. So for each study, written plan should exist. First of all, the protocol should exist. It is approved and dated by the signature compliance person, QA personnel. Also, the deviations from the study plan should be described also, should be explained also, and acknowledged and dated. So identification of the study and test item, very, very important. The reference item also, it should be prepared before you start it. It should be recorded also. So it starts with the title, a statement which relieves the nature and purpose of the study. Identification of the test items by code. It is given that all the solutions can be given the code also with a special name also, the number, biological parameters apart from. The reference item to be used, it should be ready. It should be recorded also. Information concerning the sponsor and the test facility. So it should be name of the sponsor, address of the sponsor should be ready. Documented. Name and address of any test facility. It may be multi-center. It may be multi-laboratory testable items. Study. Name and address of the study director. Name and address of the principal investigator, maybe one or more than that, or the phases of the study should be properly ready with the. Okay, the slide is changing. The slide is changing.
Yes, sir. Your slides are changing.
Okay, yeah, thank you. Okay, detailed information on description on the chronological procedure of the study, the method, materials, and conditions, types, and frequency of the analysis, measurements, observations, examination, how to be performed, who will perform, how will you record, it should be ready. Any statistical methods also. Another is the specimen from the study should be identified to confirm their origin. Either it is imported, it should be ready. Such identification should be enable traceability from where you import the solutions. It is recorded as appropriate for the specimen for the study quality. All the data generated during the conduct of the study should be recorded by individual entering the data. Who will enter the data? This entry should be signed or initiated also the date. Now, content of the final report that the final report should include, but not to be limited, the following information. It starts with the identification of the study, test item, and the reference item. A descriptive title, identification of the test item by code or name. The main part that after you finishing the GLP study, it should be proper study result. Description of the material and test method, that description of the material methods which you use, which test guideline you use, the proper summary of the result, all the information and data required by the study plan, it should be there. Nowadays, I found that even in the clinical trials, even in the GLP laboratories, they shifted from hard copy to the digital transformation under the good documentation practice. So all the record in the GLP, also in the clinical trial, there are some softwares available directly, they enter in the digital transformation. So as we move further into the digital era, the good documentation practices also evolving. Companies are shifting from paper-based system to the electronic documentation systems. And this transfer is also not without any challenges. To meet with the increasing data volume, ensuring the data integrity, simplicity for the regulatory compliance also. So we will see that how you record and which are the benefits of recording in the electronic documentation data systems. Electronic system can handle the large volume of data more efficiently. It eliminates the possibility of human error in manual data entry, and that's by increasing the accuracy for the data. Data can be easily archived and changes can be tracked also and traced also. Maybe not possible also, providing the greater transparency and the traceability. Electronic system also simplify the compliance with the regulations as they can be programmed to adhere the requirements and many standards set by the regulatory bodies. Other benefits are electronic documentation data systems that maintain the commitment of the adhering of the good documentation practice. It is very easy also. Have put in place the comprehensive security measures and conduct regular audits also by the security and integrity of the data. So many softwares available, they sell with the per year, per 3-year data package. That is Descartes, JDC1, TAG, and XAML. That I found that 4 softwares which are available, which gives a proper electronic documentation practice. But it has many challenges. Implementation of an electronic documentation system comes with a set of challenges. That is, transpositioning from a paper-based system to a digital system may be complex with many persons, requiring significant time to learn. Resources should be there. A complete redesign of the documentation workflow must be there, must be followed without any reduction of the quality. So it is a training of the staff must be there. The issue of the data security and privacy, that is also a critical part for the electronic data system. Rigorous encryption and security measures must be put in place to protect the sensitive data of the study. Audits should be regular with the system and requirement for the system along with the reliability. So archival of the records and material should be there. The study plans, the samples, the test, the specimen, the report, how much years you archive. Records of the all inspection, audits, qualification and training, all the data. So confidentiality is also a part, apart from the recording. Confidentiality is a core principle of the GLP to protect the integrity of the non-clinical studies and the sensitive information of it. So all the recording of all the study should be confidential. GLP emphasizes the confidentiality to maintain the integrity of the non-clinical studies and prevent the misuse of the unauthorized also the disclosure by the commercial valuable information. So confidentiality agreement must be there. All the personnel involved in the GLP regulatory activities, including the inspector, auditors, are required to sign the confidentiality agreement. Who will assess physical or electronic data that should be proper documenting? Data protection, that is very, very important. The electronic records are protected using the industry standard security and measures. And paper files also the secure with the appropriate physical access control systems. So it has a electronic storage, will increasing the migrate paper documentation. Such electronic records will be ensured with their integrity. Information technology systems will implement the appropriate access control tactics. So first is the electronic storage. The second is the paper records, because 100% is not an electronic storage. Some documentation must be there, and that should be also confidential. It is protected. Also the third party access. Sometimes the softwares are SANAs that filed during the mandatory audits. Who will access it? Definitely should be recorded also, should be documented also, who has power to access. The classification of the client who will be informed. No other individual has the proper access information. Apart from it, consent should be there. So confidentiality is also very part. So we have seen the recording apart from confidentiality in GLP. Apart from it, the audit is the one of the most important, the key factor with the laboratory success. So good laboratory practices is one of the most important part of the quality and integrity of the data generated by the laboratory testing and analysis. So GLP is a very critical component of the quality assurance also with the reliability, accuracy, and the reproducibility. So audit tools in GLP, it is very, very essential that audit tool should be standardized. It is documented, used to evaluate and verify that laboratory operations comply the GLP practice, the regulatory requirements also. So there are many tools in the GLP audit. It starts with ensure the compliance, data integrity, quality assurance, error detection, improved efficiency, regulatory compliance, risk reduction, enhanced reputation, increased confidence, and the continuous improvement in the study. So that the various types of the audit tools you can see. The first is the qualitative GLP audit tools, quantitative GLP audit tools, statistical, document review, observational, informational technology, and risk-based GLP audit tools. So it starts with the first, which is the qualitative audit tools. In GLP, it has many components in it, like GLP checklist, SOP review template, the personal training record, the quality assurance program review, the laboratory inspection checklist, personal observational checklist. So the auditor will see all the parts which is described here. That is a qualitative audit tools. The next is the quantitative GLP audit tools. It means various statistical tests, means histogram, the fishbone diagrams, the pie chart, the bar chart, the scattered diagram, various statistical methods, control charts. So it is a quantitative GLP audit tools. If they are reliable or not will be checked by the auditor. The next is the statistical audit tools, which is a specific part for the various statistical tests, what you have applied, like ANOVA, like regression analysis, multivariate analysis, p-value, hypothesis testing, statistical process control. So there are variety of the statistical test is specified, audited by the auditor. The next is the documentation review audit. As we have seen, that many records are there, SOPs are there, will be audited by the auditor. Raw data, study protocol, study report review. So all the checklists should be there and should be re-verified by the auditor. Observational GLP audit tools. It means that the laboratory observational checklist should be there. It is also shown that how it works. The documentation is must for all the laboratory observational checklist, personal observational checklist, and equipment observational checklist. It should be proper. It is checked by the auditor. Another is information technology GLP audit tools. Means the data integrity, it is there or not. System validation, it is there or not. Electronic data record, it is proper or not. So that will be audited. Risk-based GLP audit tools means the risk assessment matrix. It also involves the failure mode and effect analysis, that is FMEA. Also, it involves the hazard analysis and critical control points, HACCP. So apart from it, it is audited, risk-based audited. And the last is other audit tools, means equipment calibration, maintenance of the records, corrective and preventive action review, also the supplier qualification, and also the audit of the supplier. So auditors use these different tools to evaluate how the GLP is working, how the good laboratory practices is working in your lab. With the programs such as data analysis, extraction tools, various Excel sheets, databases, access, statistical other analysis, other tests, generalized audit software also available like ACL, Arbitrus, EAS, or the business intelligence like Crystal reports and business objects. So we have seen three parts of the presentation. First, how you record. The best part, the whole data should be recorded. The whole study should be there with the proper recording. Apart from it, electronic, digital recording. Also the confidentiality and also the audit part. So thank you so much for your kind attention. And if you have any query, definitely you can ask.
Thank you so much, sir.
So GLP is basically a part of GCP. I think we have all about heard GCP. But also a part of it, it is interconnected. That is also a GLP.
Thank you so much, sir, for sharing your knowledge on record keeping, the audits, and how to present the records with maintaining the confidentiality. So thank you so much for joining with us. Now moving ahead with our next speaker, Dr. Manoj Kahar. I hope I'm audible to you, sir. I'm making you co-host.
Am I audible to you, ma'am?
Yes, sir. Now you are audible.
I can share my screen now.
Just a minute, sir. I also would like to extend invitation to Dr. Mukesh Gohel. Can you just try once muting and unmuting of your speaker? Dr. Mukesh? Hello, Mukesh, sir? I cannot hear you, Mukesh, sir. We can solve this query later. We will proceed with Dr. Manoj Kahar, sir's presentation.
Can I share my screen, ma'am, now?
Yes, sir. So it is my privilege to welcome Dr. Manoj Kahar, sir, on the virtual dais. He's a highly accomplished professional in the field of laboratory medicine, holding both an MD and PhD in pathology from Government Medical College, Surat. He is also a certified specialist in transfusion medicine and stem cell transplantation with advanced training from the British Blood Transfusion Society and the University of Manchester, UK. Currently, he serves as the lab director of the NABL accredited Bhanumati Clinical Laboratory, Navsari, and is also a consultant at Shushrusha Blood Center. With 24 years of extensive experience in various disciplines of laboratory medicine, his contribution to private practice has been both consistent and commendable. He is recognized NABH assessor in blood banks since 2012 and was the first to clear the AATM transfusion medicine exam. In 2021, Dr. Kahar has authored several papers in national and international journals and is respected faculty member for online courses on quality assurance, clinical chemistry, and ISO 15189 implementation by MEU India. He has also been a guest speaker at state and national conferences. His expertise spans transfusion medicine, histopathology, and quality assurance. He is also an active member of esteemed professional bodies such as GAPM, BBTS, AATM, ISBTEI, and ISTM, and others. Today, Dr. Manoj sir will share his valuable insights on the topic reporting results, analytics, content, and quality, a crucial subject in ensuring accuracy and reliability in diagnostic practice. I'm honored to welcome you today on this dais. Thank you so much, sir.
Ma'am, is my screen visible?
Yes, sir.
Should I go to the full screen mode?
Yes, sir.
Is it okay now?
Yet not. Yes, sir.
Is it now okay, ma'am?
Yes, sir.
So should I continue with your kind permission?
Sure, sir.
So at the outset, let me thank to the organizers for inviting for me in this online session on good clinical laboratory practices. And the topic assigned to me is a very simple one, that is reporting results. And during this talk, okay, so what we will discuss here are total testing process and the laboratory issue, that is how we issue a laboratory report, and then post-analytical errors, how much percentage they contribute to the total errors, then requirements of ISO 15189, the latest 4th edition. Then I will give you a insight into a very good guideline which is published by eHealth Network Guideline. Then contents of a laboratory report. What is the need for harmonization in terminology, units, and reporting of laboratory results? Some insights into reporting of reference interval, decision limits, reference change value, measurement uncertainty, and laboratory reports. Interpretative comments in laboratory reports, different ways of presenting laboratory results to physicians and patients, integrated diagnostics and integrated reports, artificial intelligence in the post-analytical phase, and then some concluding remarks. So this is our agenda. So when you see, we perform any laboratory test obviously to obviate or negate a diagnosis based on the clinical findings, to monitor the effectiveness of a treatment, to determine the progress of a disease, to screen a population that may be a random or a focused population for a particular disease. And as we all know, lab reports are issued based on the analysis performed, and they are an effective way of communication with the end user, be it a clinician, patient, insurance company, or government sector. The end user may be anybody, clinician, patient, insurance company, or a government sector. And as we know, our laboratory input ultimately leads to the patient satisfaction. Is my arrow visible, ma'am, to you on the screen? Hello?
Hello?
Is my
Yes,
arrow
sir.
visible to you?
Yes,
Is
sir. You can show it again.
Is the pointer visible? Laser pointer?
Yes, yes, yes. It is visible.
Okay, thank you, ma'am. So your laboratory input ultimately leads to the patient satisfaction. And in between, we are giving a lot of things. We are giving the laboratory test results. Then that based on that information, the treatment may be adapted, may be changed. There are some medical decisions to be taken, and ultimately that leads to the patient satisfaction. Okay. So as we know that the laboratory has the total testing process, and it starts with patient, ends with the patient. So as the clinician sees the patient, he has a clinical question, and based on that clinical question, based on the examination, he will select a test. Then a specimen is collected, transported to the laboratory, sample preparation, analysis. Then we interpret the test and then issue the result. Now this result can go to the clinician, or the patient can have direct access to your report. And this direct access to the patient in Western countries, that may be web-based or other information sources. So if you see, this part is in the patient care setting, and this part is in our area. And today we are focusing only from here to here. Communication between the laboratory and the physician or the clinician, or maybe in some instance to the patient. A second concept is brain loop to loop. So it starts from your physician's brain to your laboratorian's brain. And the physician, he will communicate to the laboratory through the ordering. Then you have the collection, identification, transportation, preparation, analysis, and report. So your through the laboratory report, you are communicating with the physician your interpretation of the analysis what you have done. So your piece of paper which you are sending to the physician or maybe to the patient contains lots of important information. And that's a very effective way of communication with the physician as well as the patient. Now, when you see the errors in the different phases of the laboratory, there are different phases. And this I have taken from a very good paper by Mario Plebani. And I request and to all of the attendees, they have a look at this paper. The detection and prevention of errors in laboratory medicine. It's in Annals of Clinical Biochem. And if you see this table, Mario Plebani has distributed the errors in pre-analytical, analytical, post-analytical, and post-analytical. So if we take the laboratory reports, we are somewhere here in the post-analytical phase. And if you see this is contributing about 12.5 to 20% of the errors. And these are erroneous validation of analytical data, failure in reporting, addressing the report, excessive turnaround time, improper data entry, manual transcription errors. These are very, very important things. Improper data entry, manual transcription error. Yesterday I had a case. The total WBC count was 8,000 and the lab technician C typed 800. So that's a manual transcription error. And if that report is issued, it can create unnecessary problem. We have to withdraw again the report, convince the doctor, convince the patient that that was a typing error. So lots of issues they arise if you don't do proper data entry and there are some manual transcription error. Then failure and delay in reporting critical values. So all this is post-analytic and they contribute a quite amount of errors, 12.5 to 20%. This is also very important paper, and this states the harmonizing the post-analytical phase and focusing on the laboratory report. And the final post-analytical phase of laboratory testing is increasingly recognized as fundamental step in maximizing quality and effectiveness of laboratory information. So as I showed you the loop-to-loop, physician's brain to laboratory's brain, there's a loop, complete loop. And in that total testing cycle loop, we need to improve upon the laboratory report that we issue to the physician or to the patient. Now, when you generate a laboratory report, there are some essential things which you need to compulsory. Essential needs to be mentioned in the report. There are patient identification, data, sex, age, date of then date, time collection, nature of the specimen, analytical results. Your report which you prepare and the data which you put on the report, it should be is such a size that it should be suitable for incorporating in medical records. So nowadays, in most of our corporate hospitals and bigger medical colleges, we have electronic medical record system, EMRs, and in that EMRs, your medical laboratory reports should be they must be acceptable to that system. You should not provide too much data in your laboratory report, which can clutter the system. And then you should have an indication of abnormalities. These are the essential features which need to be mentioned on your laboratory report. These are the additional features which you can use, and these are cumulative formats, then analytical confidence limits, relevant conditions, warning of any drug interference. Say example, if you are doing a vitamin B12 assay and it comes quite high, then you talk to the clinician or you talk to the patient and see whether some injectable vitamin B12 has been taken or not. And that can be a drug interference in your analysis. Then space for interpretative comment, attractive, uncluttered appearance. So don't put too much information in your report where that some additional report can hide your necessary information. Now, ISO 15189 4th edition 2022, it has also requirements. And 7.4 talks of post-examination process, and this talk 7.4.1 talks of reporting of results. And it very categorically states that examination results shall be reported accurately, clearly, unambiguously, and in accordance with any specific instructions in the examination process. And the report shall include all available information necessary for the interpretation of the results. And if there is any delay, we have to notify the users. And if you see this 7.4.1.6, it has all attributes of reports mentioned in it. So this 7.4.1.6, it gives you A to M, what should be in your report. And these are unique patient identification, date of primary sample collection, date of issue, identification of the laboratory issuing the report, name or other unique identifier of the user who is going to use it, that person's name, or maybe some identifier, type of primary sample, specific information, and this already we have discussed. Then what was the method used for doing the analysis. Then you have to use this electronic identification of the measurement and measurement principle. And these are some electronic identification things. This is one is logical observation, identifiers name and codes, LOINIC. Then this is NPU, NCG, SNOMED, CT. These are for electronic transfer. Then all examination results must be mentioned with units of measurement. Ideally, they should be reported in SI units, but unfortunately, in many laboratories in India, we still use the traditional units. This is not a proper thing. ISO 15189 says that it should be reported in SI units or other applicable units, but preferably SI units. Biological reference interval, clinical decision limits, likelihood ratios, diagrams, nomograms. Then identification of the person reviewing the result, authorizing the release of the report. If not contained in the report, readily available when needed. Then identification of any results that need to be considered as preliminary, indications of any critical results. So this 7.4.1.6, if you see A to M, it categorically states what should be in your report. Then there are some other additional report information that you can be providing in your report. Time of primary sample collection, time of report release, or some interpretive comments. Then if you do some amendment to your reports, then what are the procedures for the issue of amended or revised results? And 7.4.1.8 talks of it. Due to lack of time, I'm not going into all the details, but I would definitely request you to refer to the 4th edition of ISO 15189, and in 7.4.1.6 it states about the requirements of your result reports A to M. And then there are other points like 7.4.1.7 says additional information for reports, and 7.4.1.8 says talks about amendments to reported results. So you can refer it and then if needed modify your lab reports. Now, what are the basic constituents of any laboratory test result? So first, it should be an analysis test. What test you are doing? So if you see here, this is a blood glucose measurement. Then what is the specimen type? Blood. What is the specimen container? Examination technique, hexokinase. Anatomical sample location, from where the sample was collected. Then measure and quantity, mass concentration of glucose in patient blood plasma. What was the system which you are testing? Blood plasma. What is the value obtained? Interpretive requirement. So your result will have value and interpretive requirement. So these are the basic constituents of any laboratory test result. Now, this I am giving you, sharing one of the report from a well-known foreign laboratory, and this is from Center of Immunology and Microbiology. And what they have done categorically, they have listed some of the tests in, say, humoral immunity. So this all tests will talk about or discuss about humoral immunity of the patient. This is infection immunity, right? So this is a test group panel for a particular group. So this is test for humoral immunity. This is infection immunity. This talks about autoimmunity. This is total IgE. Then they have put a note. The results should be evaluated in relation to the patient's medical history and clinical condition. Now, if you can see here, these are the observed value. These are the reference range. And this is the graphical assessment. If we take this HSV, IgG, then the result is 4.460 and the reference range is 0 to 100. So obviously this 460 is outside. So if you see the graphical, your point is here. So it is out of the reference range. So this is the result graphical assessment. So you can use such types of formats also, where you can club the test and then make a test group panel, either a test group or a panel, and then indicate that this is beyond your reference interval. So what is a laboratory test report? It is a combination of specimen information and results. Your laboratory report is a combination of specimen information and result. The report should contain information about unequivocal identification of the source, type of material analyzed, and the requesting agency. It may contain such other information that is pertinent to the correct interpretation of a result, where you mention the confidence interval, reference data, interpretive requirements. So this is a laboratory test result report. Now, what is a laboratory result? The laboratory result is a measurement unit, the final value which you are reporting for a measured or a computed quantity. So this is a result, and this is your results report. I would recommend to go to this particular guideline. This is freely available on the net. And this is EHN laboratory result guidelines. It's a very extensive guideline. And what they have done is they have prepared a complete guideline, and they are telling what should be in the report header, what should be in the report's body. And this guideline is talking of across the country exchange of laboratory results. So sometimes some foreigner has come to you and you have done the laboratory test, and that person goes to his native country. Now that native country physician will see your report, and he should be able to understand what you are stating or commenting in your report, what information you want to pass. That should be clearly made available to him. And in this guideline, they are giving everything in detail. Many of these slides I have taken from these guidelines. So I sincerely request to all of you to go to this ENHL laboratory result guidelines. They are freely available and very nicely written. And report header should have, I'm not going to read each of them, but there are very important fields they have given. And these are family name, surname, given name, date of birth, personal identifier, then gender, address of the patient, telecommunication if you need to contact the patient for any further information you need. Then if the report is going to some health insurance company, then health insurance person, health insurance code, health insurance name, insurance number. Then these are for the recipient who is going to receive a report. So recipient identifier, recipient name, recipient organization, which hospital, which clinic, address of that hospital, clinic, country of the recipient, telecommunications. Then who is authorizing this report? Author identifier, author name. If it is directly from a equipment, then the device name, its particular details, author organization. Legal authenticator identifier, legal authenticator name, legal authenticator organization. Who is validating the result? Result validator identifier, result validator name, result validator organization, validation date and time. Then documents ID, type, status, report date and type, document title, study type, what was the study performed, who will have the custody of the report. Dr. Harsh Joshi sir also mentioned all these points, report custody and confidentiality. Then language, because sometimes some of the countries, they prepare the reports in their vernacular language, and this particular guidelines has some sample reports also. Unfortunately, in these guidelines also, the sample reports were either in Swedish language or in Estonian language, and therefore unfortunately I could not take pictures of that sample reports because they were given in their vernacular language. But if you see those samples in these guidelines, they are very beautiful samples given for how to prepare a laboratory report. But the language was very different, so I didn't take the pictures of it. Version of the document. Then this is the for the report body. Earlier that was for the report header. Now this is a report border. Order ID, order date and time, order placer identifier, who ordered the test, order placer contact, order placer organization, problem diagnosis description, specimen identifier, types of species, material, collection period, dynamic location, from where the specimen has come, especially in context of histopathology. You are getting the lymph node from right side or left side, or maybe you are getting right testes or left testes, or right ovary or left ovary, left fallopian tube, right fallopian. So laterality is also very important. And many times there are issues in this laterality. Once I had this big problem with me, and I reported a breast cancer in left breast. Only that was only left cancer in the left breast, and the return requisition form was mentioning lump from left breast, and I reported it as a breast cancer. The patient came to me and she said that my left breast is okay. This is from the right breast. I was in a fix, and then I had to retrieve the test request form, and then I had to show her that then here it is written that it is from the left breast. Therefore, I have reported. So laterality very important. Morphology, source device, collection procedure method, receive date, everything is important. And then if you are narrating histopathology and cytopathology, you describe your findings of the microscopic findings. So that becomes a narrative report. Then comments, interpretation, recommendations, and then your observation date, code, observation name, original name, display, method, device, order, performer, who performed the test, reporter, observation result, observation interpretation, result description, accreditation status. So all these, what I've shown you, they are taken from this beautiful guideline, this one. And I request that you all of you assess this and have a look at it. It's a very beautiful guideline. Okay. Now, when you share the report with different healthcare professional, then there is a need for standardization of the terminology which you use. So, for example, if you are doing a culture, then you have to mention that this is the microbiological culture of a specimen. You are culturing a bacteria. Then examine properties, mass concentration of albumin in blood plasma, types of specimen, whether you take an arterial blood, 24-hour urine, cerebrospinal fluid, anatomical location, skin of left knee, very particular, skin of left knee. Analyze components or elements such as sodium, alanine, transfusion antibody, kind of measure property, mass concentration, volume, number, fraction, rate, frequency, mass, etc. Results for nominal and ordinal result values and the units by which the value is presented. So sometimes we give the results in nominal way or in ordinal way. So this is a slide which explains what is the difference between a nominal data and ordinal data. Nominal data means just you have the suppose these are examples: gender, woman or male, religion. So there are no numerical values. There are no numerical values. They are without any type of quantitative value. When you say ordinal data, then we can assign numbers to ordinal data, but we cannot arithmetic with ordinal numbers. And then they can be first, second, third, or you can have, say, example, elementary school, high school, college. So this is ordinal data and it have numerical values. Nominal data do not have any quantitative values. From data to information. All aspects of laboratory service across the total testing process ultimately depend upon the concise, reliable communication. Data are numbers, magnitudes, entities, and facts, such as our laboratory test report. Result. We have analyzed the specimen, obtained a result. Now, this information, you have generated a data, and this data should be converted into information. It should be converted into information, as data without interpretation are facts without understanding. So our laboratory results should always have some comparators, like reference values, decision limits, interpretative comments, and your data must be actionable. Based on your data, based on the information you provide, the data must be actionable. From the user's point of view, whether it is a physician or patient, the conversion of data into useful information is the only thing that counts. They are least interested in our values. They are interested in the final information that we are giving to them. As a laboratory professionals, obviously, we assure accuracy and reliability. Above and over that, the notification of analytical results must be accompanied by other essential tools that enable right interpretation and utilization of laboratory information for the clinical decision-making process and patient management. So your data must convert into information, and based on that information, some actions are to be taken by the physician. There are risks of error in current reporting, and these are related to different units, reference intervals, chronology. Say, for example, hemoglobin, the recommended date you have to report in gram per dl, but most of us will report in gram per dl. This is to be reported in gram per liter. These are the right units, but if most of us report in gram per dl, there is a very tenfold difference. Many drug and hormone assays are frequently quoted in different units between laboratories, states, and countries. Failure to understand the method difference in results. Say, for example, if you are doing some assay and somebody is using rapid immunochromatography, somebody is using ELISA, somebody is using CLIA, somebody is using NAT. So the physician and the patient should understand which method is being employed and what are the pros and cons of that method. So your results should categorically mention what method is used, which kit you have used. Everything should be mentioned in your report. Then for infectious disease markers, there are various units used, flaggings, there are variation. So all these things need to be harmonized. Say, for example, I have given you here, there are different drugs, and they can be reported in molar units, or they can be reported in mass units, and there is a conversion factor where mole to mass is converted. So you have to be very particular and mention this, that I am reporting in molar units, and if you want to convert it to mass unit, this is the conversion factor. So what I was discussing in the earlier slide, terminology, units, and reporting, how harmonized do we need to be? It's a very good paper by Robert Flatman, and again, I will request you to go to this paper, and this paper tells us why harmonization is needed in the terminologies, units which we use in our laboratory, because the differences can create some errors that can lead to misinterpretation of results, misinterpretation of result quantities, failure to understand methodological difference, misinterpretation of chronology. There are variations in flagging, lot of problem. So we need to harmonize our reports. Harmonization in terminology that we use, units which we use, the way we report. Now there are two things. One is reference interval, and another is clinical disease limit. So let us understand what is the difference between reference intervals and clinical disease and limits. This both can be put on our laboratory reports. So if you see this reference intervals, there are statistical limits, and usually there are two values, while clinical decision limits is a critical threshold value, and it is one value. This is a biological characteristic of the unaffected population. These RIs, reference intervals, they are derived from unaffected healthy individuals, while they are derived a decision regarding a clinical disease. This is general population. This is clinical population. Based on general population, clinical population. Here you take 95% centered interval of the reference distribution, and these are based on clinical outcome studies, guidelines, consensus values, ROC curves, predictive values. These are defined by laboratory experts. These are defined by mix of clinicians and laboratory experts. These most prominent experts are laboratory, here clinicians. These are well-defined standards here, still to be developed. And again, more or less same thing I have given you here also. These are difference between reference interval and decision limit. And how to develop reference interval for a test, for a laboratory test in itself, it's a complete a presentation, and it's a huge topic, how to determine or how to derive reference intervals for a particular test. So I hope I have made you clear the difference between your reference intervals and clinical decision limits. So here is an example of a clinical decision limit for, say, lipid profile. So these are your clinical decision limits for total cholesterol, LDL cholesterol, and if you take HbA1c, then less than 40 millimole per mole, no problems of glycemic control. 40 to 47, gray zone, pre-diabetic. More than 47, less than diabetes, less than 50 therapeutic target. So these are clinical decision limits. They are not the reference intervals. These are not the reference intervals. They are the clinical decision limits. So you can, for those parameters where clinical decision limits are available, you can use them. Then, see, this is the issue of differing reference interval. We have an example of a lipase. Lab A is reporting a lipase of 150. Lab B is reporting a lipase to the same, say 145. If you see here, the difference is only of 5 UL. But if you take in context of the reference interval, here the reference interval they have given, lab A has given 0 to 100. So if you normalize, this becomes 150% difference. Here, this is 104%. So your reference interval also will lead to the interpretation. So please define your reference interval properly. If you take the analytical imprecision of lipase, it is very less, but because of this differences in the reference interval, the normalized results suggest a substantial change in lipase level if you go to lab A and lab B. Ideally, this is a very important statement. Ideally, there should be little or no variation in reference intervals between laboratories in the same geographic area where analytical methods are well standardized without some suitable documented explanation. So if you are working in if I'm working in, let's say, Western India, or say you are working in Northern Gujarat, or I'm working in Southern Gujarat, so the local population, there should be not much variation. So this is also an important line to be considered. There should be little or no variation in reference interval between laboratories in the same geographic area where analytical methods are well standardized without some suitable documented explanation. So reference interval should, in a geographic area, should not vary much. That is what this statement is stating. Now here, these are the parameters which definitely require gender related reference intervals. So male and female will be having different types of reference interval. These are the parameters where you need to derive specific pediatric reference intervals. So these parameters, definitely you need to have a pediatric reference interval, and it is very difficult to establish pediatric reference interval because you will not get a normal healthy pediatric baby coming to your labs to give blood. That is a very big issue to prepare a pediatric reference interval. So all these parameters, you need a gender related reference interval. For all these parameters, you definitely need a pediatric reference interval. Now, when we are giving some cumulative reports, and in that cumulative reports, we put columns. Now, your consultant, if you are working in a hospital, and he is used to your report format, and if you are putting your latest value on the right side, so he is used to seeing your report, and he will see only the last value on the right side, and he will interpret that this is the latest value. Now, unfortunately, sometimes the patient takes a sample to some other laboratory, and that laboratory is placing the current value on the most left. Now your physician who is used to see your report and is seeing the current value on the right side, he will be confused, and he may take an inappropriate action on the patient. It may happen. These are some human errors which happen because you are customized, you are practiced to see those type of report formats. So this chronology of reporting results, if you are giving cumulative reports, is very important. Laboratory A may show newest episode in the rightmost columns, while laboratory B chooses to do the reverse. Then it can cause problem for the issue. The Australian RCPA PITUS, Pathology Information Terminology and Unit Standardized, is a project by Australia. They recommend that most recent results should ideally be highlighted to reduce this interpretive risk. And your recent results should be in a bold, or it should be surrounded by a rectangular box or some other color code. So there are some variations in our report also. Where do we put the reference interval? Most of the laboratories, they put on the right side, some put below the analyze, some put on the left side. So please, there should be a harmonization in this. Every laboratory report should have your reference interval either on the right side, either on the left side, or below the value. That needs to be harmonized. The source and applicability of the reference interval. Most of us, we are using the reference intervals which are transferred from earlier years. When these reference intervals were derived, the technology was different. Nowadays, we are using a very high-end technology, and we need to have new reference intervals because the technology has changed, our analytical instruments have changed, and we need to derive newer reference intervals based on the newer technology and the state-of-art equipments we are using. We are having reference intervals which are being transferred from generations earlier. Then there are variations in flagging. Some they show arrows, decrease, increase. Some they show gradings in the colors, shaded colors. Multi-level flagging, some laboratories they use. Then flagging of critical result is a particular challenge. So most laboratory systems do not specifically flag critical significant results or report, preferring to rely on escalation to an additional urgent notification system. So most of the laboratories, what they do, if you have a very critical result, then you phone the clinician or the end user and inform them, and have a record on your laboratory that we have informed them telephonically on this particular time and date. If your consultant is not traceable, then you need to flag that critical result in the report also. Then there's one thing which is sometimes reference cell change value. And this reference change value are objective tools for assessing the significance of difference in serial results from an individual. And this simple tool is for using monitoring serial results. And RCB, this is the formula where Z, if you are using 1.96, that is probability 0.005. And if you are using 2.58, that becomes probability 0.001. And this is the formula for RCB. And this is your analytical CV, and this is the variation in the CV based on the biological variation database. Then you can give some interpretive comments in your laboratory reports. And for giving this interpretive comments, there are clinical drivers like patient safety, value of interpretive comments, quality requirement in international standards. ISO 15189 also says that you have to give the interpretive comments, physician satisfaction, new and complex laboratory tests, doctor's education. For this, you give interpretive comments. Technical drivers, we need to harmonize this. Financial drivers, competition between clinical laboratories. In my practice, I make a point that if I find something abnormal, then I write with my own handwritings in that particular report. And because of my own handwriting mentioning that problem in that particular test, my clinician, he feels assured that this particular thing has been categorically verified by Dr. Manoj Kara. So I recommend that those who are having clinical, private practice, or those who are reporting this clinical results or some extra information, interpreted comments, try to write with your own handwritings. That gives a major advantage. Okay, so I'll skip up this. You need to have interpretive comments, and these are factors favoring the use of interpretive comments. When do you do this? Introduction of new and complex tests, data on physician satisfaction, impact on clinical outcomes, clinical regulatory guidelines, increased communication of electronic data, competition between clinical laboratories, increasing use of expert system, interpretive algorithms need to provide an improvement in quality care. When do you give interpretive comments? Always. In such situation, you have to always give the interpretive comments where particular tests that cannot be interpreted by numerical data. Say, for example, serum protein electrophoresis, then you have to mention that this is the peak in this region, this is the region, this is the problem, this peak can be because of this many proteins in patient-specific situations or when requested by the clinicians. So interpretive comments may be given in such situation always in some patient-specific situation or when requested by the clinicians. Then there is concept of measurement uncertainty. ISO 15189 says that you do not mention, but if it is required, if it is asked by the clinician, then you have to give this measurement uncertainty. And this is the formula of expanded measurement uncertainty, which is this expanded measurement uncertainty is K, and K factor can be 2 or 3. 2 when you are taking 95% confidence interval, 3 when you are taking 99. Most of the time we use this 2 multiplied by 0.5 into your CVI that you get from your biological variation database, and your measurement uncertainty can be mentioned as a number. So if your result is 50, then plus or minus 0.5, or you can give it as a percentage, or you can give it as a range. So what I want to stress or make you understand is you are telling to the clinician that I am reporting 50 microgram per liter of this particular analyte. However, this analyte may be anywhere between 14.5 to 50.5. That is your message you are giving. I am reporting as 50, but this analyte can be anywhere between 49.5 to 50.5. That is measurement uncertainty. Then our laboratory recipients may be physicians, patients, insurance companies, government sector. So you need to have a format, and there are different ways you can report. So one of this is graphical presentation of trends. And here you are using, see, this is a table view. This is a RBC, this is a flag that your result is 4.4. Your reference age is 4.5 to 5.9, so definitely it is less. And the preceding day's result. What was the day before, 2 days, 3 days before? So this is the way. And this is your spark line. So if you see, the RBC counts are going this way. This is for hemoglobin. So this is your tabular form. This is this is a result. This is your unit. This is a reference interval. This is a flagging, preceding day's result, and spark line, all in one. Or still better, this is a result, unit, reference range, flag, bar chart with numerical results. This is a bar chart with numerical results. And then you can have a deviation Z log also on the same report. And for this, you need proper software systems. Then you can report also, give this radar charts also, where, see, this is your reference value, then this is your raised value, and this is a very raised value. And according to the clinical information provided and the tests which are you are doing, you can get a diagnosis, diagnosis A, diagnosis B, diagnosis C, and these are radar charts which you can use. This is comparison between your tabular representation and graphic representation. Here, data overlaid, important results may be sometimes masked. This graphic representation give you clarification, skews your interpretation, patterns in data are unclear. Here you get a very specific pattern, which as I have shown you, see, here you get a pattern, you are getting a pattern, right? So that becomes very easy for the doctor or the patient to understand. Highlights a trajectory, highlights key findings. So graphical presentation has its own advantages. Then when you are giving the results to doctor, you need to have an option to emphasize or de-emphasize your information. So if you see here, your platelets, they are 18. So you are emphasizing it. So sometimes some of the parameters you emphasize, some of the parameters you de-emphasize. Now, if you see, this is other type of reporting. This is a motion chart, and this is for hyponatremia patient. And these results are between 1st January to 8th of January. And this is urine sodium, this is serum sodium, this is urine osmolality, and this is serum osmolality. And if you see here, this blue line shows that the patient is under hyponatremia, low hyponatremia on these particular days. Now, this is a screen capture of the motion chart for hyponatremia clinical change. So what is the change? Again, same thing, but here clinical change. So very high hypovolemic, patient is hypovolemic, euvolemic. So all these days the patient was euvolemic. Here the patient is getting hypovolemic. So this is the advantage of reporting as motion charts. Sometimes your recipient of the report may be patient. So when you are giving results to the patient, they should be simpler form. See, this is one. You can give your result is here. This is a standard range. So patient can easily understand. And this is a simple line. See, this is a simple line. This is the block line where you have again divided the result to very low, low, borderline, standard range, borderline, high, high. So this is a simple line. This is a block line. And this is a gradient line. This was for platelet count. And now these are again standard range, platelet count, same thing. Same thing. I'm explaining for platelet count, for ALT, for serum creatinine. So this is a gradient line. So you can have simple line, you can have block line, you can have gradient line, and these are the gradient lines for three parameters: platelet count, ALT, and serum creatinine. Then this can be another way to give a report to a patient. How is my diabetes? So this is for 47. Good. This is for GFR. So this is the interpretive comment. Could be better. So you have to bring it. Could be better. Then cholesterol. So these are other way of reporting to the patients. For INR, vitamin D. So this makes easier for the patient to understand if you are issuing the patient reports to the patient. These are 10 recommendations when you are reporting the results to a patient. Whenever possible, provide a clear takeaway message for each result. Signal whether differences are meaningful or not. When feasible, provide thresholds for concern and action. Individualize the frame of reference by allowing custom reference intervals. Ensure the system is accessible. Provide converser tools along with the results. Design in collaboration with the users. Design for both new and experienced users. Make it easy for people to use the data as they wish. Collaborate with experts from relevant fields. So these are the 10 recommendations for when you are reporting the results to your patients. These are 5 rights for your laboratory report. Right turnaround time, right data validation, right units, right reference range, decision limit, right critical values, interpretative comment. These are 5 rights for laboratory information: right acknowledgement, right interpretation, right utilization, right follow-up, right documentation. Then nowadays they are coming with a integrative report where everybody contributes. Laboratory medicine, histopathology, cytopathology, molecular biology, radiology, other specific tests. So for a clinical condition, you give everything comprehensively in one report. And this is termed as integrated diagnostic report. Days are ahead, and maybe we will be in an era where we will, and this is useful when you are working in a bigger setup in a hospital. You have access to your EMRs, and you can sit with your consultants and design upon how to give an integrative diagnostic report. Artificial intelligence has come into play, and there are interactive machine learning tools developed to improve data aggregation, interpretation, and results reporting. And we are moving ahead in this direction also with AI. So summary slide conclusion. 40 years ago, Alan Ball stated that an unattractive, uninformative, or confusing report may fail to do justice to an excellent analytical service. Very important statement. You have done the test very nicely, perfectly. All your QC is okay. Everything is okay. IQC, well, everything okay. But if your report is unattractive, uninformative, confusing report, you are doing injustice to your testing. Unfortunately, relatively little effort has been expended on achieving the best possible report, and individual enthusiasm and initiative has led to widely diverse practices in reporting. And there is an urgent need for standardization of report formats. What I have discussed with you, harmonization is needed, and there is still a need to close the loop of the total test between the physician's brain and laboratorian's brain. We need to have a proper closure of the loop, and we have to improve upon the laboratory report format and how we communicate with the users. And harmonizations play a very fundamental role. And laboratory professionals, national and international scientific societies, and federations, they should strengthen their efforts to provide valuable guidelines and recommendations designed to improve upon both the laboratory report and its communication to the user. These are my references, and I will definitely request you to go to these two first references. These are very fantastic references which tell us how to prepare our laboratory reports, and these are other useful references, articles, which I used in preparing this presentation. Thank you. If there is any query, I will be more than happy to answer it. Thank you, ma'am. Over to you.
Thank you so much, sir, for sharing your screen and sharing your insightful knowledge. I would not say insightful, I would say a descriptive and so enlightening knowledge, where all the standards of how to present all the data, how to use the standardized units, how, and also you have shared your personal uh, what cases, instances where you have communicated with your doctors by sharing your pathological aspects of your views. So this has to be standardized, and of course you said in the conclusion the harmonized, the proper way so that it can be used everywhere universally. And also thank you for sharing the recent artificial intelligence perspective as well as the evidences to all the points you have covered. Thank you so much, sir. I I have not received any questions in the chat box yet, so we can conclude now. Now moving ahead with our today's session. So before we come to the other next sessions of the afternoon, my request to all the speakers, all the delegates, to all the judges and our GMC observer, we will take a 20 to 25 minutes of virtual lunch break so that we can complete our morning session. I hope all the delegates have enjoyed thoroughly and have an insightful session of the today's morning speaker session. After the break of 20 minutes, we will resume our speaker session featuring Dr. Mukesh sir, Dr. Pragnesh sir, and Dr. Jhalak ma'am. Once these sessions of 3 speakers over, we will move ahead with oral poster presentations of all the respective branches. I kindly request all of you that please make sure to join by 2 o'clock, by 1:50, that is the 2 mein 10 kam mein, so that we can continue the rest of the program and stay connected. See you all at 1:50. It's 1:25. We will take break of 30 minutes. Good afternoon, sir. Am I audible? Sir, we can't hear you.
Now audible?
Yes, sir. Now it's audible.
Okay.
You can once share the
So,
screen so that
yeah, I'm
before
sharing.
we start, we just have a practice. Okay, done.
Is it visible now?
Yes, yes, sir.
Okay.
You can stop sharing the screen for a few minutes. We will wait for 2-3 minutes and then we can
Slide is,
start.
slide is also changing.
Yes, sir. We are starting the session in just 2 minutes. I request all the delegates to request their colleagues to join as early as possible. Okay, so good afternoon to all the respected faculties, speakers, judges, all the delegates, and our respected GMC observer. I hope you all had a great lunch time. And now we are moving ahead with afternoon session. So further, it's my pleasure to invite Dr. Mukesh Gohil sir on the virtual dais. Who is currently serving as a professor and head of the Department of Biochemistry at NHL Municipal Medical College, Ahmedabad. And he also holds the position of consultant biochemist at SVP Institute of Medical Science and Research Center, Ahmedabad. He's a graduate of GMC Baroda. Dr. Gohil holds an MBBS an MD in biochemistry, and brings with him over 15 years of academic and laboratory experience. He is a recognized undergraduate and postgraduate teacher under Gujarat University and several other esteemed institutions. Dr. Gohel has completed both basic and advanced courses in medical education and is actively involved in academic leadership roles, serving as a member of Curriculum Committee and Medical Education Unit, MEU, at Nodal Center, NHL Medical College. He is also a Central Executive Committee member of ACCL MP and Zonal in charge of Ahmedabad at AMBI. His contributions to medical science include 16 publications in national and international journals, along with active participation and resource faculty roles in numerous workshops and conferences across the country. Dr. Gohil will be speaking on a very important topic, that is methods of validation and analytics, a subject critical to ensuring accuracy, reliability, and integrity in clinical laboratory practice. I welcome you, sir. Over to you.
Thank you, ma'am, for a nice introduction. I would also like to thank organizing team of Narendra Modi Medical College and team APPI Gujarat. So I will share my thoughts or my view on the method validation. Okay, ma'am, my screen visible?
Yes, sir. It's loading. Yes, sir. It's visible.
Okay, ma'am. So let's start actually my talk on method validation in laboratory. Particularly, I will mainly focus on analytical parts of method validation. Now, this is actually a topic of under the good clinical laboratory practices. And for good clinical laboratory practices, I would say it is invisible when you follow, but it is impossible to ignore when you don't. And whatever I say, I will justify at the end of my talk. So let's start method validation in laboratory. Now, so here on the screen, you can see the Goldsmith filter model for validation of any lab test. Now, whenever we plan to start any laboratory test, actually it undergoes the many filter of validation. It can be started with the administrative validation, then sample validation. See, administrative validation are ultimately include the cost of the test and whether it is feasible or not, etc., etc. Sample validation, which mainly include the sample volume, which type of sample you will use for that test. Then comes to the most important part, that will be the technical validation. Technical validation will mainly include the analytical performance of the test. I will today mainly talk about on the technical validation or the analytical validation of the any method or test. Then we go for the patient validation and clinical validation, whether it provide reliable clinical decision or not. Now, when you don't follow any of this validation on the nearby, you will see another model, that is a Plebany-Carriot study model for laboratory errors. So when you follow all the validation, ultimately good quality results can be produced. But when you won't follow this, may results in certain types of error, particularly the error in the, or if you don't follow technical validation, ultimately results in certain analytical errors, and which is ultimately results in a poor quality results. Now, when you want to start any new diagnostic test or any new diagnostic procedure, test or method for the analysis for that particular test. Now, that method cannot be directly used to perform a test here and report a result. But this method need to be validated first. So you need to validate that method performance. And then you implement the method and then you perform a test, and with check of quality control, you can result. If you find any problem in the quality control, you can again, to prevent such problem, again look for the implementation, and you will find any failure in during validation, you may develop the improvement and again go to the cycle of revalidation. So this is how any routine test or special test when started in the laboratory, it undergoes the cycle of validation. So next comes, what is validation? Validation means it is any analytical method is acceptable for its intended purpose. For example, I want to measure cholesterol, and that method must be able to measure the cholesterol, not others or any molecule similar to cholesterol. So that is need to be validated. So validation is a process of proving that any analytical method is acceptable for its intended purpose. Now, why we want to do the validation in the lab results or in a clinical practice? So this thing I will explain by giving one example. And this example is ultimately based on a case scenario. A very common thing we observed, even being a routine people also observe this thing. So this will be this case scenario we will discuss now. Now, before the go for case scenario, whenever you look at any lab value, so any lab value usually have some numerical number. Now, this number can be right, wrong, or close enough to right. So statistically, third one will be possible. Any number, for example, if you want to measure a weight, it is not like that every time you measure your weight 60 kg, 60 kg, 60 kg, 60 kg. No. It can be nearby that. Sometime it will be 59.5, sometime it will be 59.8, sometime it will be 60, 60.1, like that. So whenever you measure any number or any analytes, it is never you will find every time same or not too much deviated. But it is important that every time you will get close enough to the right. And that we termed it as a uncertainty. So uncertainty is actually a inbuilt property of any measurement. In laboratory, usually we perform the measurements. So simply we can explain this uncertainty is nothing, but it is a range of deviation from the true value. Actually, true value we don't know. But whatever we get, it is near to that. So this is very famous quote by the Berzelius. Whenever you go for any lab analysis, it is not to obtain the result that are absolutely exact. I will never expect it. But I will always expect that it need to be as near as accurate as any chemical analysis can go. And to achieve that, actually, we need the method validation before starting of any method. Now, these are the one case scenario or example which I want to discuss with you, and later on we discuss the method validation. So this will emphasize why method validation is very, very important. So this is some OPD scenario in which a patient comes to the physician for regular checkup, and physician order for lipid profile. Now in lipid profile, one of the tests is the serum total cholesterol. So here patient comes with the lipid profile results, and patient serum total cholesterol value was 250 milligram per deciliter. Now doctor think it is obviously more than normal. So he put patient on some intervention. Now this intervention can be in form of lifestyle modification or drugs, and then ask patient to revisit the doctor after 3 months along with the same test, lipid profile. And after 3 months, patient found that their cholesterol level was reduced, and it is at 220 milligram per deciliter. Now the main question will come, what doctor think or patient think? That reduction in cholesterol is because of successful intervention which doctor has done, that is a lifestyle modification in drugs, or it is due to analytical variation in the measurement. So let's see. So for example, so definitely you have to ask for the lab people. So lab state that their method imprecision in the measurement of cholesterol is 3%. Now, usually this measurement 3%, we usually measure it as a coefficient of variation, CV. And CV is actually SD by mean into 100. So if you convert 3% CV at 250 milligram, your SD will be 7.5. Okay. Now in lab, usually we considered as mean plus minus 2 standard deviation is an acceptable deviation for any test. So here, if you consider 3% CV, then standard deviation at 250 milligram mean, it will be 7.5. So if you convert mean plus minus 2 standard deviation here, so your 250 can be anywhere between 235 to 265. See, 250 is a mean plus minus 2 standard deviation. So 7.5 into 215. So 250 plus minus 15. So that is anywhere between 235 to 265. It is okay. It is a uncertain measurement. Similarly, your 220 after 3 months, it can be anywhere between 207 to 233 because your standard deviation at 220 milligram, it will be 6.5. So 220 plus minus 13, that will be 207 to 233. Now here you can see, first time when you measure, it is a 230, it is anywhere between 235 to 265. And second time when you measure, it is anywhere between 207 to 233. And obviously, these two values are not overlapping. See, one is a 207 to 233, and this one is a 235 to 265. So when they are not overlapping, it means this will definitely suggest that there is some reduction. Okay, but for example, if your method imprecision will be 4%, so you are doing at a 4% CV. So when you consider it a 4% CV, your standard deviation at 250 milligram, it will be 10. Because CV is a SD by mean into 100. Here you consider mean 250, CV 4%. So your SD will be 10. Here you can say your 250 milligram cholesterol, it is anywhere between 230 to 270. Because mean plus minus 2 standard deviation, that is our acceptable range. Similarly, your 220 milligram cholesterol, it can be at 4% CV, their SD is a 8.8. So 2 into 8.8, it will be nearby 18. So it is anywhere between 202.4 to 237.6. Now here you can see 202.4 to 237.6, and this one is a 230 to 270. So there are clear overlapping in a range of 230 to 237. So what I want to tell you here, your 250 milligram can be 230 also because of analytical variation. Your 220 can be 230 also because of analytical variation. So here, very important question comes, whether your cholesterol will be reduced due to intervention or it may be because of analytical imprecision. So conclusion is, in first case, it is definitely due to intervention because it was not overlapping, because your CV was very precise 3%. But in second case, when your CV will increase, when your imprecision of the method will increase, ultimately you cannot come to any conclusion. It can be due to both. It can be due to imprecision in the method, or it can be due to therapeutic intervention also. So this example will emphasize that measurement of the different imprecision, inaccuracy, everything in the method is very, very important. And that actually we termed as a method validation. Okay. So now we come back to the method validation. So it is the objective of the method validation. Why we want to do method validation? So because method validation procedure will quantifiably characterize my system performance. It specifically establishes accuracy, precision, specificity, sensitivity, and many more parameters. It also particularly give me, is there any error or not? So to assess the potential for error. It also identify method to method difference. So in the last lecture, I was listening about harmonization. So this will identify whether you need to harmonize or not. It also ensure method reliability in actual conditions. And even some of the accreditation and regulatory bodies or standards are also make it compulsory to do method validation. Now, for what you need to do method validation? When you require method validation. So you require method validation when you develop any new test or new procedure, particularly in-house developed method. Now, also if you want to have a standardized method, but you modify it Like for example, I will have certain test procedure for serum, but I want to do it from body fluid. So I modified the method because my sample is changed. So if I modify the methods, I need to change the reaction timing. So you need to validate it. After some major instrumental changes, or when you place any new system in a service, you need to do validation. Also, when you use standard method outside its intended scope. So same example I will take. For example, I want to measure it. I have the taste to measure it from serum, but I want to, or I measure it from the fluid, body fluid. So I need to validate that. At regular interval, to assess the ongoing system performance, particularly when troubleshooting questionable system performance. When you have some big question on the performance and you are going in a troubleshooting of that performance. So one of that way, you do extensive method validation, you will definitely identify the problem. And again, it is required as a part of regulatory or accreditation compliance. Specifically in India, we required it as for ISO 15189 2022 regulation. And when you go for NABL, also required by NABL 112. Now, what we check in validation? So there are certain key parameters that we check during the validation of the method. Now, these are the list of parameters. We will see one by one. So one is a precision. So precision means it is a repeatability or reproducibility of a test. Now what it means? It means, for example, I want to measure the cholesterol. So every time my cholesterol, for example, value will be around 200. So every time I will measure, it will nearby 200. It should not be like that it is 100 one time. So that is imprecision. Now accuracy. Accuracy means closeness to the true value. So for example, I will measure the cholesterol, whatever true value it is, it should be near to that. That will be the accuracy. Specificity means ability to assess the analytes in presence of other substance. For example, glucose is also there, cholesterol is also there. My method will be able to particularly measure the cholesterol. This is very important, particularly when we are measuring the drugs, because in drugs, the interference are very common with the similar drugs. But our method should be specific to analyze that particular molecule only. Linearity. So linearity means it is the ability to obtain a test result proportionate to the analyte concentration. For example, I want to measure a glucose. So my method will be linear enough to measure the glucose at lowest value also, like 50 milligram, to at higher level also, 600, 700, 800 milligram also. So that is my linearity. And based on linearity, I will decide my reportable range of a lab. So reportable range is a interval between the upper and lower concentration of analytes. Remember, reportable range is an analytical measurement range. It is not a normal reference range, which talked in the earlier lecture. So analytical measurement range will be decided by the lab. So at which range I will report the result. Similarly, limit of detection. So limit of detection is the lowest amount of the molecule that can be detected. This is particularly very, very important in qualitative, in a certain test where you want to detect it. Particularly the estimation of drug or trace element estimation, where this all are very important. Limit of quantitation. So limit of quantitation is lowest amount of the analytes which can be quantified accurately with appropriate precision and accuracy. Then robustness. So robustness means it is a method should be robust enough. It means it remain unaffected by small variation. And ruggedness of the method. It means method will be reproducible in different conditions. For example, different technician is doing same test, they have to give a same value, not different value. For example, if you give do some analysis in different instrument, it comes with the same value. Okay, so this is a ruggedness of the method. So out of all the key parameter, a few of the parameter for method and experiment I will discuss with you because of the limited time. Because very commonly we measured or we estimate the precision of the method and accuracy of the method and linearity of the method. So these three things need to be validated first. And later on, All these are need to be validated. Okay, but this is not very commonly, but these three things commonly people are doing that. And to estimate these three things, we must need to do certain experiment. Okay, now to estimate the precision, there is an experiment which we termed it as a replication experiment. So that I will explain you how to estimate the precision. So this will be done by a replication experiment. So replication experiment are very commonly used to estimate the precision of the test, or I can say in another way, to estimate the imprecision or random error in a test. How to do? So you will take same material. Which material you will take? So material can be standard or can be professionally available control material, or sometimes pool of the sample you can collect it. And this material you will do it for 20 times. When you do, so you can do it within a run. Matlab one time I will put a sample and I will repeat it for 20 times. That is a within a run. But it will not give you exact imprecision. It will give you short-term imprecision. You can also do in a within a day. For example, I will do it now. After 1 hour, I will do another hour. I will do. That is a within a day. But within a run and within a day will give you the short-term precision. But here, ideally, you need to do between a day. Matlab for 4 sample, 4 time I will do today, 4 time I will do tomorrow. So over a period of 4 to 5 days, I will complete whole exercise. Now whatever material which I will collect, what concentration should I select? So it need to be near the medical decision level. Again, what is a medical decision level? So again, it was discussed in last lecture. Medical decision level, matlab it is a decision at which some intervention will be take place. For example, for cholesterol, sir told the medical decision level, it is a 240 milligram. So that concentration you need to be selected, and it is of 2 to 3 different concentration should be taken. And with that, need to analyze or calculate mean, standard deviation, and coefficient variation. And then with help of all this thing, ultimately, you need to define whether these are performance are acceptable or not. How you define acceptable performance? Acceptable performance will be decided by guidelines, which is given by CLIA, that is a Clinical Laboratory Improvement Amendment Act. They have given for each and every test, they have given certain total allowable error. Matlab this percentage of the error is allowable because of measurement uncertainty. And for example, I will talk about cholesterol. So total allowable error for cholesterol is 200 milligram. Sorry, it is in a percentage. It is a 10%. So at 10% of total allowable error, here you can see if your standard deviation within run and within day, it should be less than 1/4 of total allowable error. So it must be less than 2.5%. Here, if you do between a day, where your total allowable, your standard deviation, which should be less than 1/3 of total allowable error. So in that case, it will be 3.3%. So this is how replication experiment can be performed, and it will ultimately estimate your imprecision or random error. If you get more than total allowable error, that case your method is not precise enough. So this has certain precision comparison between intra and inter assay. Now second experiment, that is between comparison of method experiment. Method, that is a different, this is a comparison of method experiment. Now here we usually see the accuracy. So this is very commonly used to estimate inaccuracy and systemic error. Now here what you do, so you analyze the sample by new method and comparative method. Your comparative method are usually reference method or already routine established precise method. And between these two, ultimately you find out the difference. How many sample you take? So you take 40 sample over entire measuring range. For each and every sample, you do single or duplicate measurement. Duplicate measurement is advisable, but single measurement will be more easily done. So you need to do within minimum 5 days should be there. Maximum can be 20 days. You need to complete the exercise between 5 to 20 days. And usually when you compare, you take a sample, you do with the both method, do within a 2 hours of each other to avoid sample instability. And then you obtain a statistical graph. So one side there is a result of comparative method, and on another side there will be test method results, and you draw a line. So that is a comparison plot. Based on comparison plot, you will derive different statistical value like slope, intercept, etc. And based on that, ultimately with this equation, you will find out the bias, that is a YC minus XC, and your bias plus 3 standard deviation, which we have derived it from replicate study. The total should be less than your total allowable error. So that is how you measure the accuracy. So see, this is the 2 method, both are overlapping each other, there is no bias. Here you can see one method will give you, like the series 1 method will give you little bit lower, and these are little bit higher. Okay, so here you can find there is an error. It is a systemic error will be there, or bias will be there, and it is a constant. Means at particular concentration and at higher concentration, error is always constant. For example, look at here. These are the comparison between 2 methods, and here the bias are proportionate bias. Means bias is more at higher concentration. And these 2 methods are there. There are no bias at all. Both are in acting in opposite way. Okay. So definitely there will be bias, cannot be compared. Also, you can draw a difference plot where all your difference plot are near to the center line, 0 line. Now the third experiment is a linearity experiment, which very commonly used to measure the analytical measurement range. For example, my lab want to report the result for cholesterol. At what range I will able to report it with same precision and same accuracy. So it can be anywhere between the 100 milligram to the 600 milligram. So I need to define that range. That is my analytical measurement range. So here what I will do, I will take series of sample with non-concentration, or even I have concentrated sample is available, then I will dilute it in a serial dilution. And I will take at least 4 to 5 numbers. And then what material I can use? Okay, now standard you can use prepared high level standard and then dilute it. Or nowadays linearity control are also available. So also you can use highest concentration sample and then you dilute it serially. This anything can be used. Dilute and diluent, which are very commonly used for dilution, is also very, very important, because ultimately you try to use of the same matrix diluent. Prepare a serial dilution, and then you need to do everything in a replicate measurement, and then you prepare a graph. So in one side there is an average of measure value, and at another side there is an average of the true value. And here you graph that you get it, that will be the linearity example. If you get it a straight line, this is your reportable range. Then interference experiment. Here you can get a value of a different interfering molecule. Sorry, you need to check whether different interfering molecule will be affect your method or not. This is particularly very important when you get the systemic error. In particularly, it is a constant systemic error you are getting, like we have seen in the graph. Now, what material you can use? You use a patient sample and divide it into 2 parts. And one part you will dilute it with the water. Second part you will dilute with the non-interfere. Now, non-interfere may be available as a chemical, or you can use, for example, if you want to check a hemolyze, interference of hemolysis, you use hemolyze sample or lipemic sample. That also you can use, but in particular specific amount. And remember, this should not be get diluted. Both volumes should remain equal. After that, you measure that particular sample in both, particular analytes in both. Like here, you measure the analytes. Here also you measure the analyte. And if you get the same value, then there is no bias. So these are the ideal situation. Then there are certain recovery experiments. Recovery experiment is also very important to estimate systemic error, particularly when proportional systemic error will be there. What to do? So it is similar to that interference experiment, but here you are adding particular analytes, and in another way you are only adding water. So for example, here after addition of analytes, you estimate that analyte, and here also in second sample also you estimate the analyte. So whatever amount of analyte you are added here, that should be reflected here. So you can see here 10A minus say 7A divided by 3A into 100. So ultimately you will get 100% recovery. So these are the ideal situation. Now remember, usually we perform first 3 experiments are very commonly people are doing. The interference and recovery experiment are only when you expect constant systemic error or proportional systemic error. After that also there are many experiments, but because of the constraint of the time, we'll limit it here only. So nowadays basic method validation toolkits are available, where everything you just need to enter the number with involvement of AI. And these are the final few points which is very important. So when you want to go for method validation, always follow structure parameter based approach. So you need to plan first. So first define what method you are using, which parameter you will plan for method validation. Then perform. So perform as per experiment which I told you, and analyze by appropriate statistical method, report it out everything, and then approved by concerned authority. And after that, that method can be in use. Document everything, and whenever you find any problem, you need to go for revalidation also. So validation is very important. It always ensures quality and credibility to the lab results. And now comes to the last point, and that will be someone also asked the question, difference between method validation and method verification. See, actually method validation is actually very broad term. So whenever you plan any new method or you build a new method, you need to validate it. But method validation is a shorter process which is required when you already use any standard unmodified method, but you need to just verify whether that method will be their method will also come with the different performance characteristic. But in method verification, you just verify all that performance characteristic will be confirmed in your lab with the same standard unmodified method or not. So that is a method verification. So method verification is a process of confirming standard unmodified method which perform as expected in your lab. So it apply to all commercial available standard method used for particular intention by the manufacturer. So purpose of doing method verification is to confirm the lab can reproduce the manufacturer claim performance or not. So it typically mainly involves the 3 things to determine accuracy, precision, linearity, and reportable range. Again, based on the risk and complexity, you can also do the other things also. So it is a less extensive, easy to do, quicker one. And whenever you start any new standard method in your lab, you need to verify their performance characteristic. It is also required in clause 7.3, 1.4 for standard method in ISO and ABL also. So here I will end my presentation. And so any question, there are certain questions will be there in the chats, but I could not get it because of the continuous presentation. Now any other question can be asked. Like one question I already, that is the difference between the method validation and verification. Ma'am, over to you, ma'am.
Sir, another question is there. Dr. Manoj sir has asked, do you have any recommendation for kit for doing linearity experiment?
Actually, all recommendation, actually my whole presentation, I forgot to mention a reference, but my whole presentation, I have taken it from the WasteGuard. So there are already recently book available on the WasteGuard regarding the method validation. where the references, so all the references, ultimately it is a Westgard group, Westgard methods on basic method validation.
Okay.
So you can just visit the Westgard website, and there are also 2 books are there. Actually, both are purchased book, but I have the copy somehow. So my whole presentation will be from that only.
If you don't mind, sir, if you can share that with the speaker group, I will share with the other speakers as well, and also with.
Okay, ma'am. Yeah, sure. I will share the whole book.
Sir is asking. He's asking about reagent kit.
Reagent kit. So with the same reagent, actually, we are performing linearity experiment.
Okay.
So whatever the reagent, for example, cholesterol reagent we are using, so we are using the same reagent. Reagent kit, I don't know, that is the same method which I should use. Same reagent I using for method validation. Sorry, for linearity check.
Dr. Manoj, sir, I have made you unmute. I have unmuted you. You can ask your question directly.
So,
Yes,
sir,
sir.
Mukesh, sir, my point is, I'm
Yes, sir.
getting your point.
Huh.
I have all these method validation books from Westgard. I have QC books,
Okay,
everything.
fine.
My
Nice, sir.
question is,
Okay.
for linearity, you need to have different types of levels of samples during the complete
Yes, sir.
entire range. So there are few
Yes.
in international markets, sir, where they provide
Yeah.
you samples of varying concentrations. You are getting my point, sir.
So that is what,
They are
yeah, that is a linearity control. Yeah,
linearity controls.
there are linearity controls are available.
So I am
Linearity
asking
kits are
for
not.
anything which is such available in India, because in
Yeah.
international market they are available, but I could not search in Indian market, because to do this linearity experiments, sir, we need various very high concentration
Linearity control.
linearity
Yeah.
controls.
So
So
not easily available.
that's
Not
what I'm
easily
asking.
available.
That's what I'm asking, sir, because to do
Not
that
available.
linearity
We have
experience,
to ask for specifically. Sir.
ah,
At
that's
Biored Endox, the people they manage somehow. They once they give me,
but
but they have to manage.
they are not easily available,
Not
sir.
easily
My
available.
question is
Yes,
for
sir,
that,
not easily.
that
That's why.
that sample.
That's why what we do,
Hmm.
we take the patient sample, highest concentration. Sometimes we get it now. We take it that.
But
That
sir,
we dilute it.
say for example, you take triglyceride. To get a sample of triglyceride of more than 1,000 is not a routine thing. You hardly get in 6 months.
Yes, sir.
Or 1 year.
Hmm.
In a small scale laboratory, to get a sample of triglyceride more than 1,200 or 1,500 is not a simple task, sir. That's what my
Not
question.
a simple, definitely, sir. But when we get it now,
Hmm.
because this is also the one-time task, once in a year, or that is we do it. Otherwise, not a routinely we do.
And my other question is,
Linearity experiment. Yeah.
my other question is, sir, how frequently we need to verify the manufacturer's claims? As I have been telling, validation is already done by the manufacturer, and the manufacturer gives his own claims in the
Gives
kit
it
insert.
everything. Yeah.
They give the
Yes.
precision, imprecision, accuracy, inter-assay, intra-assay, literature. As an
Yes, sir.
end user, I have to verify it. My question is, how
Yes, sir.
frequently we need to verify their claims? Because once it is okay,
Usually,
I will.
we do earlier 6 months, but in new NABL, they told it is your risk assessment. You decide at what frequently you can do.
But what is your recommendation? 6 months? Okay.
We do 6 months, once in a 6 month. Yeah. Again, depend my EQC and EQUAS performance, but we do usually every 6 months.
So my question is, verification is to be done every 6 months for a particular assay analysis.
Yes, sir.
Okay. Thank you, sir. So kind of you.
Thank you, sir. Yes, ma'am.
Okay. So thank you so much, sir, for your kind knowledge, and also it became very much interesting for the interrogation session. Now I would be thankful
ma'am.
to join with us, sir. Thank you, Mukesh, sir.
Thank you, ma'am.
So now we are moving ahead with our second last presentation of the speaker session of today's event. I am inviting Dr. Pragnesh Parmar, sir, and I'm making you presenter, sir.
Yeah. Thank you, Dr. Chaitali.
Okay, I'll take a moment, sir. So I would be very happy to welcome Dr. Pragnesh Parmar, sir, on the virtual platform today. He serves as an additional professor and head of the Department of Forensic Medicine and Toxicology at AIMS, Nagar, Telangana. A seasoned expert in forensic medicine toxicology, medical legal practice, and medical education, he brings with him a remarkable academic and professional journey. He holds multiple qualifications including MBBS, MD Forensic Medicine, GSMC Famer Fellowship, PGDHL, ACME, and AMAHA, underscoring his commitment to both medical science and education. With over 14 years of post-MD experience, he has authored around 100 scientific publications in esteemed national and international journals, amassing nearly more than 1,000 citations with an H index of 15 and I-10 index of 25, which is remarkable. His scholarly impact and teaching excellence have guided numerous MD and MBBS students, and he has played a vital role in shaping medical education policies as a convener and expert committee member for the National Medical Commission. He is an active contributor to the academic community, having attended 25 conferences, 30 workshops, and more than 33 CMEs, while delivering over 35 invited lectures at both national and international forums. He also holds key leadership roles in several professional bodies, including Vice President South Zone Indian Academy of Forensic Medicine, Joint Secretary South Zone Indian Society of Toxicology, Honorary Vice President Global Association for Forensic and Investigative Medicine and Sciences, Executive Committee Member Punjab Academy of Forensic Medicine and Toxicology. His outstanding contributions have earned him several accolades, including awards at IAMLE 2018, MLM 2021, Toxicon 16, PAF Metcon 2022, and many more. Today, he is going to speak and enlighten us on topic SOP chain of custody and logistics, a key component in maintaining accountability and traceability in laboratory and forensic processes. I welcome you, sir.
Thank you, Dr. Chaitali, for elaborated introduction. So, hope I am audible and my slides are also visible in full screen.
Yes, sir.
Yeah. So, good afternoon, everyone present here. And first of all, I am thankful to Narendra Modi Medical College and entire organizing team for giving me this opportunity to be present here. And the topic given to me is SOP. This is the word we are frequently using in our day-to-day practice. I am performing or I have performed this task as per the SOP. That is not my fault if something happen here and there. If you are stick to the SOP, you have one defense that I have followed the SOP. So today I will speak on SOP, that is a standard operating procedure, and a little bit on the chain of custody. So specific learning objective of today's session is we will see what is the SOP, what is the definition, and what are the need for SOP in various laboratory, either it is biochemical laboratory or clinical laboratory or any other laboratory. What are the tips and good practices in writing the SOP? How we can write a good SOP which can be understandable and applicable for everyone, and the process of document control for the SOP. Little bit we will touch upon chain of custody and challenges and future perspectives. So this is the overview of my presentation. So what are the SOP? Here you can see in this cartoon picture, the drop box has been dropped down by the person and he's saying that I just followed the directions. So here the written drop box, so he drop it down. So SOP is detailed written instructions to achieve uniformity of the performance of a specific function. So whenever we want to perform some function, uniformity is required, and we want certain laid down instructions which should be clear. So either I will perform that function or Mr. XYZ is performing or anyone else is performing, we will get the same result and the function will be accurate. So for that we require some laid down instructions. That is the SOP, nothing else. We have SOP for many things. SOP for delivering a lecture also, it can be a good. If we go to the Ministry of Health and Family Welfare website, we will find SOP for treating various diseases also. Same way, there are SOPs for performing the task in the laboratory. So do we need SOP? What are the reasons? So reason is there, requirement is definitely it is there. It bring consistency and uniformity. As I told you, whoever will perform that task, there will be some consistency or uniformity in that task. For that, SOP is required. It also enhance your efficiency and timeliness. Either I will perform or someone else will perform. It produce the efficient result and in timeline. And it can be act as a training tool also. When the someone is learning, if you learn through the SOP, then he become proficient in that also. Then whenever there is a personal turnover changing, now we see in laboratory most of the time laboratory technician MLT, they are many time outsourcing people. So outsourcing people, whenever they will get permanent job, they will switch over their outsourcing job and go to that permanent. So that frequent personal changeover is there. So if you have SOP, then other person can immediately learn or he can go through that SOP. Otherwise, when the person will change, his method of operating instrument will change and it will bias the result or result will affect. Second thing, SOP bring transparency in audit trail also, so it is very useful. And study reconstruction over a period of time, and it is one of the prerequisite for GCLP. Now we are talking, this entire theme is on good clinical laboratory practices. So if we want to establish or if we want to do GCLP, we require SOP for our most of the important procedures. So certain questions coming in our mind, like what are the questions an SOP should answer? So these are the elements of the SOP. It can answer as far as questions possible, but these are the basic questions. What has to be done? Who has to do what? So role should be defined. How it has to be done, when it has to be done, and where it has to be done. So everything is, place is defined, the method is defined, the person is defined, methodology, everything is defined, and what is our outcome, everything we can include in the SOP. Then and there it can be a perfect SOP. This cartoon is also saying that you see, oh no, I forgot to mention regarding the gloves, and he's doing the DNA analysis. So his own DNA will come in the sample. So these are the things we have to be very accurate depending upon the procedure. In certain procedure, certain step is very important. So we have to give emphasis on that. So depending upon the procedure to procedure, your drafting or component may little bit vary. So next question is, who should write the SOP? Who can prepare the SOP? So the person who is directly involved in the performance of procedure should prepare the SOP. It is not like that person who is not operating that instrument, then he is not knowing the intricacies of the instruments or reagents, then he should not draft. The person who is actually doing it, he has to draft because he knows the practical aspect. Then all the implications of the procedure he should appreciate and knows how to write the SOP. So these are the basic components that he must know and he can draft accordingly. Second thing, who should review the SOP? Who should validate the SOP or who should approve the SOP? Now the SOP is approved and now you can put it on our institute website or you can print out and keep in your laboratory. So all this step is required. First, the person will draft the SOP, one other person is review it, then internal and external validation, and then final approval. So we can say review should be done by the person other than the original writer. Suppose I have written some SOP, then I will not review by myself. So I have to give some other person. So some loopholes are there, then he will, or we can discuss and make it correct. And appropriate training and experience is also required, and you can get such experience and training when you do the work. Second step is the validation. So validation also is very much important, internal and external. Otherwise, sometime it will go in one direction. So test suitability for intended use by validation. It enables the modification if any modification is required. And time to time we have to modify also because we know this era is constantly changing. Though it is not that much fast in the medical field. But if we see the engineering field or AI field, daily it is changing. So we have to time modify also. Certifies, and the person who is validating will certify the quality of the document and he can say it is fit for purpose. Now we can go ahead. And finally, it comes the approval by the immediate supervisor, or if you have QA officer, definitely every institute now have QA cell, so quality assurance officer may approve it. So all these, either it is our medical field or any pharmaceutical company, they have also SOPs for each and every drug. They will check their quality assurance, quality control and everything. Then they have to follow the standard protocol and SOPs. Now, characteristic of an SOP. So ideally the SOP should be written in the clear and unambiguous manner. It should be clear instruction. There is no any confusion. Language must be also in understandable by the user. Suppose of end user is some MLT person who is not well versed with the English or some other language, then you have to think accordingly. You can put some diagram, instructions like that. And instruction is also easy to follow. You should review regularly the SOP and update the changes, as I told you, because whenever you find something in your audit finding, then you have to change the policy accordingly, or any policy changes occur, then you have to adopt it in your SOP. So it is a changing document. You can't say once I have made the SOP, now it is over, lifelong task is over. No, it is not a lifelong task is over. You have to modify as and when required. So SOP for what? So whatever procedure you are thinking it is key procedure or it will affect the result or benefit of the patient, then you can make SOP for that. Is it a routine procedure? So ask the question to yourself. If the procedure is performed inconsistently, will this affect the performance, safety, or the quality of process and data? Then you can prepare proper SOP, which will help to improve the standard. Now, how to write, review, revise, distribute, document control, training, all these things are very important things which you can include. Even sample handling, how to collect the sample, how to transport the sample, receipt and registration of the sample, processing of the sample, everything can have their own SOP depending upon your lab facilities. Analytical methods employed for equipment use and maintenance, management of supplies, data collection and documentation, archiving. So all these things depending upon you can, if you are using LMIS software, then you can use accordingly. If you are doing manually, you can do accordingly. So depending upon your needs, you can modify. It is not like that I will copy paste someone's SOP. Definitely you can have idea by looking the SOP, but you have to change as per your own laboratory needs. So ensure that all SOPs are available at the workbench. It is not like that your SOP is lying in the cupboard in lock and key. So whenever it is required, it is not there. You have just prepared just for the sake of preparation. No, it should be there on the workbench. So whoever is performing or handling the equipment, if he has any confusion, he can definitely go through it. There are some tips for writing good SOPs. So it should be written in a manner and language which is appropriate to the lab personnel conducting the procedure. And the sentence should be start with the action verb. Can do this or record like this. So that are the action word we have to use. Use pictures, flow diagram, as I told you, or example for calculation if it is needed. Get directly to the point. Avoid any wordy sentence. It is not like any novel or you have to put your articulated word or fancy word. No, it is a scientific document. So you have to stick to the guideline and it should save the time of the person who is reading it. We are not preparing any big article or huge article that it require so many things. Important point are needed and it should be complete, containing all the necessary information. It should be objective, containing facts, not the opinion, and coherent, showing a logical thought process and sequentially listing all the steps. Step 1 followed by step 2 followed by step 3. It is not like that you have written step 4 then comes step 1 then step 3, then it is confusing. The lab person, MLT person, or any other person who is performing the test or handling the equipment, he will confuse. Then effective writing, it should be clear and concise. Now you see one example is there, you should not use certain word like should be or like that. Here you see the unclear instructions are the weight of chemical A should be recorded in the lab notebook. So it is not appropriate. Clear one instruction is record the weight of chemical A in the lab notebook. So it is clear, there is no doubt. If you require furthermore how to record the weight, which instrument used, then you can lay down it properly or step by step. Now, level of detail depends upon the level of expertise of the individuals performing the work. If you feel like that the person is not that much well versed, then you can go in detail. If you know the person is already well versed, then you can cut short at certain level which you feel. Use generic terms wherever possible and avoid certain terminology like do this or alternatively do that or wherever appropriate or as per my opinion. Such type of words you should not frame in the SOP. It should be clear and concise. So this is the one format of the SOP. You can follow or do modification as per the procedure or the equipment you have to handle and depending upon your institutional policy also. For at least departmental policy, you can make one uniform format by which you can run. So title should be there, scope or background, principle or purpose, specimen collection if some points is required, reagent or equipment or any controls or procedure description, calculation, how to calculate, any limitations are there, reporting of results, normal range or standard or critical value if you want to give the input on that, applicability to other SOPs, glossary or definition, attachment, reference. This is one model of the preparation of SOP. Maybe some point may skip. If calculation is not required in your procedure, then that point will be skipped. So it depends. So what should happen before implementation of a new SOP? First important thing is preparation of SOP, validation, approval and everything. Then you have to train the person. The person who is going to operate the instrument must be trained via this SOP. Then and then you can start implementing. So staff to be trained on SOP prior to use, and training should be documented. Whenever you organize any training, document it. So on this date I have given the training. And if you feel like that retraining is required at certain re-interval, then you can organize it again. So it should be documented. So whenever any inspection occurs, you have data ready with you. With this many staff has been trained under the SOP on this date and time for this many days. Now again, we have to do the revised training on this date. So effective date of implementation of SOP must be after the completion of the training. Once the training is completed, the staff who is going to operate, then you can start implementing the actual SOP on the samples. So now the person who is handling and the SOP, so all the person should be trained on the SOP who is going to deal with, have access to the appropriate SOP, comply with the SOP and document and communicate any deviation from the SOP to the laboratory head or authorized designee. So that according to you can work, or you can have an idea whenever you are not getting the expected results. You can ask him whatever the loopholes in the SOP, either he deviated from the SOP or not, and according to that you can decide. Same way in the court judgment also, many of the time court will also ask either the physician has treated the patient as per the SOP or guidelines, we can say in that. If he's deviated from that guidelines, court will hold you guilty. Why you have not followed the standard protocol? So here also the same will work. So if we summarize this entire chain of event, then first you have to identify the need, which type of procedure require the SOP. Then draft the SOP. Then it should be reviewed by other person, internal and external review. Then after validation, then approval by the quality assurance officer. Then you can distribute and implement, train the people who is working under your laboratory. If any troubleshoot is coming, then you can update accordingly. So this is the continuous process. If you update, then again try to validate and do all the things. So it is little change may come accordingly. So final word on SOP, if we say SOP should be useful to the organization and employees, it is for us only, so we can achieve our goal. Document study methods effectively and efficiently. It support quality management and support staff training program. Because we know whenever we are doing some high-end work in medical field, it required quality. Definitely quantity has its own importance, but quality always has supremacy. So now India also definitely we are shifting towards our quality goal. So we have to maintain that quality. So SOP should not be documents which just exist, as I told you, in your cupboard, or only you are preparing because you want some compliance or some certificate from agency, either it may be NABL or NABH, or for the sake of preparing the SOP, you have prepared the SOP and now keeping in the cupboard, then it is not much use. If you are doing such hard work, then implement on the floor. So it will be benefited. Employee, patient, as well as the organization, all will be benefited. Now we will touch upon some part of the chain of the custody. As you know, chain of custody is very important. When we transfer the sample or giving sample from one person to other person, we have to follow proper chain of custody, or from one institute to other institute. This is very important. So it refers to the documented process which will record the possession of the samples, handling of the sample, transfer of the clinical sample, and prevent the unauthorized access or tampering. Particularly in our forensic field, in our forensic science laboratory, chain of custody is very important. Same way it is required in pathology also, biochemistry also. Many of the institutes are taking outside samples. So how will you ensure it is the sample of the same person, or it is either you have received the complete sample or incomplete samples? So many of the time you have to be very sure. So if we see sample collection and identification, then all the samples must be properly labeled with patient ID, date and time of the collection, and study specific information should be there. Unique barcoding system can be adopted if your laboratory is doing that. So it will minimize the human error and enable the digital tracking. Many times, you know, patient ID has been interchanged, so you will mismanage the report. We have seen many times such type of incidents may happen. So to minimize, you can use barcode system or any other digital tracking system for the same. Now documentation and record keeping. Whenever you hand over the samples, there should be a chain of custody forms which can design as per your need, must be completed at each and every stage of the sample transfer. Detailing of the personnel handling the sample, date and time and condition of the sample should be noted down. If your laboratory is using LIMS, as I told you, that is electronic laboratory information management system, then it is used for real-time tracking. You can track where the sample is currently. Sample packaging and transport. So compliance with International Air Transport Association And biosafety regulation is mandatory if you want to transport via flight or in other country, then it is required depending upon your study. Suppose you are doing some multi-centric study with international organization, so you have some foreign funding by which NHA or anything, then you have to follow that guideline if you are transferring the samples. Samples should be transported in validated temperature control container with tamper evident seals so that it will prevent the deterioration of the sample. And whoever the end person who is analyzing will get the accurate results. Courier also should be trained in GCLP to ensure the proper handling and transit details. Otherwise, during courier, it will be mismanagement. Now, sample storage and security. Biological samples must be stored in designated access control freezers and refrigerators depending upon the requirement of the sample. Either it is -20 is required, -80 is required, or -4 degree. Depending upon that, you have to preserve it with continuous temperature monitoring depending upon how many days you want to preserve. So according to you have to maintain the temperature log of that freezer. Access log should be maintained to track the personal retrieving or relocating the samples. If you are relocating one from one instrument or means one freezer to other freezer, that also you have to maintain the time and date. Audit and compliance. A regular audit should be conducted to ensure the adherence to GCLP and COC protocols. This is internal audit. Do internal audit. Don't wait for the external agency to come. Like NABL people will come at that time only we will see, or NABH people will come, we will manage at that time. No. Do the internal audit, regular internal audit. Non-compliance should be addressed with corrective actions as usual, including the retraining or updating the SOP where necessary. Now, what are the challenges and future perspectives? Human errors are inevitable. We know that training we have to provide adequate. So many times we are lacking in that. We are not organizing frequent training. So inadequate training of laboratory personnel can lead to errors in sample handling, documentation, and transport. As I told you, most of the time in many of the hospitals or even government organizations also, you find outsourcing people. So many of the time they have passed out from some private organization. They have not enough or adequate knowledge. They have never worked practical exposure in laboratory. So to train them is many times difficult. Regular workshop and certification program should be implemented to enhance the compliance and reduce deviations. Technological limitations are also there because every laboratory cannot have LIMS system. So you may work manually. You have to enter the data manually. So it depends. So you have to train accordingly or prepare your SOP accordingly. Now in future, we are knowing that AI is increasing. So integration of blockchain technology for real-time immutable record keeping could revolutionize this COC practice also. Chain of custody practice may change in future. Regulatory variability. Different regions and regulatory body impose varied requirements for COC management. So suppose our forensic, they have different things. So you have to follow that standard. Harmonizing the global standard through collaborative framework would streamline the laboratory operations and improve interoperability. Environmental and logistic constraints also we have to think. Maintaining the optimal conditions for sample transport, especially in the remote locations, remains a challenge. Many of the town now government is also enhancing the drone-based project. Like drone, you can transport into the internal villages. So from the villages, sample can be transported via drone to the tertiary care center. So we have to maintain how you can handle the sample properly. Even advanced biostabilization technique and improved packaging solutions can be explored by which you can properly transport the sample to extend the sample viability during the transport. So some type of many things are there by which you can improve or we can improve our performance. So SOPs also require and chain of custody and certain logistics to maintain that is very much important. So that's all from my side. These are the various references which one can go on. And thank you very much. Thank you once again to everyone for gentle listening.
Thank you so much, sir, for giving us a brief on detail about the SOPs that has to be followed, that has to be made appropriate to our institute and not to be taken care or copied of. Even if we are copying, we have to follow it thoroughly with taking care of all the points. And you have enlightened it on the very different perspectives. So thank you so much, sir.
Thank you everyone.
So now we are moving on to the last and final speaker session of the day. So it is my great pleasure to invite Dr. Jhalak Parmar, ma'am. I hope I'm audible.
Yeah, you're audible.
Just a minute, ma'am. I have made you presenter.
Yeah. Am I audible?
Yes, ma'am. So,
Okay.
Dr. Jhalak Parwar is a dynamic and promising young academician currently serving as an assistant professor in the Department of Pathology at Pramukh Swami Medical College, Bhaikaka University, Karamsar. She holds a degree of MBBS and MD in pathology, and she is quickly making her marks as a dedicated contributor to both medical education and diagnostic pathology. In addition to her academic role, she is a postdoctoral fellow in oncopathology at Newburgh Oncopath, Mumbai, and Anna Newburgh Reference Laboratory, Bangalore. She brings with her over 8 years of experience working in NABL accredited laboratories, where she has honed with her expertise in quality control and management, including EQC and IQC in hematology, clinical pathology, histopathology, and blood banking practices at Sri Krishna Hospital, Karamsad, Gujarat. She offers fresh perspectives, a committed approach, and an admirable passion for continuous learning and excellence in pathology. Today, she will be speaking on topic planning of the work, content, subcontracting, a crucial component of laboratory quality systems and workflow efficiency. So I warmly welcome you, ma'am. Over to you.
Thank you so much. Thank you, everyone. Thank you for such an elaborate introduction. And I'm happy to have this opportunity. I hope I justify the role, and I will try to be as concise as possible. I would be stopping my video now. And should I share my screen or should I share the PowerPoint?
You can click on the screen as well as PowerPoint, both, either of.
Okay. All right. Is my PowerPoint visible now?
Yes, ma'am.
Okay. So good afternoon, everyone. Good afternoon, all the students as well. Thank you for this opportunity. I would be talking about analytical planning of the work and ensuring its compliance with the new current guidelines of GCP and GLP, that is good clinical practices and good laboratory practices. Now, the committees that have formed this entire document, it was only GCP earlier. The good laboratory practices have been incorporated very recently. And being a pathologist, it is much more similar to what our NABL standards are, but there are some additional components to it. But this particular document refers to research laboratories more than diagnostic laboratories, but it is more or less the same. So here, with my presentation, I would like to highlight a comprehensive approach of analytical planning, where we are targeting on each component to provide an efficient, faster, and minimized error work. And it is about studying the different protocols, managing the subcontracting, and ensuring our data integrity, which provides a very practical strategy for maintaining the best standard possible in each and every setup, especially those concerned with scientific research. So let's go ahead with that. So how do you plan a study? So first of all, our objective should be clear. So any effort, if it is not framed structurally, would never result in a very good result, or would never give us a desired result. So for example, if the pharmacokinetic study of a drug is not done thoroughly, then we will never know the ADME profile of any kind of new drug. So it has to be a very structured framework. The next thing is timeline, that we have to be time bound. It cannot have an indefinite planning or indefinite period where you can keep planning. We have to define, before we plan on an analysis, we have to define the timelines about key milestones, and we have to also decide on deadlines and practical deliverables. For example, if I have to develop a protocol for testing of an HPLC sample, I have to decide that in how many months or in how many years am I going to finalize how this entire thing will work. So let's say I've listed the example in this PPT that for the first month, we will design the development. In the second month, we'll get the ethical approval. Because I work in a research institute, because I work in a medical college, we also have to take the approval from the ethics committee that if any research is going on, we have to be giving them an assurance that there is no conflict of interest here. Then data collection. Data collection is biggest issue. Whenever any research is going on, mostly it takes 3 to 6 months for a good data to be covered. And analysis. Analysis also gets a little on the detailed side, because once you have all the raw data, many aspects get highlighted while you analyze the data. That yes, you even start making new associations when you analyze the data. So uh, coming back to the main the plan, that is timeline, that each and every analytical plan has to have a timeline of decision. Then roles and responsibilities. One person cannot be doing all the tasks, and all the tasks have to be divided equally according to the ability and capacity of the personnel. And a principal investigator, for example, will oversee the study. The sample handling will be done by other team. Analysts will conduct statistical analysis in any study. Also, the next point is risk assessment, that potential risks and development of migration strategies is also very important at the same time, where there is risk of equipment malfunction or hazard within the working premises. Also, backup, instrumental breakdown. So we have to have a backup and regular maintenance for that. So when we have an analytical plan in action, before that, when we form that, so we have to understand that regulatory compliance is very important, that you cannot form a plan which is ideal but is not followable. We have to know our limitations as well. So this is just a triad, let's say the hierarchy, which states that first of all, we have to get the ethics. If you are working in a research laboratory, we all know that there is always an ethics committee that is there. We have to submit our protocol to the review to the board, who will review it, whether the study is feasible or not, whether this study does have an impact in patient management, let's say, for our medical laboratories, whether this is feasible or not, that has to be approved. Then we have to define standard operating procedures. I think Pragnesh sir has described it very well, how SOPs keep on modifying themselves. It is not a lifelong work that you have established once you have defined the SOP. As the diagnostic guidelines or the research guidelines keep changing. For example, earlier the lower limit of blood sugar levels was 110. Now it has reduced to 100. So the guidelines of diabetes management have changed accordingly. So same way for our diagnostic processes also, the guidelines, if they change, we have to modify our SOPs accordingly. We have to also modify the SOPs as per the upgradation of instrument. So established SOPs, if they are there, we have to follow, or we have to make a new SOP for all the procedures. And regular audits and inspections have to be done. Monthly Q&A inspections will be done to verify whether we are adhering to these SOPs or not. Because sometimes what happens, we form the SOP, but nobody is adhering to that. So application and practical aspect of that has to be looked by monthly inspection, monthly audit. We can do a vertical audit, we can do a clinical audit like that, and we have to adhere to the guidelines, and we have to assure that everything is in place. So let's say certain biological samples, they have to be handled in a way that they avoid contamination. So are the biosafety cabinets, they are working properly or not? That has to be checked every day. That has to be also done for monthly QC has to be done, that they are not contaminated with other stuff. That can be done monthly, weekly, depending on that. So regular quality assurance, it verifies that the data that we are going to collect from this procedure is not hindered by other external factors. So what are the key elements of an analytical plan? Before I move to the planning of an analytical plan, we must understand that an analytical plan, if it is only good if it has all the key components which are essential for deriving the results that we desire. So there are four main key elements. One is your study objective. If you don't have a good objective, if your objective does not justify the entire purpose of the study, then it is useless. So whenever we are having an analytical plan, we have to clearly state that these are my objectives and I want to do particular analysis for this purpose. Then the analytical methods, that if I'm using particular method of analysis, why have I chosen that particular method and why not others? So we have to specify the techniques, the equipments, the software, whatever we are going to use. The data collection, we have to also outline the protocols for collection, handling and storage of samples. Especially we have to mention which are the inclusion criteria, which are the exclusion criteria. We have to be very specific about it so that our data quality remains good. And then data analysis, where we have to provide a comprehensive statistical methodic plan. Okay, I am going to use this particular method of analysis because this aligns with my goals. So this effective analytical plan, it defines a method, procedure for data collection, analysis and reporting to ensure consistency, reliability and reproducibility, which are the key elements of our NABL as well as ISO standards. So I've listed an example that if we are going for a microbiological assay, then the plan should have a consistent sample preparation, incubation and colony counting methods. It cannot vary. If one person is preparing a sample in a different way than the other, then the results might be differing from each other and we might not get the desired association or the desired correlation that we are looking for. So we have to develop a robust analytical plan which has a clear objective, clear analytical methods, defined methods of data collection, especially which adhere to particular protocols, also with respect to handling and storage, and detailed statistical methods which allow us to objectively identify potential errors, random as well as systematic errors, whether we are going in the correct direction of study or not. And most important is documentation, that anything we do, we have to maintain a comprehensive record of that. And because anything, we now know that everything goes for delta check. In any kind of laboratory, everything goes for delta check, which means double check before the results are released, because there is always a chance of error. So that was about the plan. Now personnel requirements. So people who are doing the study. So there should be qualified analysts. You cannot directly hand over the data to somebody who is not trained enough. So people who are trained for specialized techniques, for example, a phlebotomist in a pathology laboratory who is trained enough should be given the task of sample collection rather than somebody who does not have good experience. Training of documentation. So all the personnel, all the team members have to be trained to particularly maintain the documentation of each and every step of the analytical plan. Only then we can achieve the regulatory compliance that we're talking about. And continuous education. In the former session also, sir emphasized on continuous education, that all the personnel should be regularly having a reinforcement of their training, and they should be given the chance to enhance their learning as well. So these three are personnel requirements. So this is one of the examples that I've stated. For example, if we are going to do an HPLC test, if I am planning to do an HPLC test, I will break it down into 5 components, like how will the sample be collected, which team will collect it, in how much time do we collect it, and what resources are required for that. So the first row states about sample collection. Second row states about sample processing, which takes around, which takes other people, team B, into account. The other team C is responsible for data analysis. QA team is responsible for quality control, and the entire study is being coordinated by a study coordinator who prepares an entire report of what has been done by team A, B, C and the QA team, who will form the data sheets and the template. So this entire breakdown will help minimize the errors and milestones that we or the expected deliverables that are defined at each stage. That, for example, if I have decided that by the end of 1 to 2 weeks, I want to collect at least 50 samples. So if I have defined that for each team, then definitely I will be able to achieve it. But if I don't define it, that who will collect, people might get confused that who is responsible for which task. So that thing might get delayed. Instead of 2 weeks, it might take 3 or 4 weeks. So to establish good milestones and expect the deliverables at each stage, we have to be having a breakdown structure of each of the study method. So let's talk about, that was about forming a good analytical plan. Now let's talk about subcontracting or the subcontracting management. Subcontracting essentially means that if I am not able to carry out a test, I am giving it out to other people who also adhere to the GCP or GLP standards, which I am practicing, or the laboratory that is in concern is practicing or is desiring to adhere to it. So if I work in an NABL accredited laboratory, I expect to send that work to another NABL accredited laboratory or higher, who is also following some other accreditation. But subcontracting cannot happen between another laboratory of a lower cadre or people who are not adhering to these standards, because that compromises the entire purpose of subcontracting. So let's say qualifications are to be verified and the compliance history is also to be verified. Sometimes what happens that certain labs, they do an agreement with one or the other lab that we are wanting to subcontract particular test to your laboratory, but there is compliance issue that expecting a result in 3 days, instead of that they take more than a week or so to give us the result, and that delays the patient management. So that cannot be done. We have to verify that whether the subcontracting, I mean the lab to which the subcontracting agreement is being done is compliant enough to give us the deliverable result. Then formal agreements, that it has to have a formal written agreement which depicts the detailed roles, responsibilities, particular timelines and quality expectations. We have to define everything. Nowadays, we all know that with NABL and ISO 2022, and even before, we have always been taught that what is not documented is not done. So documentation is one of the most important things. So any sort of let's say MOU is to be done, it has to be a formal agreement. It cannot be a verbal agreement, and it should contain all these contents about roles and responsibilities. Also, it has to be monitored, and with time to time, it has to be audited regularly to check for compliance and required standards. And if any corrective actions are required, then they can be implemented. And communication, there has to be a meticulous effort from both the ends, the laboratory that is subcontracting and the one that is accepting the subcontracted material. Then both, without communication, the progress or the compliance is very difficult to assess about. And if required, they can regularly update their systems. They can regularly ensure that they are having meetings or discussions to find on prospects of improvisation. So that is about subcontracting. Then let's move forward to data management practices. Everything here is about data when we are talking about research or we are talking about good practices. So real-time data should be recorded. For example, if I am having a particular result, that result should be documented or that result should be archived in my LIS or any other system in the real time, because that is accurate. Rather than doing it later, there might be some data loss. Data integrity and security is equally important, where we have to establish that there is accuracy, there is traceability and protection. For example, a hospital runs on an indigenous system designed for the particular hospital, and they have a traceability enough that one or two patient identifiers being used, the entire history of that patient for the last 5 years of visit is visible in the system. And that system does have a cloud system that is available for protecting that data, that no data is lost from that. Then we have access control that only authorized personnel can see. For example, now, as we all see, anyone can, like all laboratories are giving out digital reports, but some laboratories are practicing that only password protected files are being sent, and that data which is within the laboratory also is accessible only to particular individuals, not to everybody. This is to ensure confidentiality and not losing data to other people as well, for avoiding unethical practices. And long-term archiving. Data retention, NABL advises that 5 to 10 years is a good data archiving system. For certain laboratory sections, 5 years is enough. For certain sections, 10 years is recommended, but it is minimum 5 years of data retention is advised by NABL, is required by NABL. And same should be applied for this as well. And we also must have a backup system in place that if the system undergoes a breakdown, then there has to be a backup system. Like, for example, nowadays, as my other presenters, they highlighted that AI is taking up. So Google nowadays has, when people buy the cloud system for a particular company, the Google Cloud that is being offered to them usually has it in 3 places internationally at different locations, so that if there is any physical damage to the data, it is still available at some other place. So, sorry. Yeah, comprehensive reporting, that was about data archiving. Then now we have formed the analytical plan, we have talked about subcontracting, but what are we going to do when it comes to let's say all-in-one type of a situation where you have to do everything all at once? So it has to be a very comprehensive approach by the personnel who are responsible for reporting, as well as the personnel who are handling the data. So all results should be compiled, and they should be, all data points should be accurately reported within the raw data or the analytical method. For example, if there is a particular patient which has a particular condition, I have included that in my raw data, but it does not reflect in my statistical analysis, then I am going somewhere wrong. So it should represent it in the analytical method. If I am using any LJ chart, a particular dot representation, if I'm using any other graphs, that particular data should be represented on that particular statistic. There has to be a multi-tier review, that if one person is doing, sir earlier talked about review system, that if one person has formed the SOP, that has to be reviewed by the other person. So same way here also, technical experts who are involved in the process should be reviewing it. Quality assurance personnel may also do it. There are external quality assessment programs, or there can be senior management. So there can be a peer review process, or there can be another technical expert or the external quality assurance that can be taken up. Interim reporting should also be allowed, which provides a live update, where once we are reaching a key milestone, we are tracking the progress, but we have still not reached the desired deliverable, but still we have some important thing to address, or some important thing which we can be saying that this could be concluded to a particular result. Then, and meanwhile, somebody who is already reviewing this one, so that can be a checkpoint to know whether this is a integrated one, or there is timeline adherence. So there can be interim reporting of this particular data. And final report should be a formal one which summarizes the results interpretations and conclusions, and it can be disseminated through publications or presentations and other regulatory submissions. So what does it ensure? That 100% compliance if we try to adhere to GCP and GLP standards, then we get a 99.9% data integrity, which minimizes the errors and ensures reliable results. And there can be increased efficiency with structured approach, which saves time and saves our resources. Also, proper implementation will help us to pave the way for ethical and scientifically sound outcomes, and systematic organization of resources, tasks, and the team that is doing it. It will create a very good foundation for successful research, and which not only adheres with the regulatory requirements, but also contributes significantly to the scientific community. That's all. I hope I tried to deliver it in a very short period, but I hope I did my best. I would be happy to take any questions if there are.
I don't think so. There is any questions there.
Okay.
Okay, so there is no question. So thank you so much, ma'am, for sharing so much of knowledge on the topic. So thank you once again.
Yeah. Thank you so much for this opportunity.
So as we draw this enlightening speaker session to a close, on behalf of the entire organizing committee, I would like to once again extend a warm and heartfelt welcome to all the dignitaries, the speakers who are present today, and welcome to Dr. Urvesh Shah, sir, our esteemed GMC observer. Thank you so much, sir, for your gracious presence virtually and dedicating your valuable time to join us today. Today's event would not have been possible without unwavering support and encouragement of Dr. Dipti Shah, ma'am. Our heartfelt gratitude to you, ma'am, for being a pillar of support throughout. A big thank you to Dr. Saumil Merchant, sir, Dr. Pooja Dullo, ma'am, and Dr. Janardhan Bhatt, sir, for not only taking this initiative, but also successfully implementing it with dedication and vision. Narendra Modi Medical College is also thankful to APPI Gujarat State Chapter and Forum for their collaboration. And the organizing team and the speakers are also thankful to Narendra Modi Medical College for consistently organizing this kind of webinar sessions twice a year. We also extend our sincere appreciation to all our eminent speakers who are experts in their pathology field for their time, insights, and the knowledge shared throughout this day. Your contribution have truly enriched this academic platform. The successful completion of this event is direct result of your collective efforts, time, commitment, and teamwork. As a token of our gratitude, the organizing team will be sending out the token of appreciation, the award of appreciation to each speaker and judges, which will be couriered to your respective addresses, and our team will be in touch shortly to coordinate with the same. It has been a privilege to host such a distinguished gathering of professionals dedicated to excellence in good clinical laboratory practice. We are looking forward to more such collaborative efforts in the future. For now, I thank everyone for being present today and share their insightful knowledge with us. I thank once again to all the dignitaries. Now, with the speaker session on conclusion, it's time to begin the next segment of our event, the oral and poster presentations. I will be announcing quickly about the oral poster presentation participants, so be attentive to it. Those participants who are presenting in pathology branch, please join Google Meet link which has been shared in your respective WhatsApp group for your oral and poster presentation. The remaining participants of all the branches will continue on WebEx for the respective sessions. I repeat, pathology will go to Google Meet link and the remaining branch people participants will stay on the WebEx link. Those who are in the pathology branch, they can leave the WebEx link and join their Google Meet link, which will be shared in your WhatsApp group. The remaining branches have to stay on the WebEx link. We will begin the next 10 minutes. We will begin the session in next 10 minutes. So kindly follow the instructions shared in your groups and ensure you join on time. Already the sequence of participants have been shared to you. Be present on that way. Only paper presentations are going to be present on the session. Poster presenters don't have to present anything. Oral presenters have already been given a sequence of numbers. First, there will be Margi. Second is Lomesh. Third is Ajay. Fourth is Alolika. And the fifth is Sanket. I request all these 5 to be ready for their first presentation. We will start in 5 minutes. Once I will call the name, you have to raise your hand and I will assign you the rights for sharing the screen. If you have any doubt, you can raise your hand and I can solve the query before we start the session. I repeat, if anyone have any doubt regarding how to present, they can raise their hand so that I can solve the query. All the presenters will be given 3 minutes of presentation and 2 minutes of question answer. All the presenters, be ready with your PowerPoint. The moment we call you, raise your hand, unmute yourself. Okay, how to share presentation on this? You have to, I will assign you the sharing button, sharing roles. After that, click on the share screen option. If you have joined from mobile phone, I request all the participants to please turn off your notifications, all notifications, because while sharing the screen, any notification may hinder your presentation or may disturb your presentation. So for privacy purpose, make sure you turn off all the notifications. Yes, Dr. Lomesh. Yeah, just 5 minutes. We are starting. The first is Patel Margi. I hope she is ready. Dr. Margi, did she join with some other device? Dr. Margi? Okay, so Margi is not there. Anyone knows that Margi has joined from any other device? Okay, so let's move ahead with the second presenter, Dr. Lomesh. I'm making you presenter. Dr. Lomesh, I have made you presenter. Kindly unmute yourself.
Yes.
Okay, now you start sharing the screen.
Okay.
Okay, now we can see your WebEx screen.
PPT is visible.
Yes, it is visible.
Okay. My topic is the clinical and functional
Just a minute.
outcome. Okay.
I'm starting with the timer. 3 minutes
Okay.
of presentation and followed by 2 minutes of question answer. Okay?
Okay. Thank you.
Start.
Okay. My topic is the clinical and functional outcome after total hip replacement in avascular necrosis due to sickle cell disease. Sickle cell disease is one of the important etiology of hip osteonecrosis in the Indian subcontinent. And sickle cell disease presentation is osteoarthritis of femoral head secondary to osteonecrosis. Avascular necrosis of femoral head in sickle cell disease is an immense progressive and disabling component in 20 to 50%, majority of which are in their second to third decade. Young sickle cell patients with osteonecrosis femoral head are greatly disabled due to the pain and restriction on motion. My objective of conducting this study to understand the patient satisfaction by assess the pain intensity of hip joint and health related quality of life preoperatively and post-operatively using VAS score and Harris hip score, as well as evaluate the duration of return to occupation and activity of daily living post-EHR. In material method, apart from personal details, Harris hip score, visual analog scale, we use the question to assess the quality of life return to occupation. Study design is interventional, and the population we take are the patient who has avascular necrosis with sickle cell disease, and sample size is a patient who operated in our hospital within 6 months of duration. In my inclusion criteria, I include the all avian patient with case with diagnosed by sickle cell disease, patient willing to participate and patient who give a follow-up. And I exclude the patient who are not willing to participate, who have a AVN but other than a sickle cell disease cause. AVN which is in the sickle cell crisis and patient who lost to follow-up. In the study, aim was to assess the THR or in a sickle cell disease operate in our institute. The follow-up is a 6-month follow-up, 6-week follow-up, and by doing hip Harris score is a validated tool used to measure the functional capacity of patient of hip pathology before and after the surgical procedure. And the visual analog score is a psychometrical scale that is generally used in hospital and clinic by doctor and conduct a pain scale survey. My result I collect in the Microsoft Excel sheet. My result is a hip Harrison score is improved from 45.6 to 86.15 post-operatively, which is accordance with the study conducted by Azam MQLT. This shows that the functionality of the hip joint was improved after the THR from average to poor result to good result. VAR score was 7.15 pre-operatively, now is 1.85. Evaluating shown that in present study before surgery where patient were experiencing severe pain on average, significantly improve after 6 weeks. Studies show that 90 patients saw improvement in their gait 6 weeks after the total hip replacement and only 3 patients were using walking support in their follow-up after 6 weeks. Studies show that 90% patients were satisfied and returned to their occupation. Only 2 patients were not able to return to their occupation. Regarding demographic study, majority are patients are in the 20 to 25 age group and the 25 to 30 age group. And this primary are male more affected than the female. Sedentary workers are found to be more affected than the moderate or strenuous worker, which are in the contrast study conducted by Walter van der. And mean duration of illness was found to be 19.2 months, which is 45% patient was suffer for 1 to 2 year duration. This is my
Conclude.
case 1. My conclusion is study conducted for THI is effective surgery in the reducing pain intensity and improve quality of life in patients with avascular necrosis due to sickle cell disease. Study also showed that limb was reduced in post-THI as well as patient required to less walking support after the surgery. Majority of patients returned to their occupation within 6 weeks of surgery. And the result obtained from this study will encourage patients with avascular necrosis due to sickle cell anemia to take decision undergoing total hip replacement after the surgery. Thank you.
Okay. Respected
Hello.
sir.
Hello.
Hello.
Yes. What is the diagnostic marker of sickle cell disease?
For the diagnostic marker for the sickle cell disease, we do a H, HB electrophoresis for and a sickle cell sickling test. The sickling test is very much sensitive, and HB electrophoresis is very much specific for sickle cell disease, sir.
What is the market cost of one test for the sickling?
Sir, in the sickle test is generally 35 to 40 and HB electrophoresis generally 3,000, 2.5 to 3,000, sir.
Oh.
Okay.
Okay, anyway, thank you very much. You can leave.
Okay, thank you, sir.
Okay, you can stop sharing the screen. Next is Dr. Ajay. Dr. Ajay, have you joined with any other device? Kindly raise your hand. Okay. Dr. Adolika? Yes, I'm making you presenter. You can unmute yourself. Yes.
Yes, ma'am. Am I audible?
Yes, you are audible. You can share your screen.
Yes, ma'am. Ma'am, is the screen visible?
No, not yet. No. Okay, now I can see your screen.
Yes.
So you will have a 3 minutes. At 3 minutes, I will say for conclusion. So for in a minute, you
ma'am.
have to conclude your slide. Okay.
Yes, ma'am.
Okay. Start.
Good afternoon. I am Dr. Alolika, tutor in Department of Physiology, Dr. M.K. Shah Medical College. My topic is the pattern and magnitude of intraocular pressure following a visual task on a smartphone. Ma'am, I'm not able to change the slide.
Click on the screen and then do it next slide. You have joined from mobile? Ah, okay,
No, ma'am,
go
from
ahead.
laptop. Yes, ma'am. Beginning with the introduction, electronic devices like smartphones, computers, tablets, etc. are practically unavoidable nowadays. They are used for various activities like studying, checking emails, for entertainment and social networking. Use of these devices has been increased among all age groups, but the young individuals spend a good amount of time using these devices. On using these devices, users are exposed to device features like screen size, resolution, contrast, screen glare, have consequences on our ocular health. They may present with following ocular signs and symptoms like eye fatigue, itchy eyes, dryness, blurred vision, double vision, and some extraocular symptoms like headaches, sleep disturbances, musculoskeletal aches, together known as computer vision syndrome, as per American Optometric Association. The widely proposed etiologies are sustained effort for accommodation and different viewing distances and angle, making eye focusing and eye movements an extra demand. So based on these ophthalmic manifestations discussed above, there could be a significant fluctuation in the intraocular pressure in these users as well. So thus the study was done to see the effect of visual use of a smartphone on the pattern and magnitude of intraocular pressure change among healthy undergraduate students. Coming to the methodology, 80 healthy undergraduate students between the age group of 18 to 25 with normal visual acuity were taken. Then the pre-work intraocular pressure were measured using the non-contact tonometer. A movie was shown on for 20 minutes on a smartphone. Then the post-work intraocular pressure were measured immediately after the task, then at 5 minutes and at 10 minutes post-task using non-contact tonometer. Then the post-work intraocular pressure were measured immediately. Okay, only the right eyes were considered. The three intraocular compared to the using the paired student t-test. After watching a movie on a smartphone for 20 minutes, the significantly increased. Intraocular pressure returned to the pre-work level in 5 minutes after stopping the task, and it continued to decrease significantly after 10 minutes of post-task. So I conclude saying that it is recommended to use e-devices sensibly, keeping the ocular health in consideration. People should be encouraged to take frequent breaks in between, practice good posture, maintain a safe distance between the eyes and the screen, and reduce the screen time. Thank you.
Sir,
So what is the recommendation?
Sir, I would recommend to take breaks and take a wider screen devices like computer or laptops and maintain a certain distance to view and take frequent breaks in between.
What is the ideal duration of exposure to smartphone in teenagers?
So this was for only short duration. I have done for only 20 minutes of movie viewing, sir.
So what is the mechanism how the smartphone can increase intraocular pressure?
So due to when we are viewing with the smartphone, due to accommodation phenomenon where the lens, the anterior curvature of the lens can protrude and block the trabecular meshwork through which the aqueous humor drains. So there can be chances that it get blocked and drainage can be impaired. So a transient increase in intraocular pressure can be seen, or
Which
because
method
of the
you,
neck posture.
which
Yes,
method you
sir.
use to measure intraocular pressure?
I used the non-contact tonometer, sir. Fluids non-contact tonometer.
Have you taken the ethical committee permission?
Yes, sir. Yes, sir.
Do you have the certificate of ethical committee?
Yes, I have. This is my MSc
Okay.
thesis, sir. I am MSc in
Okay.
medical physiology. It is
Okay.
my
Okay.
thesis.
Very good. Very good. Thank you very much.
Okay, thank you, sir. Thank you, sir.
Okay. Thank you, Dr. Adolika. Now next is Dr. Saket Rathod. I'm making you presenter. Am I audible? Dr. Saket? Am I audible? Dr. Sanket? Am I audible? Okay, so next is Dr. Ashray Jain.
Hi, can you hear me?
Yes, I'm making you presenter and you can now share the screen.
Can you see my screen?
Start the slideshow.
Can you see it?
Yes, we can see your screen. You
Good
can
afternoon,
start the
everyone.
slideshow if possible.
Okay.
You can start on the play button that's there in the upper.
Yeah. I had started.
Okay, your time starts now.
Yeah.
Okay, I just a brief instruction. Please focus on methodology, result, discussion, because that remains. When we ask you to conclude at that time, your discussion is almost remaining. So focus on methodology, result, and discussion.
Okay. Can I start?
Yes, start.
Good afternoon. I'm Dr. Asha Jain, third-year resident at SBKS Medical College. I am here to present my case report on a rare giant parotid pleomorphic adenoma with atypical preoperative segmentation of category 4B sum. Pleomorphic adenoma are the benign salivary gland tumors which predominantly affect the superficial lobe of parotid gland. Parotid pleomorphic adenomas are made up of mixture of both epithelial tissues and the stromal element. They usually manifest as slow-growing asymptomatic parotid gland swelling without facial nerve involvement. And they are best treated by wide local excision with good safety margins. I am here presenting a case report of a 31-year-old female that is presented to ENT OPD with a history of swelling in left cheek since 2 years. The patient reported a history of left cheek swelling since 2 years, which was insidious in onset and gradually progressive. She has a surgical history of left superficial pyrectomy done 2 years back, and she has no family history. This is the case which I have been talking about. On examination, I found it 15 into 10 centimeter swelling, single multinodular swelling on the left parotid region, which is extending onto the left postauricular region till left mandibular region. A scar mark is present, which is of the left pyrectomy. There are no engorgement scenes and no discharging sinus seen. We have performed the MRI phase with neck and contrast. Figure A shows the axial section and figure B shows the coronal section. It shows the extent of the tumor. We performed the FNAC preoperatively and it shows the pleomorphic adenoma with APPI. On treatment, we perform total pyrectomy that is done under GA. We keep a modified Blair incision. We raise the flap and soft tissue dissected and retracted. Internal jugular vein, left external jugular vein identified and preserved. Spinal accessory nerve, hypoglossal nerve identified and preserved. We identify the trigger pointer, and from that we identify the facial nerve, but it was sacrificed. And both lower parotid removed in total stands for HPR. Left-sided facial Danaplast dressing given and post-op left facial palsy present. She came on the follow-up after, and she has on examination swelling of the left side of cheek, so significant reduction, and patient clinically improved. When we said that when we specimen sent for HPR on the result, it is seen that the sections of ductule cyst and tubules arranged in a trabecular to pseudo-alveolar pattern that is scattered in fibromyxoid Epithelial cell lining ducts showed nuclei with open chromatin eosinophilic to vacuolated cytoplasm. Myepithelial cells show clearing, focal hyaline and sclerotic changes are seen. Pleomorphic adenoma. 31-year-old female present with a large bloated mass clinically suggestive of giant pleomorphic adenoma. Preoperative fine needle aspirate cytology show atypical categorizing and sum according to the Milan system. Cytological features include cellularity with varying degree of atypia and occasionally necrotic debris, which raise concern about the potential for malignancy. Subsequent surgical resection confirmed the diagnosis of giant pleomorphic adenoma. The atypical cytological presentation was attributed to large size of tumor and its degenerative changes. The case highlights the diagnostic challenge of atypical cytological findings in large pleomorphic adenoma. I conclude salivary gland neoplasm can occur at any site where salivary gland tumor tissue is present. Pleomorphic adenoma is a commonest salivary gland tumor that is characterized by diverse histomorphological features. Early diagnosis and treatment plan entails thorough institute-taking clinical examination coupled with radiograph and histopathological findings. Proper diagnosis and careful surgical resection with preservation of the facial nerve help in better prognosis with least chance of recurrence. Giant pleomorphic adenoma parotid glands are rare, particularly in young patients, and their preoperative cytological evaluation can be challenging. According to the Milan system for reporting salivary gland cytopathology, it's provide a framework for categorizing the salivary gland lesions, but atypical presentation complicate the diagnosis. Milan system, while effective, may require careful interpretation in cases of significant tumor size and atypical features. Accurate diagnosis necessitates the correlation of cytological findings with clinical and histopathological data. These all are my references. Thank you.
So what was final cytological diagnosis?
Sorry, sir?
What was the final diagnosis?
Sir, it was pleomorphic adenoma only. When we send that sample to the histopathology, they confirm that it is a pleomorphic adenoma. It was benign. It was benign, sir.
So what complication can arise after removal of parotid gland?
Sir, if the facial nerve is very close to if it is into the deep lobe of parotid gland, then there are chances that facial nerve can be sacrificed, and which apparently does in this case. And if it into the parapharyngeal spaces, if it goes, then it can affect the other nerves also, sir. On surgical.
Have you tried facial nerve grafting?
No, sir, we didn't do that.
Okay, thank you, sir. No.
Okay, thank you, sir.
Okay, thank you. Next, Dr. Neil. Dr. Neil Jain, I am making you presenter.
Hello.
Hello.
Am I audible?
Yes. Just a minute. I am making you presenter. Can you share your screen now?
Okay. Shall we start? Hello.
Yes. I can see the screen, but not yet. Yeah, it's loading gradually. Okay. So you can just
Can I
just
start?
yes, you can start. You can first do the first slide.
Okay. Good afternoon, everyone. My name is Neil Jain, and I am second year resident in ENT from SBKS Medical College. My topic for today is a rare case of pleomorphic adenoma of soft palate. Pleomorphic adenoma is the most common benign salivary gland tumor, primarily affecting major salivary glands such as parotid. However, it can also arise in minor salivary gland, the most common intraoral site being the palate, followed by upper lip and buccal mucosa. Palatal pleomorphic adenoma presents clinically as painless, slow-growing mass found on posterolateral aspect. Although benign, untreated or recurrent cases may undergo malignant transformation into carcinoma X pleomorphic adenoma. Here I am presenting a case of 30-year-old male patient presenting with complaint of swelling in oral cavity since 2.5 months, which was insidious in onset and gradually progressive, associated with change in voice. There was no association with facial nerve paralysis, earache, pain while swallowing, weight loss, or difficulty in breathing. On ENT examination, there was a single solitary globular non-mobile non-tender swelling of about 5 to 5 centimeter from left soft palate extending into oropharynx and crossing midline was seen in oral cavity. In neck region, a single solitary firm non-tender non-mobile swelling of about 1 into 1 centimeter palpated over left level 2B region. On CT neck with MRI shows a large rounded or oval-shaped soft solid tissue mass lesion with areas of necrosis arising in left lateral wall of nasopharynx and oropharynx. FNAC shows salivary gland neoplasm of uncertain malignant potential category 4B. Treatment plan, a patient with due consent was taken for surgery, intraoral parapharyngeal tumor excision under general anesthesia, horizontal incision kept over most prominent part of the swelling, soft tissue dissection was done and swelling dissected from all around. Swelling extending to nasopharynx lateral pharyngeal wall was also removed in toto and sent for histopathological examination. Hemostasis was achieved and closure was done. Histopathological examination report shows the encapsulated tumor comprising of epithelial cells arranged in trabecular to acinar patterns and myoepithelial cells scattered throughout in the background of predominantly fibromyxoid stroma as well as chondromyxoid stroma. Features of carcinoma X pleomorphic adenoma were not seen. Impression is pleomorphic adenoma. On follow-up, patient was clinically improved and swelling was not seen. I will conclude by saying that minor cerebellar gland pleomorphic adenoma presents as mostly firm, rubbery, painless, slow-growing tumor with submucosal presentation. Though these benign tumors are well encapsulated, resection of tumor with an adequate margin of grossly normal surrounding tissue is necessary to prevent local recurrence because these tumors are known to have microscopic pseudopod-like extension into the surrounding tissue due to dehiscence in the capsule. Although benign, untreated or recurrent cases may undergo malignant transformation into carcinoma X pleomorphic adenoma. Definitive diagnosis lies in the histopathological examination and treatment is by surgical excision with wide margins. Excellent results are seen if the wound is allowed to granulate and heal by itself. Recurrences are uncommon but may be seen on long-term follow-up. Early detection and proper surgical intervention of the tumor should be done to get better results. Thank you.
For which complications you were ready? Which complication could have arisen during operation?
Facial nerve paralysis could have arisen. Face syndrome could have arisen.
Okay. Any more?
Sir, normal infection, redness, pain due to infection. Numbness of the ear or earache.
You can leave. Thank you.
Okay. Thank you, Dr. Devanshi. Now I'm making you presenter.
Hello.
Yes, Dr. Devanshi.
Is it visible?
No, not yet.
Is it visible at present? My screen.
No, it's not visible. And little bit louder, please. We cannot hear you.
Okay. Hello. Hello.
Yes. Yes, now we can
You
hear.
can hear me? Okay. Screen is visible?
Yes.
Okay.
Your time starts.
Should I start?
Just a minute. You can start now.
Okay. Good afternoon, all. I am here to present a study of metabolic syndrome in type 2 diabetes mellitus patient. Metabolic syndrome is a constellation of metabolic abnormalities that associated with the increased risk of cardiovascular diseases and diabetes mellitus. The major causation factors are central obesity along with insulin resistance. The metabolic syndrome is complex and interrelated with specific risk factor for type 2 DM. We use this study basically to identify the most crucial risk factor leading to metabolic syndrome, which predisposes the population for type 2 DM. My aim is to identify the prevalence and characteristic of metabolic syndrome among the patient with type 2 DM and identify common demographic, clinical and biochemical parameters of metabolic syndrome in type 2 DM. Methodology, I have done a cross-sectional observation study for approx 1 year of period, and on population was patient of type 2 diabetes mellitus, which was diagnosed by latest ADA guideline. Demographic physical examination and laboratory investigations were collected as a data, and sample sizes of 105, and statistical analysis was done on non-parametric and parametric based stage. My results were as following. The mean age of the population was 56 years, and 46% was female and 54% male. Among them, 22% are from upper class, 47% from middle class, and 29% from the lower class. Among them, 71% has a sedentary lifestyle, and smoking, alcohol, tobacco is the main addiction associated with the population, which is more in male compared to female. The comorbidity is hypertension, followed by coronary artery disease, followed by CVA. The metabolic syndrome criteria was NCEP ATP3 criteria, among which 5 out of 3 are present, then the metabolic syndrome is considered, which include the hyperglycemia or insulin resistance, atherogenic dyslipidemia, and hypertension. The main variable, the most prevalent variable was waist circumference and reduced HDL, along with triglyceride and raised systemic blood pressure. The prevalence was 68.6 in percentage, and 72 people were has metabolic syndrome, who is known case of diabetes. 43 were male and 29 were female. Among them, 77% has a sedentary lifestyle and 73% has BMI of more than 25. So my prevalence of metabolic syndrome in my study is 68.6%, which is consistent for 3 following studies, which has 68, 71, and 70% of prevalence of metabolic syndrome respectively. The raised blood, fasting blood sugar, reduced HDL, and raised waist circumference were the most prevalent criteria, which was also consistent with some already done study. And the metabolic syndrome has associated with sedentary lifestyle, which is 77% in my studies, which is ranges from 34 to 90% in 2 to 3 respective study done on the same purposes. So the conclusion of my study is that there is high prevalence of metabolic syndrome in type 2 diabetes mellitus patient with a notable male predominance and strong association with sedentary lifestyle and obesity. The key metabolic abnormality includes elevated waist circumference, raised triglycerides, and reduced HDL cholesterol, along with fasting blood sugar. The metabolic syndrome was also associated with comorbidities like hypertension and coronary artery disease, and it necessitates the comprehensive management strategies focusing on the lifestyle modification, regular monitoring of metabolic parameters, and targeted treatment of comorbid condition. These are my some key references. Thank you.
Thank you.
Okay. What is the hallmark of metabolic syndrome?
So sir, basically there are five parameters which we have to meet. Any three of them would be sufficient to diagnose as metabolic syndrome. But waist circumference and reduced HDL are the most prevalent.
What is
And
PCOS?
insulin resistance is the
Okay. What is PCOS?
the PCOS is a
What
yes,
is
sir.
the,
It is hello.
what is the relation between
Hello.
PCOS and metabolic syndrome?
The PCOS is the polycystic ovarian syndrome, sir.
Okay. What is the relation between PCOS and metabolic syndrome?
Sir, they are closely linked as both has common etiological factors like insulin resistance, dyslipidemia, high blood pressure, etc.
Okay, thank you very much.
Thank you, Dr. Devanshi. Dr. Shivani, I'm making you present. Am I audible, Dr. Shivani?
Yes, ma'am.
Okay.
Good evening, everyone. I'm Dr. Shivani, second year radiology resident.
Just a minute. Please start the slideshow. I cannot see the full screen. You can do landscape.
Okay, ma'am.
Change the orientation of your phone to landscape.
Is this okay?
Yes, it is okay. Can you just change the 2-3 slides so that I can get to know if it's visible or not? Yes.
Okay, so good
Okay. Again, I want to just emphasize, don't waste your time in introduction. Focus on methodology, result, and discussion.
Okay, ma'am.
You can start.
Okay. The paranasal sinuses are hollow air-filled spaces located within the bones of the face and surrounding the nasal cavity, a system of air channels connecting the nose with the back of the throat. The PNS lesions are common in all age groups. A wide variety of lesions that affect the paranasal sinuses, including congenital abnormalities, benign tumors, inflammatory and allergic conditions, complications of infection and obstruction, and traumatic lesions. They can be evaluated with X-rays, CT, and MRI. X-ray PNS is the primary investigation for paranasal sinus lesions, but many times it is not sufficient to reach at final diagnosis. Also, plain radiographs does not help provide information for preoperative surgical planning. With the use of CT scanning combined with functional endoscopy sinus surgery, modern sinus surgeons can treat patients more effectively, facilitating reduced morbidity and complications. CT scan can become a useful diagnostic modality in the evaluation of the PNS and an integral part of surgical planning. It can also be used to create intraoperative roadmaps and the radiological examination of choice in evaluating the PNS lesions. Paranasal sinus lesions are diagnosed high accuracy with CT scan. Osseous and cartilaginous lesions, osteoma, osteoblastoma, osteoclastoma, chondroma, chordoma, chondrosarcoma, osteosarcoma, Ewing sarcoma, and fibrous dysplasia. Osteomia. Osteoma is a benign bone lesion. It has a male preponderance of 3:1. Common age of presentation in the second and third decades. Sites, diaphysis of long bones, skull, paranasal sinuses, and mandible. In paranasal sinuses, it occurs most frequently in frontal sinus, followed by ethmoid and maxillary sinus. Plain radiograph, round oval area or radiolucency with a sclerotic margin containing a small dense opacity within, known as a nidus. The extent of the lesion extends on where the tumor is located. In paranasal sinuses, it appears as a dense osteosclerotic bony lesion in sinuses with characteristic bony density. Osteoma. In CT scan, it is an essential investigation for the diagnosis, especially if the lesion is surrounded by dense sclerosis. It also helps to detect the exact location and extent of lesion. The appearance is of a round or oval hypodense area with a hyperdense sclerotic margin. Since the lesion is highly vascular, post-contrast sections will demonstrate the tumor blush evident in the lesion. Fibrous dysplasia. can be monostotic or polystotic. Age is from 10 to 30 years. It is more common in females. Sites, pelvis, femur, and ribs. Skull in frontal area, sphenoid and parietal and maxillary sinus, and also in mandible. Radiologically, characteristic ground glass or IV appearance of the affected bone with expansion. Cortex is scalloped and thinned but intact.
Conclude.
Conclusion, CT scan and X-ray are the modalities used to evaluate osseous lesions involving paranasal sinuses. They both prove to be useful tools for diagnosing osseous lesions, but CT scan is the ideal modality to help the clinician in identifying the exact size, site, and extent of the lesion. Thank you.
Hello.
Yes, sir.
In incoming AI era, how human doctors can be superior to AI?
Sir, AI will be helpful for radiologists to work reaching to a diagnosis, and it will be more accurate, and it would be beneficial for human doctors and we radiologists to.
My question is how human doctors are superior now in AI.
Sir, AI cannot be always accurate. Human doctors will always be on an upper hand in when it comes to diagnosis.
How I can't understand. You said previously you told that AI is accurate, and now you say
It,
the
it
doctor
will
is accurate.
complement us, but we always human doctors will always have the upper hand.
Nice. Thank you very much. Next.
Thank you, sir.
Thank you, Dr. Shivani. Next, Dr. Anmol. I'm making you presenter. Dr. Anmol. Dr. Anmol. You are muted. We can't hear you. Kindly unmute. Dr. Anmol.
Am I audible?
Yes, now you are audible. You have started the screen sharing, but
Yes. Wait.
it's hang, I think.
Is my screen visible?
It's blurred, yet not started. We can see the screen, but you have not started the presentation yet, I think.
Wait.
Even your internet connectivity is also very low. The screen that you are sharing, that is also not properly visible.
Is now visible? My screen is now visible.
We can see the screen, but we cannot see the PowerPoint that you are sharing.
Better you join with other with mobile.
Okay. Let me join
I
it.
think there is some problem with your mobile itself.
Okay, so you can take a break. By the time I can call the next participant. After that,
Do you have?
I will be
Do
calling.
you have iPhone? iPhone? Do you have?
Yes, I have iPhone.
Is this iPhone? Sometimes
Yes, sir.
iPhone don't support. That is true. Whereas you take some Android, I think.
Okay, sir.
Okay, so you can take a break, share the screen, and sit in the better connectivity area. Now I request Dr. Karan.
Okay.
I'm making you presenter. Dr. Karan. Kindly unmute yourself.
Yes, ma'am. Yes, ma'am. Am I audible, ma'am?
Yes.
Is my slide visible, ma'am?
No, not yet.
Now?
No. Have you started screen sharing?
Yes, ma'am. I have started.
It's not showing.
Now is it showing?
Yes, now it's visible.
Okay. Good
Just
afternoon, everyone. Yes.
Just check once it is changing.
Yes, ma'am. It is showing.
Okay. Again, repeating again.
Yes,
Please
I'm not
focus
going
on
with. Yes.
methodology.
Yes.
Your time starts now.
Yes. So I am presenting a 22-year-old female case which presented with complaint of periumbilical pain and lower abdominal pain since 1 day and not passing urine since 6 hours. Not associated with any nausea, vomiting, fever, diarrhea, or rectal bleeding, or weight loss or menstrual problems. On examination, bladder was palpable, so catheterization was done to relieve the acute urinary retention, which relieved the symptom. After asking further history, she had similar 2 episodes in the last 6 months of urinary retention, which got relieved by primary health center and by doing catheterization, and no further evaluation was done at that time. On PR examination, patient was found to be having a cystic lesion was palpable approximately 7 centimeter above the anal canal, compressing the lumen from the posterior aspect from 4 to 8 o'clock position. Per rectally, we were not able to reach above the lesion. No hemorrhoid or ulcer or nodularity over the rectal mucosa was found. After investigation, blood and urine investigation X-rays were normal. Ultrasonography showed 12 by 10 centimeter mixed echogenic collection in pelvis with internal 20 by 25 mm hypoechoic component within it. We did the CT scan, which showed 13 by 15 by 40 centimeter multiloculated, minimally peripherally enhancing fluid density lesion in pre-sacral region. It extends craniocaudally from S1 to bilateral ischial fossa. The lesion shows peripherally calcified wall and internal enhancing soft tissue component and septation. Anteriorly, the lesion was reaching up to the rectum and compressing it. It was also compressing the uterus and also compressing the bilateral ureter, and which was leading to both kidneys were showing hydronephrosis and dilated ureter up to its lower end. Both ovaries were seen separate from the lesion. So the possibility was it was either the presacral immature teratoma, tailgut cyst, or anterior sacral meningocele. Uh, this is the CT cut which is showing the lesion here and here. We also did the MRI because to delineate the anatomy properly. MRI showed 12 by 13 by 17 centimeter mass extending anteroposteriorly from presacral space to almost up to symphysis pubis, suggestive of tail gut cyst. So we underwent the surgical operative intervention. We did after positioning the patient in prone position. We put the inverted V-shaped incision, whose tip was pointed at the coccyx, which was the modification of the Kraske approach, which was suggested by Kraske in 1870s, which was used for presacral teratomas. We opened the cavity and coccygectomy was done, and approximately 250 cc of pus was drained from the cyst and was sent for culture. Coccyx was excised to better visualize the cavity. Gluteus and levator and a muscle attachment at the coccyx were removed. The entire cyst was excised while taking note care to injure surrounding structures like ureter, external iliac vessels, or rectum. Romovac drain was placed in the cavity, which was crevated, which was removed on the post-operative day 7. This is the post-operative picture. We put the incision like this, and which was closed in the layer, and here the Romovac drain was placed. Histopathology report was showed it was a tail gut cyst along with changes of acute and chronic inflammation. Discussion. Retrorectal region is a potential space surrounded by rectum anteriorly, sacrum and coccyx posteriorly, and the peritoneal reflection above and below there is pelvic diaphragm suggestive of formed by the coccyx and levator ani. Tail gut cyst, when infected, can present with signs and symptoms similar to pelvic abscesses or perianal abscesses. The diagnosis can take place as early as in the prenatal.
Conclude.
Yes. So every case in my case we as previously 2 episodes of urinary retention were not properly evaluated, so we have to evaluate every urinary retention case properly. It may be due to another causes apart from urinary system. Type of surgery and approach for removal of tail gut cyst depend on the size, location, and expertise available at the institute. Imaging and histopathology examination is must, so we do not miss any malignancy that can happen in the tail gut cyst. Thank you.
What was the post-operative diagnosis?
Sir, post-operatively, it was a infected tail gut cyst, sir. We removed it entirely.
It was, what was the age of the child?
22 years old, man.
20-year-old.
Yes. It is most commonly seen in middle-aged female because in early ages it does not show any symptoms, sir.
Okay, good.
Thank you, sir.
Okay, thank you, Dr. Karan. Moving ahead with Dr. Aman. You can start sharing the screen.
Hello, am I audible?
Yes, audible.
My screen visible right now?
Yes.
Okay. Myself, Dr. Amanto, my second year resident from SBKS College. My topic for today is different modalities of treatment in distal third tibia fibula fracture in adults. Fracture of the tibia shaft are the most common of the long bone fractures with the highest incidence of diphaseal fractures. Because the shaft of tibia is subcutaneous throughout its length and may be a diminished blood supply, severe complication and major disabilities are common outcomes. Fracture of the tibia and fibula can range from completely undisplaced fractures with minimal soft tissue damage to the traumatic amputations. The treatment modalities described for tibia fibula fractures range from simple cast immobilization to complex surgical procedures. Considerable concern existing that misalignment of the heel tibia shaft fracture may result in post-traumatic arthritis of the ankle joint. As the location of deformity approaches the ankle or the knee, the misalignment results in maldistribution of articular surface, pressures that may be predispose the patient to premature osteoarthritis. Several clinical reports have demonstrated that the fracture stability of distal tibia with intact or stabilized fibula does not ensure successful healing. Few studies claim distal tibia with intact fibula has increased chance of delay union, non-union, varus malunion. However, various cadaveric studies have shown that the fibular fixation increases rotational stability in tibial fracture treated with intermediary nailing of tibia. Our aim was to study the result of fractured distal third tibia or fibula treated with various methods in an adult. Objective was to review the available literature for management of distal tibia and fibula in a fracture adult to find out better modalities of treatment in fractured distal third tibia fibula according to the type of fractures, as these fractures are notorious to non-union. Methods and materials. The prospective studies were conducted on a 20 patients diagnosed with distal third tibia fibula fracture presented to casualty. Inclusion criteria included patient age 18 years and above and the fracture of the distal third tibia and fibula treated by the operative means. The exclusion criteria who did not want to participate in this study: fracture of tibia fibula proximal to junction of the upper 2/3 and lower 1/3, malleolar fracture, open fracture, pediatric age group. All the patients were treated according to the protocol with the open reduction and internal fixation with plating, or closed reduction and internal fixation with nailing. Passive cordyceps exercise was started for the next day of the surgery. The patient was discharged with non-weight bearing walking for 12 to 16 weeks, depending on the fracture pattern. Partial weight bearing was started as early of the clinical and radiological union. Patients were allowed depending on the clinical examination as well as the radiological finding on the union. The prospective study was carried out on 20 consecutive patients. The average age group for our present study was 42 years, where 15 patients below 50 years of age and only 2 patients above the age of 61 years. We observed more of the young active population in our studies. In our study, there were male predominance of 60%. Road traffic accidents.
Conclude.
Yeah. According to our study, the study of 20 patients with fracture of the distal tibia had undergone open reduction internal fixation with locking compression plates and closed reduction internal fixation with tibia nail. Fibula was also fixed with either rush pin or plate. The open reduction not only helps in achieving a reduction in difficult situation, but also in rapid union because it facilitates preservation of blood vessel supply to the fragmented anatomical reduction of the fracture. Close reduction internal fixation with tibia nail is also a good modality of the treatment, characterized by high rates of union and low incidence of complication. Greatest advantage in open reduction internal fixation with lock-in trace is anatomical reduction. Advantage of intermediary fixation is that the lock intermediate nail have an advantage in the duration of operation, restoration of the movement, and reduced wound problems. One group believes that if the fibula is intact, it leads to delay union or tibia because fibula is a long bone. Wherever fibula is fixed either by rush nail or by plating, and if fibula unites earlier, this leads to delay union or non-union of tibia fracture. Other group believes that the fibula fixation is not must or should be fixed at the time of fixation of the tibia fracture. So we got a good union in 19 cases out of 20. One led to delay union where the gap was persistent at both the sites and bone grafting was done ultimately to lead the union. Thank you.
How many percentage of the patient had a nerve injury?
Sir, during operative, we made sure that none of them had any nerve injuries, sir, on the operative field.
How do you predict that there is a no nerve injury during operation?
So post-op, if there are any clinical signs of foot drop or a loss of sensation or any complaints by the patient, so sir, we can make out that there are some nerve injuries, sir.
If there is a nerve injury, what will you do?
So if there is a nerve injury, sir, we'll wait for 3 months, sir. Then we till the after that, sir, we'll do ECV, EMG, and CV, sir, for the conduction, and then we'll carry the plan forward.
Okay. Thank you very much.
Thank you, sir.
Okay. Next is Dr. Abhishek Gupta. Kindly unmute yourself.
Hello everyone. Is my screen visible to everyone?
No, we can only
Is
see
it
the
now?
Webex screen. Okay, now it's visible. Can you just change the slides? 2-3 slides?
Yeah.
Okay. So
Yeah. So
start.
can I start now? Yeah. Myself, Dr. Abhishek Gupta, second year DM cardiology resident from SBKS Medical College. So my topic is to assess the correlation between the prognostic nutrition index and short-term clinical outcome in patients with acute heart failure. Heart failure represents a globally challenging challenge affecting over 26 million people worldwide with substantial implications for mortality, morbidity, and healthcare cost. It is characterized by failure of the heart to meet systemic circulation needs, either due to impaired ventricular filling or reduced ejection of the blood. Acute heart failure, a severe and a sudden onset or worsening of heart failure symptoms, demands urgent medical intervention and remains a leading cause for hospital admission globally. The prognostic nutritional index, a composite marker derived from serum albumin levels and lymphocyte count, has emerged as a valuable tool in assessing nutritional and inflammatory status in various clinical conditions. While its prognostic value has been extensively studied in chronic illnesses such as cancer and chronic heart failure, limited data exists on its utility in acute settings like acute heart failure. This study investigates the relationship between the PNI and short-term clinical outcomes in patients with acute heart failure, aiming to provide insights into its role as a potential predictor of mortality and recovery. By integrating nutritional and inflammatory markers, PNI offers a simple yet comprehensive method to stratify risk and guide clinical decision making the management of acute heart failure. The aim of the study was to assess the correlation between the prognostic nutritional index and short-term clinical outcome in patients with acute heart failure. The study design is a prospective observation study conducted over 24 months in Department of Cardiology, SBKS Medical Institute in Vadodara. Sample size was 70 patients hospitalized with acute heart failure, which inclusion criteria had patients more than 18 years of presenting with acute heart failure, new onset or acute worsening of chronic heart failure, and the patients excluded were with severe liver cirrhosis, thyrotoxicosis, severe anemia, pregnancy, and end-stage renal disease and sepsis. The PNI formula was 10 into serum albumin plus 0.005 into total lymphocyte count. Patients' PNI level were measured on admission and correlated with outcomes in terms of mortality, including in hospital within 28 days. Data analyzed using the software IBM SPS version 23 and the p-value less than 0.05 was considered significant. Baseline characteristics of the patients were age varied in 55.47 to 11.05 and 57 were male and female were 13. BNP varied in the range of 13,422.3 to plus minus 5724 and the PNI varied in the range of 46.1 to plus minus 6.4. Out of the 70 patients, 3 expired and 67 survived. The anti-proBNP in the expired patient range from 15,400 plus minus 2523 and in the survived it ranged from 13,333 to plus minus 5820 and the PNI in the expired it ranged from 42.9 to plus minus 1.8 and in the survived patients it ranged from 46.3 to plus minus 6.4 with a p-value of 0.046 which is significant. And the PNI which showed that the PNI is inversely correlated with anti-proBNP levels which highlights its utility as a surrogate marker for disease severity. The finding of this study reinforces the prognostic significance of the prognostic nutritional index in acute heart failure patients by analyzing PNI, a composite marker of nutritional and inflammatory status. This study provides evidence of its potential to predict short-term outcomes, including mortality. The ROC analysis demonstrated that the PNI threshold of less than 45.04 offers excellent sensitivity in predicting mortality. However, its moderate specificity suggests that while the low PNI effectively identifies high-risk patients, further stratification using additional clinical parameters may be necessary to enhance the accuracy. The interplay between the malnutrition and acute heart failure progression is multifactorial, including inflammation, gut malabsorption, metabolic dearrangements creates a vicious cycle that exacerbates the cardiac dysfunction. Nutrition support guided by tools like PNA can play a pivotal role in breaking this cycle, improving clinical outcomes. Early identification of at-risk patients enables timely interventions such as dietary optimization, anti-inflammatory therapies, which can mitigate the adverse effects of malnutrition on cardiac health. Conclusion is PNA is a simple yet effective tool for predicting the short-term clinical outcomes in acute heart failure patients. Lower PNA scores were significantly associated with increased mortality, prolonged hospital stays, and a higher NYHA class at follow-up. These findings support incorporating PNA into routine risk assessment for acute heart failure patients to guide timely nutritional and therapeutic interventions. Thank you.
Okay. Which are the biological markers of chronic heart failure?
So first of all, biological markers will be, we can use BNP and as well as NT-proBNP.
Any other?
But we use for this NT-proBNP because it doesn't depend upon the.
I am asking the list. I am asking the list the biomarkers of chronic heart failure.
Sir, biomarkers, it will be, first of all, it will be NT-proBNP followed by, there can be BNP and there can be cardiac troponins also. And there is also, sir, galectin-3 and CRPs and copeptin can also be used. But generally, these are not used, sir.
Okay. Thank you very much. Well done.
Okay. Thank you, sir.
Thank you, Dr. Krutarth. Dr. Krutarth, am I audible? Dr. Krutarth, am I audible to you? We can't hear you. Have you joined from mobile? So you can click on the mic button. What shows when you click on the mic button? Okay, you can't unmute yourself. Okay, I'm making you presenter again. Try once again. Try once again.
Hello, am I audible?
Yes, you are audible now.
Oh, okay, thank you. Is it visible, ma'am?
Yes, it is visible. It's if you can do landscape orientation of your phone,
Yes, ma'am.
change the orientation of the screen to landscape.
Yes, ma'am. I have already done it, ma'am.
It's not showing. You
I'm
can
looking
stop
at it.
sharing the screen and again reshare.
Okay. Is it visible, ma'am?
No, not yet. I think internet connectivity is bit low from your side. We can see
Visible
this.
now, ma'am?
Yeah, we can see the screen, but it is very hazy, blurry. It's not sharp. Can you change the slides
Yes,
so that
ma'am.
we can got to know?
Is it changing, ma'am?
No, it's not changing.
Now?
No, it's just the title style.
Is it visible now?
No, it's just the title slide which I can see. Again, it's very hazy, blurry, and it's not changing.
Okay. I'm connecting the Wi-Fi network. One minute.
If possible, you can change the device or you can go into a good connectivity zone. By that time, I can take the next participant, Dr. Vatsal. If you are ready, please raise your hand. Okay, Dr. Krutarth,
Yes, ma'am.
you can take your time for 5 minutes. By the time
Okay,
Dr.
ma'am.
Vatsal will complete the presentation, also Dr. Anmol is also on the queue. Okay.
Okay, ma'am.
Okay, Dr. Vatsal, I have made you presenter.
Hello,
Start
am I
showing
audible?
this. Yes.
Just a minute. Is my screen visible?
No, not yet. Dr. Anmol, you be ready next. If you are ready, please raise your hand. After Dr. Vatsal's presentation, you will be presenting your presentation.
Is it visible now?
No.
Visible now, ma'am?
Yes, it is visible. Can you just change the slides to 3 so that I can get to know?
Is it changing?
Yeah, it is changing.
Okay, ma'am. Can I start?
Yes.
Hello, myself, Dr. Vatsal Gupta. I have a presentation on custom prosthetic reconstruction of uh, proximal tibial giant cell tumors. Introduction. Giant cell tumor represents 3 to 4% of all primary tumors of bone. Distal femur and proximal tibia are the most common sites, followed by distal radius. Ideal aim in management of giant cell tumor is to eradicate the tumor without sacrificing the joint. Current treatment modalities include meticulous curettage with extension of tumors, removal using high-speed bursts, and adjuvant local therapy. However, there is a recurrence rate of around 60%. Wide resection should be the treatment of choice, especially for situations such as recurrences, pathological fractures, and tumors which are frankly malignant. En bloc resection of major joint creates a problem for reconstruction of large defects. Recent advances in tumor resection defects involve the use of custom-built joints for replacement of defects near the knee. Our aim in this here we present a case of 29-year-old female diagnosed with uh, right-sided proximal tibia giant cell tumor, managed with extensive curettage and custom megaprosthesis arthroplasty. Method. Our patient presented to outpatient OPD with chief complaints of swelling around the right knee since 7 months. Swelling was insidious in onset and gradually progressive. Patient was experiencing pain in the swelling since 1 month, which was insidious in onset, progressive, throbbing in character, and radiating towards the right leg. Moderate in intensity, aggravated on bearing weight on the affected limb. There was no history of trauma to the affected knee. This is the X-ray of the right knee joint in AP and lateral view, which showed an osteolytic lesion in epiphysis and metaphysis extending in the subchondral bone of proximal tibia. We did an incisional biopsy which revealed giant cell tumor. MRI image was done, which to get an accurate tumor delineation, which showed cortical destruction and extraosseous extent of the tumor with involvement of joint space without involvement of any neurovascular structures around the knee. Uh, Tumor was in stage 3 according to Anakin system for benign tumors. Patient was screened for metastasis with computer tomography of brain and chest, ultrasonography of abdomen and pelvis, but there was no obvious evidence of any secondaries. After getting the anesthetist fitness, patient was posted for white excision of the tumor and custom megaprosthetic arthroplasty. Extended medial parapatellar approach encircling the biopsy site with the hinged custom megaprosthesis was used. The custom megaprosthesis contains a femoral condylar component, a pivot pin, a thrust-bearing pad made of high molecular weight polyethylene and tibial component. Proximally, the prosthesis is angulated laterally by 6 degrees to resemble the valgus angle of the lower limb. Measurement, radiography, and MRI was used to estimate the size of the prosthesis to be used. Resection of tumor-bearing part and a medial gastrocnemius rotation flap was done. Extensor mechanism was repaired by direct suturing of patellar
Conclude.
tendon to the uh, okay. Uh, Conclusion. In cases of giant cell tumor, the management depends on various factors such as site, age, involvement of bone, extent of bone involvement, and whether there is articular involvement or not. If tumor is involving more soft tissue with involvement of neurovascular structure, then limb salvage surgery will not be possible. If there is intra-articular extension, then the main aim of management should be eradication of tumor without sacrificing the joint function by using the technique of custom prosthetic reconstruction in proximal tibial giant cell tumor. With intra-articular extension, we have achieved satisfactory oncological and functional outcomes in our patient. Thank you.
So what complication you find in your case?
Sir, there was no intraoperative complication in the patient, and there was no nerve damage post-operatively. Huh, sir? Post-operative, there was no complication in the patient, and patient was able to walk with support on post-operative day 2. There was no nerve damage post-operatively.
What is rehabilitation?
Rehabilitation is the uh, strengthening of muscles which were damaged during the surgery, like quadricep exercises was done, and patient was allowed to walk on third post-operative day, and sutures were removed on day 15th of the surgery.
Well, thank you.
Thank you, sir.
Okay, thank you. Dr. Anmol Katkani, please raise your hand. Okay, I'm making you presenter. You can now share the screen.
Am I audible? Yes, ma'am. Is my screen visible, ma'am?
Not yet.
Is my screen visible, ma'am, now?
Yes, the screen is visible, but still it is very blurry. It's very blurry.
Now, ma'am?
It is visible. Okay.
Should I continue, ma'am?
Just a minute. Yeah, you can start.
So my topic of paper present is biological reconstruction of the knee joint by pedicled patellar transplant in a giant cell tumor of proximal tibia. Introduction. Tumors. These are benign, locally aggressive tumor of unknown origin. The most common sites are seen in epiphyses of the long bones, the distal femur, the proximal tibia, iliac wing, and rarely tarsal bones, that is the small bones of hands and foot. The most common age of presentation is 30 to 50 years. My aim is to assess the functional and clinical outcome of biological reconstruction of the knee by pedicled patellar transplant in a case of giant cell tumor of proximal tibia in an option to replacement. So this is the case report. History of the female is 20-year-old female presented to us with a swelling over the right knee, gradually increasing in size since 6 months, pain and inability to bear weight on the limb since 3 months. We have done the X-ray radiographs, which reveals a large expansile well-marginated soft tissue lesions eccentrically involving the medial tibial plateau. The lesion is measuring size of 44 into 51 into 46 mm. On clinical examination, the skin shows shiny and engorged veins, swelling over on examination. Swelling is hard and firm with diffusely present over right upper tibia. There is tenderness over right proximal tibia, and knee arm is completely restricted. Then, what are the treatment options available? We can do excision in curettage with bone grafting. We can do knee replacement, but since it is a young patient, we cannot do knee replacement. We can do en-bloc excision followed by mega processes or pedicle patellar transplant with bone grafting, which is the de-Aubergine procedure. De-Aubergine first describes the procedure of biological reconstruction of knee joint with vascularized patellar transplant. This is the radiology showing the right knee lytic lesions with expansile lesion and well circumcised with narrow zone of transition. This is the MRI, axial and coronal images showing the lesion. This is the intra-OT and post-op photos, immediate post-op photos, and this is the tumor which we have removed, en-bloc excision of the tumor. This shows the 6 months follow-up of the patient. So basically what we have done, we have taken the patella and we have taken the articular surface of the patella as towards the femoral condyle, which makes this movement to come and maintain the extensor mechanism of the patella. And we have taken the grafts from the fibula from same side and iliac crest grafts. So my year-old female patient, lytic lesion treated with pedicle patellar transplant with bone grafting from ipsilateral iliac crest and fibula strut graft with G1 placement. So knee range of motion is fully achieved in the patient. Full weight bearing walking started after 1 month. Native knee is preserved as we have not put any other processes or such like that, and it is a cost-effective procedure. So clinical message is a giant cell tumor is a common benign tumor in mature skeletal. The joint can be salvaged biologically by retaining the joint function in selected cases as demonstrated in this report.
The only disadvantage is that this procedure takes a long period of immobilization, but the end result is very much satisfying to both patient and the treating surgeon, as it is very much cost effective.
Okay, so do you find any complication later on?
Sorry, sir?
How many months you have follow-up on the case?
Sir, we have taken 1 month follow-up and 6 months follow-up. After 6 months follow-up, patient has full knee range of motion without any pain or such that thing.
Is there such case methodology described in literature?
Yes, sir. There is one paper, research paper, research paper for Patela for this procedure.
Okay, very good. Excellent then. Thank you.
Yeah, thank you, sir.
Okay, now we are coming to an end of the oral paper presentation. The last presentation, Dr. Krutar. If anyone is left for oral presentation, please let me know in my chat box. I'm not talking about any poster presentation. I'm talking about oral paper presentation. If anyone is left with oral paper presentation, let me know in the chat box. Yes, Dr. Krutar. Yes, I have made you presenter. You can start presenting the screen.
Is it visible? Am I audible, ma'am?
Yes, you're audible. You have started something sharing, but we cannot exactly see what you have found. Okay, now we can see this title.
Yes, ma'am. Should I start now?
Yes, you can start.
Okay, so I am a medicine veterinary doctor from MKC Medical College. My topic is a study of CNS manifestation of 30 HIV positive patients. So India is the third largest HIV epidemic in the world, which is 2.1 million people living with HIV. India's epidemic is concentrated among the key affected population, including sex workers and men who have sex with men. Despite free antiretroviral treatment being available, uptake remains slow as many people face difficulty in accessing clinics. So, various CNS manifestations. Complication of the nervous system can occur in more than 40% of the patient with HIV. In 10 to 20% of the cases, neurological manifestations are the presenting sign and symptoms of the AIDS. The neurological problem that occurs in HIV-infected individual may be either primary to the pathological process of HIV infection itself or secondary to the opportunistic infection or neoplasm. Among the more frequent opportunistic diseases that involve the CNS are toxoplasmosis, cryptococcosis, progressive multifocal leukoencephalopathy, and primary CNS lymphomas. Conditions primary to HIV. Aseptic meningitis, HIV-associated neurocognitive disorders, including HIV encephalopathy, AIDS dementia complex, myelopathy, peripheral neuropathy involving acute inflammatory demyelinating polyneuropathy, that is GBS, chronic inflammatory demyelinating polyneuropathy, mononeuritis multiplex, distal symmetrical polyneuropathy, or myopathy. Conditions secondary to HIV or those related to the treatment include mainly opportunistic infection and neoplasm. In opportunistic infection, main infection will be toxoplasmosis, cryptococcosis, progressive multifocal leukoencephalopathy, cytomegalovirus, syphilis, mycobacterium tuberculosis, HTLV infection, amoebiasis, and neoplasm mainly primary CNS lymphoma and Kaposi sarcoma. So aims and objective. So to study clinical profile of HIV positive patient with neurological manifestation, to know value of various investigation in diagnosis of various neurological manifestation of HIV infection, and to correlate various CD4 levels with various opportunistic infection, and to know change in their value with ART. So microbiology. So I have done cross-section observation studies. My sample size is 30, and I have taken sample from my college itself for 1 year of duration. This graph mainly age distribution, mainly younger individual between the 21 and 40 are involved. Mainly males are more involved than females. Neurological illness in my study mostly most common is tuberculosis, followed by toxoplasmosis, AIDS-related dementia complex, cryptococcal meningitis, progressive multifocal leukoencephalopathy, and primary CNS lymphoma. Presenting symptoms. In most of the feature, most common feature is the fever, altered sensorium, headache, convulsion, vomiting, focal neurological deficit, and with sphincter disturbance and bowel bladder involvement. Some patients also involved with the cranial involvement like 6th nerve palsy, 7th nerve palsy, and signs of meningeal irritation are also present. In patients with HIV with tuberculous meningoencephalitis, mainly patient present with signs of meningeal irritation and altered sensorium, associated with fever, headache, and convulsion. Total 12 patients were present with these features. The patient present with cryptococcal meningitis, they also present with sign of meningeal irritation, altered sensorium, fever, headache, and convulsion. 4 patients were present with these features. In toxoplasmosis, patient present with fever, headache, mostly similar features. This graph shows CD4 count and their importance in infection correlation. So mostly below the 2000 count, mostly tuberculosis is there. There is cryptococcal and toxoplasmosis there, and in CD4 count less than 100, there will be primary CNS lymphoma and PML. So this study also, this graph also is showing the same things. In CSF pictures, in tubercular meningitis, mainly protein will be raised, cell will be lesser than bacterial meningitis, and it will be mainly lymphocytic predominant. While in cryptococcal meningitis, similar finding will be there. Conclusion is if a patient present with a patient of HIV present with fever, altered sensorium, headache, seizure, or focal neurological deficit with signs of meningeal irritation with CD4 count approx 120 to 150, then there is a high suspicion of a central nervous system or peripheral nervous system involvement due to HIV infection itself or due to opportunistic infection should be suspected. Thank you.
How did you manage your cases of CNS presentation?
Sir, first of all, we by radiological investigation examination, if in CSF picture it is if it is cell pleocytosis with more number of neutrophils are there, we can think about bacterial infection. If protein is predominant with lymphocytic predominance, we can predict tuberculosis.
Name the drugs which can be given intrathecally.
Intrathecally. When we can give vancomycin intrathecally, sir, and in cryptococcal, we can give ganciclovir intrathecally, sir.
Okay, any more? Corticosteroids?
Yes.
Any AKT?
Yes, sir.
Which AKT can be given intrathecally?
Streptomycin, sir.
Okay, you can leave it.
Thank you.
Okay, Dr. Margi and Dr. Ajay has found absent. Dr. Sanket, I think, has presenting poster. Kindly please verify with me in person. So thank you so much, sir. We have come to the conclusion. Okay, so thank you so much all the delegates for joining today's event, webinar conference on good clinical laboratory practice. I hope you all have enjoyed the insightful sessions of today's full day event, and I hope you also had a great time of listening with juggling with the medical duties, your emergency duties. A quick announcement for those who have presented posters, all are accepted, and those who were absent today for poster presenters will be marked absent. So your attendance was kept in a note. Second, all the oral and poster winners will be declared in a day or two. So stay in respective groups. So we will announce the winner's name in a day or two after taking consideration from our organizing team. And also about certificates, I know everybody will be very much eager and enthusiastic about the certificates. We will also update about how you will get the certificate. Don't worry, we will keep it in easiest way so that you can get the certificate either at your home or you can collect it from the institute or the address given. So here we come to the conclusion. We thank all of you to be here. We will also share a form which will have details of your name, your address, today's feedback, and also how do you want your certificate to be, whether you want it to be courier or delivered at your home, or you want it to collect from the institute. So please stay connected in the group so that we update you and you get the notifications all on time and you follow that. Till the time you have followed all the instructions and you have cooperated so nicely with us that I am really grateful and delighted to host you all today for this event. So I'm happy and I rest my today's event hosting now. Thank you so much for being with me. Thank you so much. Thank you, Dr. Mamta, for this appreciating words. Hope we continue to commit the similar kind of events in future as well. And hope you all can join again in the future as well.